See if we can. I'll try and do it from here. Colleagues, good morning. Dumelang. Welcome. And I'm so glad today that you are all COFCs. If you don't know what a COFC is, you will, I think, get indoctrinated to become a COFC from now. So the community of the University of the Free State, we call ourselves the COFCs. So that's why I'm referring to you, I think, as COFCs. I really want us to, I think, get settled so that we should start. We should start, I think, for a number of reasons, that the program is too packed, and we need to do justice, I think, to the program in terms of, getting, I think, exchange of new knowledges, but also I think, we need to have good critical discussions around the new knowledges. So we do not want to sort of cut short on that. But also I think, while I do this, there are a few things that maybe we need to highlight to you. Some people are still, I think, on the way coming here, but also some people are joining virtually. So they may not be here, but a lot of other speakers, both, I think, local and international, will be joining, I think, virtually. So we're going to have this hybrid, type of, I think, discussions. And I'm told that, with our good IT, that everything is sorted. When you present, you may not see, I think, the people, I think, virtually, but they can see us. So we'll still, I think, be able to interact with them. Now, in terms of the program, there might be, I think, some little, I think, changes here and there. So I think let's play, I think, by the ear, where such a change has, I think, occurred. We will let you know. We know that there were people that were in the program. They have been, I think, asked some people to stand in for them. It's a difficult time now because it's more exam time, it's more meeting times. So we are trying to juggle, between I think those times. There are people also would call in. You may not have seen them in the program, but I think they were in the program. So let's see how things go. And then I think from here on, we will need to then begin, I think, with, I think, the formalities instead of, us looking at, I think, the beautiful stands outside, but let's all come in and then we do the formal, I think, opening. Those that have programs, I think, with them, you'll see that we should have started about 30 minutes ago. And I want us not to be notorious, to being, I think, the late, starters. So I think let's sit down, let's settle. And then I'll introduce myself. My name is Mutlalipula Matsabisa. I'm in pharmacology. I will be, I think, part of you. I will talk maybe until you get tired of my voice, but you are here with me. You can't go anywhere. We'll close the gates at the securities. Yeah. So, but I'm really also, I think, surrounded by my senior, I think, management that will actually welcome you. I'm a very small boy, I think, in the institution. So if you were to look at the universe, with a big eye. And you see all, I think, the galaxies and things like that, and you try and find me, you'll realize that you can't find me because I'm very small. But if you then hone in, eventually you will find me. So colleagues, without wasting time, I want to, I think, introduce, I just need to have a program before I make mistakes. Who has got a program? Or else, this is one that if we see the do you have a printed program for me? Just wait for this. Thank you so much. Okay. Oh, here it is. Thank you. Thank you so much, Mandy, for that. So we, as I said, without wasting much time, I think we have our senior director for research in the university. He oversees the research that everybody does. He supports everybody, including me. He supports everybody without fail. I'm not marketing him, but I'm talking about, an African by the name of Dr. Glenn James Taylor. He's going to be giving us, I think, the welcoming, I think, remarks. This is his territory. For today, I think we allow him to become the chief of the area, so he needs to welcome us. And then I think in absentia, or in terms of, I think, the Department of Science and Innovation, there may be, I think, a written maybe note from them. And then we would also then have, I think, Dr. Petule Mahasha from the Medical Research Council. He's here with us, also to say something in that order. And then I think, our sponsor, our funder, who's from the Technology Innovation Agency, Dr. Vuisile Pehani. He's the executive in the bioeconomy, and that's why we're here. And then he will then, I think, also come and I think give us some motivation and stimulus to work, in the next one and a half days. And then thereafter, I think, if you are all okay with that, I want to give you, I think, an overview in terms of, one, why are we having this Indaba, but more importantly, give a landscape in terms of what the University of the Free State, through the Department of Pharmacology, is working on in the fields of the pharmacology of traditional medicines, drug discovery, drug development, formulation, and manufacturing. So I will then do that, and then we can have, I think, a quick, tea break. And then when we come back from the tea breaks, there will then be those sort of sessions. And I must say that, this is a free flow type of, I think, session. We don't expect people to have, your standard academic PowerPoint presentations, but people can sit and talk, and we have the discussions. But if you do have a PowerPoint presentation, you are welcome, to share that, with us on the screen and also virtually. And I have been told that, I think, there are facilitators, I think, for the sessions, and those facilitators would then set up, I think, the theme, for that session. And then we can have the first session, which is really based on research, development, and commercialization. It's going to be, I think, headed by, luckily, I think, the executive of bioeconomy. He needs to know where his money is going. And then we will then followed up by other sessions, which I think we'll go through. And then we will have dinner tonight. I think, just be happy that I will pay for your dinner tonight, all of you. So just all be here, and then we can all go and have dinner and interact, network and find, I think, new partnerships. What is not allowed is finding new marriages. So what we will then, I think, do tomorrow is a half day, but I know that a lot of my colleagues from the technology, the innovation hub, they've been pushing and pushing to go and see what they want to see. That's going to happen tomorrow, okay? It's going to happen tomorrow. We don't have any preview of anything. So it will happen tomorrow. We'll go through 2 facilities that we boast ourselves with at the University of the Free State. One, it is FAMOS. FAMOS is the clinical trial facility. It's a state-of-the-art clinical trial. We can run from phase 1 up to phase 4 clinical trial. It's capable of also doing in-house, so that, you know, there are beds where you need to do a clinical trial, in fact, to have people admitted. That is actually available, so you'll be able to go and see those facilities. When I talk, I will be talking about the COVID clinical trial that we are actually running as the University of the Free State through them, and also the thinking of the post-COVID clinical trial on traditional medicines. So we do have, I think, that experience, you know, on the clinical trial. And then we will also then take you to our laboratories. We just finished building another state-of-the-art, you know, traditional medicines laboratory. It is an accredited GLP laboratory. So it's really one of, I think, you know, the kind that TIA invested in, and the University of the Free State through Dr. Glenn Taylor, you know, they have invested into that. So that's what I think you will be, I think, you know, seeing tomorrow. And then you wait until next year, then we'll tell you about the manufacturing facility. But without wasting time, can I then, I think, have, you know, Dr. Glenn Taylor, maybe to welcome us before we get too comfortable.
Thank you, Professor Matsabisa. One thing I can always state is that you always understate your importance in this institution, so thank you very much for that. So as he stated, my name is Glenn Taylor. I'm the Senior Director for Research here at the University of the Free State. And it's my pleasure this morning to welcome you, each and every one of you, to this Indigenous Knowledge and Bio-Trade Indaba. Special welcome to our partners, which is the DSI and TIA, in this 2-day workshop, especially Dr. Pehane and Dr. Mahasha, also from the MRC, members from industry, academia, both nationally and internationally. As you will see on the program, we have a number of co-workers and joint partnerships that we have established in the Indigenous knowledge systems in pharmacology over a number of years, and they will also be joining us. So welcome to those abroad. Also, I would like to welcome our traditional healers and community members. I would also like to welcome the HOD of pharmacology. She was here earlier on. She said she had unfortunately had to go, Professor Van Zyl, for another important meeting. And one thing I can say about the Department of Pharmacology is that, according to my records, one of the fastest growing departments, especially in the health sciences faculty. We attract on a yearly basis now, and I think it's largely to a very understated Professor Matsabisa over here, that we attract a huge amount of applications from scholars, both nationally and internationally. What's nice about when I report stuff like this to council and to the top management of the institution, is the fact is that we're always looking for areas where we need to invest for the future, grow, and Indigenous knowledges systems is definitely one of those areas that we've targeted specifically at this institution and invested in significantly to reposition the institution as a research-led university that's relevant for its communities and society. Then I think also what I need to mention is that I'm sure you will enjoy the new laboratories that you will be seeing that we've started to develop, and they're virtually near completion now for Professor Matsabisa and the new IKS unit. They are really state of the art, and we hope that this new laboratory that we've about to open will enhance this environment even further and grow the IKS environment significantly. Finally, I am sure that the diverse topics covered over the next 2 days you will find interesting and stimulating, and I hope you enjoy yourselves here at the University of the Free State. Thank you very much.
Thank you so much, Dr. Taylor, for that. Ndati Petole Mahasha, are you somewhere near us? Can we give you the platform, please? We're doing this because we want to be friends with the MRC. And when you are a friend with anyone, you know, there must be some mutually beneficial, you know, relationship. So, please, thank you.
Good morning, ladies and gentlemen. As you have heard, I am Dr. Petula Mahasha from the South African Medical Research Council. I am thankful and appreciate the opportunity to be here with all of you to represent my organization. And I'm seriously looking forward to the discussions that we will have here, all of us. I'm not here to welcome you. We've been welcomed already. So I wish you a very much wonderful day, which one hopes that by the end of it we will have something that will be beneficial to the IKS programs within the different institutions in the country, but within TIA and within the MRC as well, as we are running these programs with the DSI. So let's enjoy the discussions, and hopefully, Dr. Matsabisa, we were in one forum with Vuisil as well. My concern always is that people meet like this. The money of the people of South Africa is spent, discussions are had, and probably a couple of years from now, a similar kind of a meeting is held. But there isn't any sort of difference in relation to discussions from the previous time as to what then is the next step. So what I will put as a request is maybe there should be a report on the basis of the discussions, so that it should be a document of a point of departure going forward, to say when we meet, if it's a year from now or a couple of years from now, then we need to identify which gaps have been filled in between, to indicate that we are moving forward with what we keep engaging about. So I will appreciate if something like that can be put together, so that at least we can identify progress with what we are doing for the sake of South Africans. Thank you very much. Have a nice discussion.
Yeah, so thank you so much, Ndati Mahasha, for that. Colleagues, before I make a mistake, I also need to recognize Me Malifu Khamani from the Provincial Department of Health in the Free State, I think Bophelo House. Me Malifu heads the traditional medicines, section in the Department of Health. So I don't know, you want to say a word of thanks or anything, Me, quickly?
Good morning, ladies and gentlemen. I call him Tate. I know he's got all these nice titles, but because I'm a Mosotho girl, I call him Tate Matsabisa. So he accepts that. I actually don't have much to say. I just want to say to the doctor, and the professors and the learned people. I'm not so learned myself. I just want to say to you that I would love what UOFS is doing to fully be translated into us seeing more traditional healers represented here and seeing more traditional healers in your laboratories. That for me would be saying we are doing what we are supposed to be doing. Because I want to tell you the honest truth that Matshabisa knows very well the knowledge that is in South Africa of traditional medicine. I always tell the truth. I didn't vaccinate for COVID. I refused completely as a South African because I work with people who know how to deal with illnesses. And I've never had COVID. And I don't think I'm going to have COVID. So the researches that are being done, let's do more research on issues like that. Thank you.
Thank you so much, Relebo. Colleagues, and then last, I think, but not least, can I call Ndate Pehani to come? I've known Ndate Pehani, I think, as long as I was young, so we come a long way with him. Up until, he called me one day, he said, you know what, I'm joining TIA, I need to talk to you about traditional medicine. Then I said, I know nothing about traditional medicines. I can't diagnose, I can't treat, I can't do anything, but I can talk to you about research. So he said, you are the right person. Thank you so much, Ndate.
Good morning to all dignitaries, delegates, distinguished guests of the University of the Free State, the various players within our national system of innovation, indigenous knowledge holders, researchers, and innovators, ladies and gentlemen. I'd like to acknowledge the DVC, Institutional Change, Strategic Partnerships, Societal Impact, Dr. Molapo Qobela, Dr. Glenn Taylor, Senior Director Research, Professor Motlalipula Matshabisa, Director, African Medicines Innovations and Technology Development, as well as many other accolades, the officials of the Department of Science and Innovation, the board, executives, and staff of the Technology Innovation Agency who are here with us today. It is my honor to deliver a message of support to this Indigenous Knowledge and Bio-Trade Indaba at the University of the Free State. This meeting comes at a time when there's recognition in the country that the elevation of the profile of indigenous knowledge systems can no longer be delayed. We acknowledge the rich, largely untapped source of knowledge within our communities, yet to be fully exploited for economic and social benefit of particularly the underserved regions of our country. South Africa's Department of Science and Innovation has kept abreast with the global developments in putting into place policy to ensure the coordination of human resources, infrastructure, and funding sources to support research, development, and innovation. The bioeconomy strategy of the country recognizes the gains made by the country in research, development, and innovation, and guides how such gains can be exploited. The Decadal Plan for Science, Technology, and Innovation is an implementation plan of the 2019 White Paper on Science, Technology, and Innovation, and emphasizes several system goals, namely creating an enabling environment for innovation, future-proofing our country's human capabilities, transforming the research system, building a more inclusive and coordinated national system of innovation, and finding ways to increase funding and making that process more efficient. Sectoral supports, priorities in agriculture, manufacturing, health innovations, and allied, which is why we're here, cannot be overlooked, and neither can the various master plans created to support industrial sectors in our country. This thought leadership by the department has a direct bearing on what we are doing here today, engaging in dialogue to shape our future and to seek ways to collaborate and build strong, long-lasting partnerships in the space of IKS. These partnerships not only serve us in the country, but also the African continent, as we look beyond our borders to facilitate initiatives such as the African Continental Free Trade Area Agreement, the initiatives of the African Union concerning development and self-sufficiency by Africa in creating its own health and food security interventions. The Technology Innovation Agency, we are an implementing agency of the Department of Science and Innovation. We provide financial and non-financial support for innovations in various sectors of the economy. Through supporting innovation and development and protection of local intellectual property, we are convinced that South Africa can transform from a resource-based economy to a knowledge economy. Accordingly, discouraging the misappropriation of intellectual property is central to economic development, and such misappropriation should be arrested here as it is anywhere else in the world. The protection of intellectual property is also critical to the survival of people, as was aptly demonstrated during the worst of the COVID-19 pandemic, and now with the supply of basic grains for food security as we face the wrath of climate change and war. We occupy an unrivaled space in the national system of innovation, which is to seek and invest in innovations to de-risk them for follow-on funders by other government departments and the private sector, such as venture capital and private equity. In so doing, not only are we playing the role of funder, but also connector and facilitator to change the appalling narrative of venture capital investment on the African continent. TIA has played the role of industry builder and has sought to increase its efforts to grow and enhance the role of indigenous knowledge systems in inclusive development and transformation. The successful commercialization of all indigenous knowledge-based projects which involve the use of indigenous plants requires the capacity to cultivate these plants, which we're engaged in. We have funded the African Medicines Innovations and Technology Development Platform at the University of the Free State to ensure that the products of promising indigenous knowledge innovations are safe, effective, and constantly of high quality. This platform, as you will hear later, seeks to address generations of market failure in bringing indigenous knowledge into the mainstream of commercialization and truly equitable benefit sharing. Going forward, 20% of our medium-term expenditure framework allocation will be channeled towards IK initiatives, which is a significant move. This is testament to our commitment as TIA to IKS. In doing our work, we are called to recognize the role of women in all economic development and social cohesion activities, and to unapologetically support women in all facets of innovation. It is my hope that the next 2 days will identify areas of collaboration and new opportunities for investment. We owe it to future generations to make it possible to explore new avenues for wealth creation, lest we be asked what we did with the resources we were given, the power we yielded, the leadership positions we occupied, the policies we developed, and the laws we created. I wish you all a successful 2 days, and I look forward to participating in the creation of a prosperous African continent. Thank you very much.
Thank you so much, Dr. Pehani, for that speech. Colleagues, maybe Dr. Pehani, Dr. Hobololo, and Dr. Taylor, a small request that I want to make. I've just realized and seen that the Director of Traditional Medicines at the National Department of Health in Pretoria is here. Maybe I could ask Ndatimbezi, just to come and say hello to the group. Yeah, okay. Where's Indaba here? This one. It's that one. It's that one. Yeah.
Thank you very much, Prof. Matsabisa, for this opportunity. I have traveled several times, a lot, but I've never been hijacked like this. So it was quite a shock for me to be called to come here, but I think I appreciate the gesture. My name is Bruce Mbezi. I'm from the National Department of Health. I am responsible for traditional medicine within the National Department of Health. Our work is quite enormous because you are quite aware that this terrain has never been regulated before. So we're trying to come up with legislations, policies to try and regulate, not actually regulate, but the bigger picture is to include traditional medicine into the national health systems. Because you are quite aware that traditional medicine is being practiced, but it is at the periphery of the national health systems. So what we're trying to do is to develop legislations and policies that will allow this practice to be included in the national health systems. By so saying, I'm talking about the 3 pillars of traditional medicines, which are the products, the practice, and the practitioners. So we're developing legislations to include all those pillars. Products, actually, you know that legislations and guidelines are supposed to be developed by SAPRA, which is responsible for all medicines in South Africa. So they are also going to develop tools for products derived from traditional medicines to be registered and available in the market. One will be asking a question of how is that going to be possible? The only medicines that are going to be channeled to SAPRA are those medicines that are going to be commercialized, because you are aware that Gogo Matsabisa sitting in the border of Lesotho, practicing with her herbs that she planted around. It's not going to be possible for her or for SAPRA to be in control of what she is dispensing to her patients. So only those that are going to be commercialized will be channeled to SAPRA. And then those that are dispensed extemporaneously by THPs will be regulated by our Traditional Health Practitioners Act. In terms of that act, we're supposed to establish a council which has already been established, and the registrar has already been appointed, who's supposed to develop, that council is supposed to develop tools that will enable us to regulate practitioners and their practice. So what happens in Gogo Matsabisa there will fall under these legislations that I'm talking about. Without much wasting of time, I think I gave you a picture of what we're trying to do at the National Department. And thank you very much, Prof. Thank you, sir. Thank you.
Thank you so much, Ndadimbezi. I think it was not hijacking. It was just for me to do the right thing. But also I think, I need to also to acknowledge, because everybody keeps talking about SAPRA, that in fact we are represented here. There are 2 people from SAPRA with us, one from medicine regulation, and also the other one is actually from the regulatory affairs, especially around the issue of cannabis. So at least we are fortunate that we can get those inputs from I think, the colleagues in SAPRA. I saw that Ndate Makuba is sitting right up there from SAPRA, and then there is also, I think, Mayor Fafudi. She is going to be getting in here at around, I think, 10 o'clock. She has just left, Pretoria. So at least we'll have, SAPRA as our partner that would also begin to guide our discussions in terms of how we move forward in the regulations, of traditional medicine. So, colleagues, because I'm never always so fortunate to get introduced, I always find myself, having to tell a story about myself. Nobody even comes and say, this is who I am. So I want to introduce myself so that I can give you a talk, in the next 20 minutes or so about traditional medicines. Sometimes I stand up here and I say, I wonder what I would say if I were to win a prize. Because I've never won a prize, so I don't even know how to thank anybody. So most probably I can start off by saying I really want to thank my 2 legs that keep me standing, and I want to thank my 2 arms that hold me tight. That's what I could say, because I don't know how to thank anything. So, colleagues, what I want to do today, I don't know if my screen will show, is really to take you through a journey in what we do as the University of the Free State in terms of the research. I know that some of, I think, my doctors are here. They will go into, I think, the details of that. But I just want to give you a quick overview and link up to what Dr. Pehane was saying, to say, where do we go, I think, with traditional medicines? Are we going to, I liken, I think, the work we do on traditional medicines, I think, with animal life. And I know that I've got my colleague there from, far away in KZN. He will understand that when you are at the bottom of, I think, the food chain, you then produce a lot of babies, lots of offspring, so that you counteract that, because you know that your children will be eaten any time, so you produce a lot. But producing that lot has actually no value to you. Now, in traditional medicine, we always talk about, Africa having the resources, Africa having, all these things. But the big question is, what do we do about those? Do we just allow, the Lion King to come and, eat and take whatever, we are producing, whatever we say, those are our resources, and then they disappear and we start from scratch? Or do we want to take, I think, a decisive step and say, this is what we want to do in terms of our natural resources? Dr. Pehane talked about moving away from this resource-based thinking. We have the resources. We have all that. I would wonder what my mother or my father would have said, because if they had 12 children, whether we brought any value to them, okay? I don't know. I really don't know. Or me, with my 3 boys, would I then come up and say, at least, they brought any value to them? So I started moving away from resource-based thinking of having 20 children, because I don't see what value there is there. Okay? So the same thing, you are happy at home when you have 200 cows. That becomes just a liability to you, because you feed them and you are not getting anything out of them. So you are just happy to wake up in the morning and say, I have 200 cows, and then afterwards you get into your truck to go and find food for them. I think we need to change that, and see how best we want to do that. So I stand here, I think, as a pharmacologist, and I have a very special interest in the pharmacology of traditional medicines. How then do we develop new drugs and new medicines based on, the knowledge that we have? So we do this because one thing that I think, we were always striving is to ensure that we do not compromise on good science. That's what we need to be doing. And if we want not to compromise on good science on traditional medicines, then that means one of the passions is to take the science of African traditional medicines and put it up into the global stage, and people begin to respect it. I had a number of, I think, students, I think in my lifetime. Some came from the US, some came from Germany, but I remember, this particular student from Freie University in Germany that I was co-supervising. So she came and spent time with us. And then she then said to me, Prof, one of my objectives is to go and spend time in a rural area with a traditional healer. And fortunately, I think, I always have some traditional healers as my students. Even now, I have some traditional healers as my students. I had a traditional healer in my group. So I say to this young German lady, here's a traditional healer. Now, the way she looked at me was to say, no, this is not what I'm expecting. Because what she was expecting, to cut the story short, she was expecting someone who was scary, someone who had beads, someone who had all these other things. And to her, that defines what a traditional healer is. So she did not expect someone with a cell phone to be a traditional healer. And to me, that's really the mentality that we need to change. Dr. Taylor, when I was doing my PhD, I was fortunate to get a South Africa British fellowship. So I spent time at SmithKline Beecham. So when they were developing up a whole lot of the products, I was there. And I recall they asked me to go and give a talk. And when I stood up like I stood up here, it was in Harlow in the UK, and Datepehani. Somebody stood up and said, sorry, Matalipula, how then do you study for your PhD using a candle and a lion roaring on your stoop? And then my thinking was, is that what people think of Africa? Is that why they say Africa is a dark continent? I think it's up to us. Einstein said, some years ago that we live in a terrible world. And that terrible world is not being made bad by the bad people. It's actually been made bad by knowledgeable people that do nothing about it. That's what Einstein said. And he was right. So those that are fortunate like ourselves, we need to make sure that we do make an impact. So I'm bringing this because I want to talk about doing science for a reason, doing science for a purpose, not doing science for the sake of doing science. So with, I think, the group that I work with, even though they may not know, we have a little, I think, policy. It's an unwritten policy. A policy where we talk about GRIP, GRPPPP, which literally stands for getting research results into products, publications, public health, and commercialization. And we're saying, if your research cannot meet any one of those, and if your research cannot contribute to improving the quality of life of people, and if your research cannot then be moved into secondary economies and contribute to secondary economies, please don't do that research. Don't do it. Why do you do it? So, we are also part of the TIA African Medicines Innovations and Technology Development. We call ourselves, AMIT. They support, I think, us, bringing up, I think, new ideas, new innovations towards commercialization. So we do research for a purpose. And that's what really AMIT is doing. And some of the things that I will talk about, within, I think, that AMIT. So when you see the word AMIT, it's us within the Department of Pharmacology. But more importantly, to say we always try to be different. We always try to innovate and be different. That's what excites us. In some of the meetings, I talk and say, I don't want to be a me too, because someone is doing this, so let me also do the same. No. As a researcher, as a scientist, you always must stand up there and come up and have these good ideas and go and see if you can actually put those ideas in the lab. So let's look at the national priorities in one sentence. Let's look at how we address community research needs and aspirations. That's why we do what we are doing. We have to respond to those aspirations. But more importantly also, what are the industry questions that we need to respond to when you do the research? Because Africa cannot afford just to do research. And I need to walk slightly away from my director of research when I say this, just for publications. Because when you publish, you are giving others your information and you are doing nothing about it. But I think me and him, we agree that research needs to have a societal impact. That's the priority. That's what we need to be doing. So that, an ordinary person walking out there on the streets can say, I really am so happy about what the University of the Free State is doing because the research that they're doing is having a positive impact on my quality of life. And then I get happy too. So we'll talk about that. But also I think we need to be very practical. All the traditional health practitioners that come to us, we ask them, why do you want us to research your products? Then they say, no, we want them to be on the market. They want to make money. Let's be practical. Let's be real. We do responsive research. We do needs-driven research. And that research needs to address old diseases. You look at malaria, you look at sleeping sickness, but it also needs to address new and emerging diseases like your COVIDs, your pandemics. That's what we need to do. We failed dismally as a continent when COVID hit. We were found wanting because we never had a strategy to say, what is it that our research should be doing in such cases? I promise you tomorrow, if COVID could come again, we'll still be wanting. So I think that needs to change. So why are we working on traditional medicines? I'm not going to go through all these many things. I think for those that do not know, medicines from natural resources, medicines from plants, they treat 90% of all known human diseases. That's fact number one. It is true. But also if you look at drugs that have been derived from medicines, whether those are prescription medicines or what, they contribute to about 30% of all the available drugs. Whether you go to the hospital or one of the drugs they will give you there, one way or the other, 3 out of 10 will be a medicine from from plants or natural resources. I mean, I can mention a whole lot of them. You go and say you go and buy, your aspirin, Disprin. Disprin is a natural-based, salicylate. It comes from umngunube, the wild willow. Digoxin for your heart failure, from the digitalis. You look at, I think, metformin for your diabetes. It comes from a plant, and we still use it. Salbutamol, those that have asthma, the little pump. It has got a molecule there called theophylline. Theophylline comes from the theobroma tree. The list can go on and on and on. Cyclosporin for your heart transplants. Those that go into heart transplants, they get given cyclosporin. And that's a natural medicine. But what are we doing as Africans? Are we happy to buy these things back and have the credits coming from somewhere else, while we can actually focus ourselves and say, this is what we want to do? 10 out of 10 drugs that treat cancer are plant-based. Vincristine, vinblastine, Taxol, whatever you can call them, they all come from plants. So what are we doing? AZT, those that don't know, AZT for your HIV. Maybe they might not have told you at the time that AZT is a natural product. Maybe they didn't want you to know, so that then, because at this time you were slightly more smarter, you started talking about aspects of benefit sharing. So maybe that's why they didn't tell you. The other aspect that I think, I just need to raise is, I told you that medicines that come from plants, they treat 90% of human diseases. It's a fact. But also, during the pandemics, all those pandemics, the people that are our, in fact, ancestors now, they survived those pandemics because they used plants. So we need to thank them. Let's thank, I think, those, what we call them, pandemic doctors that used plants, because had they not done it, maybe we would not have been here. So that's the reason why. Now, let's go back to what Dr. Pehani was talking about, resource-based thinking. And start moving away and start talking about, let's now talk about a knowledge-based thinking. You look like a small country like Singapore. Singapore is a country, Singapore is a capital city, Singapore is everything of Singapore. Smaller than us. They are richer than us, simply because they don't think about the resources. They talk about knowledge. How then do you apply the knowledge that you have? So in Africa, we talk about knowledge, whether in the Depehan you talk about gold, whether you talk about platinum, whether you are talking about a resource, but what are we doing about that? We talk about plants. What are we doing about it? Everybody boasts and say, South Africa holds, I think, a third, of the biodiversity of plants. The world, I think, has about 350,000 species of plants. South Africa has about 30,000 species of plants indigenous here. So we hold 1/10 of that, of the whole world. What are we doing about it? So let's move away, and say, how then do we harness that resource with the knowledge? And that's what we are trying to do. We have a lot of traditional health practitioners, I think, in this country and in this continent that could actually play a very significant role in our healthcare system. But because we ourselves, in fact, do not have confidence in them, we don't even have confidence in what we are doing ourselves. And that's the problem with Africans. We don't believe them. If I come and give, sorry, Ndade Taylor, I always use you because you are next to me. Oh, okay, I'll use Ndade Vuisile here. If you were to come and say to Ndade Hobololo, this is my traditional medicine. Do you want, to try it? his first question will be, what is in there? What is it? What is in there? But if I were to go to my bag there now, okay, and open up my bag, I always have patkos, okay? I'm an old man. And say, Ndade Khobololo, can I give you this thing? You want it? Yeah. He says, okay. He takes it. Yeah. But then I say, Ndade Khobololo, what actually makes Coca-Cola? What is in Coca-Cola? Yeah. Nobody knows. So why do you ask me what is in traditional medicine? And you don't ask me what is in Coca-Cola? Because you still don't know what is in Coca-Cola. Okay. So, but we also have a very good political support, but that political support needs to be sustained. Okay? For us to move traditional medicines further, we should not be treated like orphans. Ndade Khobololo then says, oh, I did not spend, money that I was given to spend, so it is now the 24th of November, and I need to get rid of this money because I'm going to appear very bad in the books of treasury that I did not spend the money. Can you please come and take it? No, it's not good planning. Because we're just taking it to temporarily relieve a problem. But there's no long-term strategy to say, this is what we need to do. Japan is where it is because Japan took some stance some years ago and said, we're not going to be following this thing of publications and publish. So for 10 years, you never see any article from Japan. They were doing that because they were building on their own technologies. That's what they were doing. So with us, because we rely on donors, we rely on grants, and then we play according to their tune, we'll never move. No grant or aid from anywhere in the world has actually lifted any country out of poverty. No, nothing. If you have one, please come tell me. Not even a single country. You look at them, those that keep getting grants and aids, from everywhere, have actually got out of poverty. You can only get out of poverty if you help yourself. Ka Sesotho re re, moketa ho thuswa o itekang. Now I don't know how to translate that anyway. All you are saying, you help those that help themselves. You must help those that help themselves. I started my career at Groote Schuur Hospital. So when I left university, my first job was at Groote Schuur Hospital. And I was fortunate to have met my boss. Maybe I'm fortunate. I always get these good bosses. Dr. Creedland. Because I did my matric, so I left South Africa around 77, and then I went into Lesotho, so I did my matric, and I got this GCE. And he could relate to GCE because he was British. And then he said something to me that I will never forget, that, you know what, it's easier for us as donors to go and pump money to save penguins that are drowning because of a shipwreck than to save homeless people. And I said, why? I said, the problem is, after we clean that penguin and we put it back into the sea, it will not come back again and demand. It will then go and fend for itself. That's why we do what we're doing. Then I looked at it and said, we need to help ourselves. We need to get out of that ditch, and we help ourselves, and nobody's going to help us. So colleagues, So what then do we do? In briefly, I think, we look at the pharmacology of traditional medicines. We look at the relevance of these to communities. We look at grassroots, ideas. What are the people doing out there? And then the whole thing is to give it an international perspective. And then so, because I'm in a university, I must teach. And fortunately, I think, I don't teach undergraduates, so we teach, postgraduates, and we go forward. And then we'll talk about some of quickly the small, projects. So we add value to the science so that we make sense of it all. We try and make sense of this traditional medicine, whatever it is. So you'll find when you get into our unit, our laboratories, we do these grassroots. We have strong community projects. We'll talk about it, I think, in the afternoon. We do basic research. That's what we do. Aspects of quality control, but also we do R&D and formulation studies and the pilot production. But for us to do all that, then there must be the science to look at the safety, the efficacy of these things. And then we do safety and toxicology, and we look at the effectiveness. And most probably we begin also to understand how do the traditional medicines work. That's what we look at, I think, molecular pharmacology. And then we do method development because we work very strongly with industry. So we do method development. And I know, is it tomorrow or this afternoon, I see Dr. Reinhard McPherson is there from Famos. He will then, I think, talk to us about the clinical trials. So clinical trials gets done, I think, in partnership with Famos. So you'll go and see them tomorrow. One of the core competencies, because as a researcher or as a program, you must have a core partnerships. That's what we do. We need to do that. We don't work in isolation. So we look at traditional medicines, herbal medicines. We do medicinal cannabis. We'll talk about that, what we are doing on that. And we also do herbal teas. And all those, we look at preclinical work, how do they work? Are they safe? And then the R&D is to take this a step into what's, production, and then also your clinical research. And then in terms of the diseases, we specifically look at certain diseases, diabetes, we look at hypertension, we do cancer, we do heart disease, we've got projects on heart failure. We look at Alzheimer's disease together with, I think, our partners, I think, Beijing University of Chinese Medicine. So we collaborate also extensively. And then we look at pain and wound healing. We'll talk about that. And then also immunological studies, as well as looking at drug metabolism. I serve in the International League Against Epilepsy. And I think one of the things that they've been asking, me is, can we see how traditional medicines could be applied, I think, into epilepsy? And this also came out, I think, when I got a call from the Red Cross Children's Hospital in Cape Town, where they said, are there any herbal medicines, that could be used, for epilepsy in children? And I sometimes hesitate to answer, because I always say to my staff, even though traditional healers would come and say, we have these products, I'm like that Thomas, in the Bible. The Thomas who said, Jesus, if it is really you, let me see where they nailed you. Let me see those holes, okay? It's not that I don't believe what the healers are saying, but I need to convince myself through science. We need to do that. The second reason when we took our teas to Freshmark, I think Bester, you'll know, Freshmark is, I think, the fresh produce for Checkers, ShopRite, I think, and OK. And then when I walked in there, they said, you know what, we love these teas, we want to have them onto our shelves. Are they safe? And then I start mumbling and said, yeah, these are safe. They've been used in traditional medicines for a long time. They said, no, that's not what we are listening to. We are listening to safety studies that have been done to prove that these are safe, because we cannot have a reputational risk to put the products onto the market. And then tomorrow somebody says, I've got diarrhea because I've been drinking your product. It becomes a reputational risk to these companies. So I'm Thomas, not that I don't believe you, but I'm Thomas in the sense that I really need them to convince the skeptics that these things work. Okay, so we look at all those, I think, diseases, drug metabolism, drug interaction studies. We found it very useful, because the liver, it's really a key organ, that helps us break down and detoxify drugs. It has got little, I think, enzymes. They're called the cytochrome P450s. You can also find some of those in your stomach, but they're mainly in the liver. And they break down, I think, the drugs and the things that we eat before then they could go and work somewhere else. So if your liver is in trouble, you are most likely to develop multi-organ failure, because everything, I think, would then move down from your liver to your kidneys and everywhere else. So we do those studies. We do the training, postgraduate, we work with traditional healers that voluntarily come. So we never go and ask traditional healers what then do they do. They literally just come and say, we have this product. This is what I think we've been doing with it. Can you test it for us? And that's where the question comes, why do you want us to test it for you? And then they would say, we want to make it available, to the larger public. We have just come back from East London. We've been talking to one doctor, and many of his patients that have been, I think, traveling around, with problems of heart failure and heart, I think, problems. Some had pacemakers on. Some were told that, your heart muscles are weak. So they've been giving us testimonies. And that actually helps us to succeed in what we are doing. Because if you were to go to a healer and the healer gets tired of you and you keep asking them what you do, and this healer wants to go and see his or her patients, and here you are with your students making noise, probably that healer, to send you away, will just give you anything. I'll just give you anything to get you off my back. Go. But more importantly, then also, I think we do a lot of work with industry. We help industry with method development, analytical, I think, work, formulation studies. So we've been working, I think, on some of those products, I think, for some of these companies where they had challenges with stability of those products. They've been taken off the market by SAPRA. Okay, so in fact they are back on the market. So we're actually proud. Even the students are proud when they see, gripe water and say, at least we contributed to it going back into the market. When they see umuti wenyoni, I say, no, we're actually happy because we contributed. So when you go to our lab, you'll see some of the remnants of those products, because we worked on those products to assist and help industry. We are also now, I think, working, I think, with one company again. They are asking us to develop an analytical method so that they can look at the stability of their peaceful sleep. We have stability chambers, so we can do, I think, stability tests. So we work with them, and that's how we respond to industry, I think, challenges and industry needs. So the other project, I think, which is a beautiful project, some of you that do not know, when you eat bread, okay, when you eat bread or when you eat pasta or when you eat your macaronis, it has got a molecule, it's a sugar called inulin. It is a prebiotic, okay? Also, what is important about inulin, it's used in pharmaceutical grade. But we were then approached, I think, by, some companies that said, you know what, we've got a challenge because nobody in Africa produces inulin. We buy it from Belgium, and it gets very expensive. So one company started using one small company in the Eastern Cape to see if they can circumvent that. But what that company was doing, it was not purifying inulin, because inulin comes from the chicory root, okay? That chicory root. Very versatile plant, because from the chicory root, you can roast those roots and make coffee. So coffee is not coffee. So chicory then makes up your coffee. But if again you are fortunate, if you grow this plant in hydroponics, this one has been grown in the soil in my garden. If you grow that plant in hydroponics, the leaves do not turn green, they turn that golden yellow. And that's the salad, vetlof, you would find at Woolworths. Okay? So it's a plant that you can use all of that. But the inulin, when you grow it in hydroponics, the yield is very small. So this company then was growing this inulin, but they could not extract proper inulin. Okay? So they had a 70% crude extract that they were giving to this company, and we're eating that bread as South Africans. That's what we have been doing. So then they said, can you come and help us with an extraction method for inulin, which in fact we have done, So I'll come back to Tia again and say, can you fund that? Okay? Can you fund that? So it's what we do to respond to industry questions. The teas, we work with communities in the Eastern Cape. I won't go into the details into the Eastern Cape. We have been working on these teas for some time, but we're working on those teas for a purpose. So when you go to buy tea, okay, you'll see when I talk this afternoon. Maybe I'll talk this afternoon. When you go to buy tea, you can either go buy the big joko in, is it 100 tea bags or something like that, the big one. So that's for mass consumption. Okay, you go to a health shop and you buy exactly the same tea, but they call it a different name because all teas come from one plant, Camellia sinensis. Does not matter whether it's Joko, it's Earl Grey, whatever. They all come from one plant. It's how they process it. So then they pack it up into 25 or 20 tea bags at 5 times the price that we buy at Pick and Pay. It's the same thing anyway that you are buying. Just rebranding it. So we'll talk about these communities. I will not go through that. And then also I think, we'll briefly talk to you about, how we responded to COVID, HIV, using some of these products that come from, I think, our knowledge holders and our traditional healers and traditional medicine. I think this afternoon we'll talk about, Pela for post-COVID and for the work we did with farmers on a SAPRA-approved clinical trial, for COVID. This is a traditional medicines, but we then would go and reformulate it up. And I think one message that I want to do, we always see people crushing roots of plants and then putting them into capsules. I think formulation is more than that. You just don't crush things and put them into a capsule and say that's it. But we'll talk about it, I think, later on. But what we have also done, I think, for Dr. Morney here, we have now taken up, the same capsule, of Pela and thought, what would happen, if you have someone in a COVID state and this person probably might have difficulty in swallowing, what could we do? And then he says, why don't we take the same Pela and make it up into a mouth spray? Tastes very nice. So those that want to be guinea pigs, let me know. So we have done that. He will talk about that. So we moved the same thing from capsules. Said, well, let's try it into a mouth spray. So the mechanism, I think, it's the same. And then I think with Dr. McPherson at the back there, I think, we do clinical trials with them. Very good, I think, marriage. It will last longer, Dr. McPherson, on the aspect of how then do we move traditional medicines into clinical trials, and why are we doing all these things? Why do you want to do clinical trials? It's simply because when I started, I said our focus is to give our traditional medicines an international perspective. So if you want to sell your traditional medicines to your neighbor, you may say, but it's not important for me to do these clinical trials. But our vision is a global vision. That's what we want to do, so that we then meet, I think, the criteria and the standards. You'll see this is famous, the picture at the back, there's a real picture. It's not something from the internet. So he will take you through tomorrow and see those facilities. I think in Datepehani, we need to look at whether Famos, such a facility, the only one in the continent, couldn't really be regarded as a national facility. That's the only facility in the rest of the continent that can actually do that. And it would actually change how we perceive, the aspect of traditional medicines. Because what we want to do with the research is to give confidence to the consumers about traditional medicines. If the consumers can be confident that I can stand up there and walk up when Dr. McPherson says, I'm going to prescribe to you paracetamol, then the patient could say, but Dr. McPherson, can you prescribe to me umngcunube? We need to get to that stage where we have this integrated health, facility. So this is, I think, my very last slide. I think that clinical trial I was talking about was the first, I think, clinical trial on a traditional medicines for a COVID. That was approved by SAPRA. It was also approved by Pharma Ethics. And then it was conducted, I think, at 3 sites, PE, Gqeberha, in Kimberley and in Vereeniging. But we'll talk about those, I think, in the afternoon. And then also how we want to repurpose that, to address the growing challenge of post-COVID. Because even though there's no COVID, people are suffering, with post-COVID. Some are now presenting with TB, some are now presenting with young kids with diabetes. That, in fact, is something strange that's happening. So how then would we want to see if traditional medicines could be the first? Because nobody is addressing post-COVID. So we want then to do that with Dr. McPherson at the back there. And then the other aspect, I think, that we need to always look out for, which I want to briefly talk to you about, is actually the challenges. That's what, when I said you don't just grind traditional medicines and put it up into a capsule. You extract, you make sure that you know what is in that capsule. But I think some of the challenges, when people bring you different plants because they think it is the same plant, okay? And then when you get into the lab, you realize actually these are 2 different plants. And you look at it and you actually also find that once you start working on it, which is what has happened, if you look at the bottle or CG, the green one, you can see it, that's a third from your right. That was the original, plant. Then I think we collected another plant from Durban. When it came into the lab, it became red. Now, if you had to grind it and just grind it and put it up into a capsule, probably you'll be giving people the wrong thing. You'll be giving people the wrong thing. And then your results become very inconsistent. And that's why we are here as, I think, scientists and researchers, to work in partnerships with you and make sure that we don't do these things. I will quickly go through cannabis. Again, I think we work with cannabis. We work on local, I think, varieties of cannabis. This is the work that we have done, where we concentrated, I think, that cannabis. I think the big main distillate is about 70% THC. We concentrated that one. And then the smaller bottles are your terpenes. But we have a different approach in terms of what we want to do with cannabis. We're not interested in your CBD and your THC, but we are interested in a particular formulation and a particular ratio that addresses a specific, I think, disease. We have analyzed, I think, a whole lot of, I think, Dr. Taylor, of the cannabinoids in the local cannabis. This particular one, I think we took cannabis from Lesotho. We've got a permit in Lesotho. It's a 10-year permit. We've got a permit in South Africa. So we can go and collect this and compare, I think, those cannabis. And those are the cannabinoids we could actually pick up in those cannabis. And we could also pick up different terpenes from those terpenes. And this is why we are standing up as a niche and say, we are not wanting to be the me too, but we know what cannabinoids, if you mix those cannabinoids, could produce in a certain ratio for what disease conditions. Say for Alzheimer, if you have CBC, CBD, and CBG, and that's what I think, Dr. Morne and myself are working on, and also with your beta-chirophyllene. Beta-chirophyllene is a terpene, but it behaves like a cannabinoid. So that's what we are playing around, and some of the things I think, we are looking at the little, I think, prototypes that, we're actually developing. Dr. Gabriel will be talking to you, I think, today about, a transdermal pest hydrogel that we are producing for pain, for cannabis. So we want to be different. People are just chasing CBD and THC for no reason. They don't know why they're doing that anyway. So, colleagues, I think, in conclusion, I think we really are saying, as a platform, we are here to help. We are here to work with you. We are part of a bigger global, agenda. Working with WHO, I know that I chair the WHO, I think, expert committee, on traditional medicines, for COVID and beyond. So we're also looking at participating in becoming a regional manufacturing facility, for WHO. And that's what we are placing ourselves for the manufacturing facility that we're building. I think, you'll see that one next year, just on traditional medicines. It's going to be a WHO, standard GMP facility. And that's really where we need to be moving, our traditional medicines to. And then there's now also the aspect of, I think, the institutes and things like that. But I think I will run through this quickly. I think we do a number of community training, I think, activities. The top, I think, left, it was a training with, I think, the lawyers on aspects of access and benefit sharing and the rights. The bottom, in fact, it was a GCP training. This Dr. Masfesen, I think we did, where we had traditional healers with medical doctors, because GCP training, GCP certificate is required for your clinical trial. So if our traditional healers are going to participate, they might as well go into the same training as the medical doctors. And that's what we did. In fact, they passed, because you have to pass to about 70% to get that GCP certificate. And then we do a number of, I think, training at the bottom. I think this was in the Northwest with their tribal council, thinking and planning, about the teas. And then just at the top there, it was, I think, again, top right, I think, where we had all the chiefs from the different provinces on our projects. We had a workshop, with them to understand where we are going. And then this was, I think, a training of the communities in agriculture by Ubuhle. That's what they did. And then just the last one to boast, these are our collaborations. We collaborate, I think, extensively. I think, we don't work in isolation. So we work, I think, with universities and institutes, almost everywhere. We had one of our students spending a year in Germany, being trained. She's back. We work with China. We'll be sending some of our students, I think, in China. In South Korea, we do the same. So we believe in exchange. But the same thing, I think, we accept, other students to come. We have just had, I think, a student from Busitema University in Uganda. She spent, I think, 2 months with us, helping them. We did the same with some Brazilian, I think, students. We did the same, I think, with medical students that came from South Korea who are into traditional medicine. So they came and spent time with us. So we want to see more of that, I think, happening, so that I think the dream of taking African traditional medicines and making it internationally, recognized and an international force begins to be realized. Colleagues, thank you so much. So I know that I talked a lot and I stood between your tea time and me, but the reason why I did that is because when I come back and talk about the teas, it's a question of why do you drink tea? Why? Why do you drink tea? Huh? Why? You drink tea because it's tea time. You have no reason to drink tea, because all of you can't even answer me. So when we talk about our teas, we'll tell you why we say you drink tea for a reason. Thank you so much. So I don't know, Dr. Hobololo, whether I chair or whether there will be questions or we take a break. Okay, colleagues, we're told to take a tea break. For those that drink tea, because it's tea break, so you can do that. Thank you.
Is the mic on? Okay, super. Thank you very much. So thank you, colleagues. I think we'll give each other just a few seconds to settle down. So a very warm welcome to the Developments in Human and Plant Health panel discussion, which I'll be facilitating this morning. We're scheduled to start immediately, colleagues, and we will in essence go into a presentation, and the rest of the panel session will in essence be a panel session. We'll have some discussion around a few prepared questions for the colleagues. We have a panel which consists of experts in natural products-based remedies for certain human ailments. We will hear about the development of IK-based pesticides to control plant diseases, and we will engage with innovation management experts from the technology transfer space at higher education institutions. As I said, some of our speakers have elected to give short presentation. We will certainly afford them this opportunity and then take a panel discussion. So to kick off, I'd like to introduce the esteemed panel members and ask them to speak briefly about what they do to give the audience some context as to who they are. The first panel member is Dr. Sibongile Gumbi, who is joining us online. Dr. Gumbi, can you just confirm that you are indeed online? Okay, then perhaps while Dr. Gumbi is joining, I will introduce her shortly. Let me ask Dr. Mthokozisi Simelane to say a few words. He is a biomedical sciences graduate and has a deep interest, colleagues, in the biochemical reactions of traditional medicine. He pursued his doctoral studies on the antimalarial activity of plants and undertook a postdoctoral stint at the University of Michigan in the USA. Dr. Simelane, I'm happy for you just to give us a few words about what you do and who you are.
Good morning, colleagues. I'm not sure if you can hear me. I've got a problem with my voice. My name is Mthokozisi Simelane. I'm a biochemist. I'm from the University of Johannesburg. My research focus is on the phytochemical studies of indigenous medicinal plants with the main objective of isolating and characterization of bioactive compounds as the lead products for the development of ethnopharmaceutical drugs against malaria and diabetes. I'm so happy to be here. It is my first time in Free State. I'm looking forward to get your questions. Thank you.
I will then go back to Dr. Sibongile Gumbi. Sibongile, can you hear us?
I can hear you clearly. I'm not sure if you can hear me.
She says she is linked, but we'd like to get her on. Oh, we need to press something, right? Super. Dr. Gumbi?
I'm here.
Right. Can you hear us, Dr. Gumbi? Yes, someone needs to admit her, please. Dr. Gumbi? Could we get some assistance, please, colleagues? Okay, so while we're waiting for the technicians just to get things sorted out there, perhaps I'll just start by saying that Dr. Sibongile Gumbi is the founder of Smart Biotech, a biopharmaceutical company concerned with the development and manufacture of high-quality health products sourced from or expressed in plants. and holds a PhD in pharmacology obtained from the University of Cape Town, as well as an MBA, EMBA, Executive MBA from IMD in Switzerland. She has held numerous posts in technology and innovation management in the National System of Innovation and has consulted for international organizations including MIHR, GalvMed in the UK, and the Rockefeller Foundation. Dr. Gumbi, if you can perhaps hear us, please indicate, and perhaps just talk a bit about what you do and who you are.
Thank you, Dr. Peano. Can you hear me?
Yes, we can. Thank you very much.
Okay, finally. Thank you.
Super.
I'm not sure if you can see me, but
Yes, we
those
can.
who are online will be able to see me. Thank you very much. Thanks for the introduction, Dr. Peano. As has been said, I'm involved in the development and manufacture of a number of plant-based products, some in the animal health space and also in the human health space. In the human health space, we're involved in the testing and development of plant-based medicinal plants that have been that their activity have been scientifically demonstrated. We have our first product that's on the market called a colon regulator, and we're intending to introduce more products of a similar nature into our portfolio. With the colon regulator, we're just about to start phase 2 clinical trials and continue with that work that we're involved in. It's a great pleasure to be with you this morning. Apologies that I couldn't attend physically, but it's I think the communication does allow for me to still participate in a meaningful and valuable way. I look forward to the panel. Thank you, Dr. Pehani.
Super, thank you very much. Let me then also introduce Dr. Monet Weyers, who is a postdoctoral researcher at the University of the Free State in the Department of Pharmacology. He conducts pharmaceutical research on indigenous knowledge systems and has a special interest in drug development combined with cellular and molecular research. Dr. Weyers, a few words from you, please. Just going to talk. I'm still introducing, just going to talk who you are, and then we'll come to the presentation later.
Okay. Okay, I see.
Just introduce yourself.
Okay. Okay. Hello, everyone. My name is Morne Weyers. I'm a pharmacist and a postdoctoral fellow here at the University of the Free State, Department of Pharmacology. And today my presentation will be about indigenous knowledge systems and the traditional medicine of Pila. Thanks.
Dr. Innocentia Mangwatoshi here. She's joining virtually. Okay.
I'm here, Chair.
Okay, super. Thank you very much. She's a lecturer and researcher at the Free State University and has worked with Dr. Gudrun Ulrich Merzenich, that's my German, from the University of Bonn in Germany, in the working group of synergy research and experimental medicine. Her PhD in IKS pharmacology focuses on cannabis and cancer drug resistance reversal through studying various efflux transporters that play a major role in anti-cancer drug resistance. Dr. Mangwata, welcome, and a few words from you, please, by way of introduction. Thank you.
Thank you, sir. Greetings, colleagues. As the chair has mentioned, my name is Innocentia Mawadu. This morning, my talk will be mainly based on my research focus, which is a focus on the research of cannabis around drug-resistant reversal, with a particular interest in the gynecological cancers amongst females in South Africa. Thank you.
I'd also like to introduce Dr. Phumuza Langa, who's a biotech graduate with extensive experience in technology transfer, technology incubation, and entrepreneurship. He has worked in several institutions such as the CSR, the University of Pretoria, Tshwane University of Technology, NIPMO, and the University of Johannesburg, focusing on the commercialization of R&D outputs. Dr. Langa is currently the Senior Commercialization Analyst at UJ's Technology Transfer Office. Dr. Langa, a few words from you, please.
Yeah, morning. As mentioned, my name is Pumuza Langa. I'm at the University of Johannesburg Technology Transfer Office. So my role largely is to help with intellectual property commercialization, and particularly in this instance, I'm working with Prof. Simelane, and we're trying to commercialize his plant extract and see how that we can get that into the market based on the IKS that informed their research. Thanks.
The final panelist is Ms. Nolita Skenjana. She will join us a bit later, colleagues, but she's an entomologist with extensive experience in plant protection research and development of IK-based pesticides. Her current PhDs entail the development of IK-based plant protection measures whilst taking up employment at the Doan Agricultural Development Institute, Stutterheim. So to kick off, colleagues, I think I'll ask Dr. Morne Weyers just to come forward, give us a short presentation, and other presenters will give us their presentations as well. Thereafter, we'll engage in a panel discussion with a few prepared questions. Dr. Weyers.
Hello everyone. As I said, for today, this presentation, I will focus on indigenous knowledge systems towards medicine and the development of the traditional medicine called Pila. To a certain extent, this refers to the power of nature and what can be achieved if you tap into it. It is also important to note that nature still contains many secrets which are yet to be discovered. As indigenous knowledge researchers and scientists of nature, it is our responsibility to find these secrets. I would like to start off by giving some stats about natural medicine. Over the past decade, natural medicine have become more popular among the people in the world. As of November 2022, the world population was projected to have reached over 8 billion people for the first time. And about 80% of these people depend on natural medicine for their primary healthcare needs. The use of these medicines in the treatment of disease has a long tradition of use when compared to conventional medicine, especially if you look at the deep-standing roots of traditional medicine in Africa. One such example of African medicine is the African wormwood known as Artemisia afra, which contains the prodrug compound artemisinin. This product is used in one of the most dangerous infectious diseases in the world, called malaria. Treatment from malaria, originating from nature, demonstrates the importance of traditional medicine research. Why should science focus on traditional medicine? Synthetic treatments, such as for diabetes, can be expensive, and traditional plants have less side effects. They are also more readily available. One such example of an indigenous knowledge medicine is Pila. Developed by the IKS unit of the University of the Free State, Pila is a herbal combination drug consisting of 4 exotic African plant extracts formulated into a precise ratio. A combination of these plants historically has been used to treat the ancient disease known as Miaga. Patients that contracted Miaga were characterized by symptoms like cough, shivering fevers, headache, weight loss, chronic gastrointestinal disturbances, pains, and mouth ulcers. A lot like what we see today with HIV/AIDS. We will now move to Pila's analytical results. First off, the current slide shows the fingerprinting of Pila by liquid chromatography, which is used for identification and quality control purposes. If you can follow with me on the slide, these are the 4 plant extracts of Pila, and the lines from the liquid chromatography represents the compounds inside those extracts. And this here is the fingerprint of PILA itself. Fingerprinting is necessary to ensure consistency in the formulation before preclinical examinations can occur. Analytical fingerprinting is a method to measure and represent the entire composition of a product, with some common chemical compounds being pharmacologically active or have certain chemical characteristics. Most importantly, only the unbound fraction of a drug can have pharmacological activity. Therefore, it is necessary to determine the free fraction of the total drug concentration, and this is why we do fingerprinting. With PILA, clinical and preclinical studies for antiviral activity and drug safety were conducted in vervet monkeys, as well as an in vitro rat study, also to investigate the enzymatic activity of PILA on the liver. From these studies, the antiviral results of PILA demonstrated a high percentage of HIV protease inhibition, yielding it as a potential active medicine against HIV. The in vivo studies also showed recovery of CD4 immune cells with a decrease in viral load. Finally, these results demonstrated normal enzymatic activity within the liver, which suggests that PILA is safe to use even at high doses. PILA was then tested in a rat model for its immune modulatory effects by using immune suppressant drugs. These drugs were cyclosporin, used as an immune suppressant in organ transplant, cyclophosphamide, a chemotherapeutic drug, and the glucocorticosteroid or cortisone, dexamethasone. These drugs are all well known to suppress the immune system. As shown on the slide, the three immune suppressant drugs with their activity. If you can follow with me again. These are the three drugs that I mentioned, immune suppressants. And on the slide here, you can see a purple and black line. The purple line represents the control. In other words, the animals that were not given immune suppressant drugs. And then the black lines represent the drug itself. And as you can see, the separation between the two represents immune suppression. Interleukin 2, interleukin 10, CD4 cells, that is most importantly in HIV. And you can see that these drugs readily depletes the immune system. With the immune system, we have antibody cascades, activators, helper and killer cells. It is well known that HIV affects the T cell system of the human body, but we also have a helper T cell system, which is responsible for a vast array of immune modulatory effects of the body naturally. These helper T cells can differentiate into either type 1 or type 2, where type 1 leads to the formation of cytotoxic T cells, and type 2 leads to the formation of B cell antibody cascades. In this way, they can help to modulate our immunity. We can refer to this as cell-mediated immunity. Helper T cell type 1 and type 2 immune responses are very crucial immune modulatory effects of a drug. Discrepancies in this system can make the immune system incompetent and more susceptible to disease. This is important in diseases affecting cell-mediated immunity, such as HIV, COVID infection, cytokine storms, cancer, and especially TB. We can now move on to the results of the immune suppressant drugs. The following here on the slide is a summary of the treatment with the immune suppressant cyclophosphamide and then with the addition of PILA. I can explain on the slide again the immune cells, interleukin 2, 10, CD4, CD8, and antibodies, IgM and IgG. Here you can see PILA given with cyclophosphamide. There is a clear indication that the CD4 cell count has recovered, as well as CD8, and there's restorations on the interleukins and the immunoglobulins. The results then demonstrate that PILA led to increases in white cell count and stimulation of the immune system, mainly by the CD4 and CD8. And this selective effect implies that PILA is indicative of restoring a helper T cell type 1 response, cell-mediated immunity. Now we can look at the others. This is cyclosporin. Here you can see a small breakout at CD4 counts and interleukin 2, with also restoring of the IgG and IgM. This suggests a re-establishment of the helper T cell type 2 immunity. We can therefore say that PILA activates and maintains humoral and antibody-mediated immune responses. Then lastly, the dexamethasone. Parameters on the glucocorticosteroid were a bit different, as seen with the interleukin 2 only following the line with no breakout, but still showing restorations on the antibodies IgG and IgM. This is the same as was seen with cyclophosphamide. To put the effects together, PILA stopped and reversed induced immune suppression, evident by the increases in interleukin 2, CD4, and CD8 cell counts. PILA reversed drug-specific immune suppression by modulating helper T cell type 1 and type 2 immune responses, giving it potential to modulate humoral and cell-mediated immunity together. We can now look at PILA's activity against the coronavirus. To test PILA in vitrally against the coronavirus, you first have to test the cellular toxicity of PILA itself. And in this case, using cells which expresses the binding site of the COVID virus, so then to later on being able to test the virus against PILA itself. As can be seen from this slide, PILA showed a low level of cytotoxicity, even at high concentrations. If you could follow with me on the slide again. The x-axis here represents the dosage of PILA, and the y-axis represents, let's say, cytotoxicity. As long as we can stay under the 50% inhibition line, it can be considered safe. Most of these are very safe based on these results, and only showing one at a very, very high concentration, peaking through the 50% inhibition. These cells were then used to study the virus receptor interactions and the ability of PILA to neutralize the COVID virus infection inside these cells. As can be seen, demonstrated here by PILA, it has a decisive inhibitory effect against the virus. If I can show on the slide again this time, if you look at the 50% inhibition line, these products do cross them and go up quite high. And this is even at normal doses. Furthermore, the extract was able to inhibit other strains of the COVID-19 virus, including the strain that caused the first wave of infections in South Africa, and the mutated variant that was responsible for the second wave of infections. Again on the slide, you can see that they go through the 50% inhibition line quite readily. In addition, the PILA extract was tested against other members of the coronavirus family, seen in previous years, the SARS and MERS, and the data suggested that PILA is likely to have a broad spectrum of activity against different viruses of the coronavirus family. This is a demonstration of the simulated molecular docking results of the individual extracts of PILA to further understand its mechanism. This data gives significant insight into future developments of this traditional medicine. The development of PILA has taken place under rigid scientific scrutiny in both preclinical and clinical research. The efficacy of PILA as both an immune modulator and an anti-COVID-19 treatment has been proven in both in vitro and in vivo studies with reproducible results. As previously mentioned, PILA has the ability to control cell-mediated immunity through T cell type 1 and 2 modulation. This gives a substantial capability to address diseases like HIV, COVID, autoimmune diseases, cytokine storms, TB, and other forms of diseases causing immune disruption. As many as 30% of people infected with COVID-19 go on to be infected with long COVID, which causes debilitating symptoms months after the initial COVID infection. Common symptoms include gastrointestinal problems, cognitive dysfunction, fatigue, and shortness of breath. But most importantly, these patients demonstrate with a significant higher value of neutrophil count and escalations in serum inflammatory markers, suggesting a disruption in the immune system function. This immune disruption may explain the number of patients suffering from comorbidities like diabetes, autoimmune disease, and TB following COVID, which we refer to as long COVID. Therefore, based on the data already seen from PILA's biological effects, it can definitely be argued that further research on long COVID and also TB should commence for PILA. Such operations can perfectly fit into future developments of this medicine. Lastly, to show, under the directive of Professor Motlalipula Matsabisa at the IKS unit, this is a label draft example of a PILA prototype dosage form produced within SAPRA standards, I hope, consisting of a specialist process for the PILA extraction and a distinctive organoleptic flavoring formulation which almost completely masks the taste that you would get from the plant extracts themselves. And most importantly here, the idea was to formulate this mouth spray so that it can deliver the same amount of dosage of PILA with 1 or 2 sprays that one would get from 1 tablet. And then to conclude, are we ready for the next pandemic? Do we have TB under control? Does nature have the answer, and how do we keep unlocking its secrets? When it comes to nature and traditional medicine, it makes me think about a story of an old man, or a wise man, that was considered a great sculptor. He made these beautiful man-sized sculptures from big rocks. And one day a young guy walked up to him and asked, "How is it that you have the potential to produce such great sculptures?" And the old man replied by saying, "The sculpture has always been there. I just had to chip away the rough edges." You don't unlock the secrets of nature by only focusing on what is easy to achieve. You do it by doing things differently. You do it by believing you can change the world. Thanks. It's 15 minutes.
Just need to switch to the MS Teams. Thank you very much, Dr. Weyers. I'd like to ask Dr. Mangwatu, if you're ready for your very short presentation, please, before we get into the panel questions. Dr. Mangwatu. Can you hear us? Okay.
Yes, I can
All right.
hear you. I'm
Super.
trying to share my screen. Okay.
Yes, we can see the screen. Please proceed, and then
All
we'll take
right.
panel questions. Thank you.
Okay, thank you, Chair. My talk this morning will be mainly focusing on the use of artificial intelligence with identifying novel drug targets. So the title is a network pharmacology study on the molecular mechanisms of cannabis sativa compounds and the treatment of cisplatin-resistant in cervical cancer. So for a bit of background, cervical cancer, which is also referred to as cancer of the uterine, is a female type of cancer that forms in the cells or the tissues of the cervix, which is the organ within the female reproductive system that connects the birth canal to the uterus. Recent stats show that cervical cancer is the 4th most commonly diagnosed gynecological cancer and the cause of cancer-related deaths worldwide, accounting for approximately 600,000 cases and overall 340,000 mortality rates annually. As we scale it further down to South Africa, it is ranked as the second most common female cancer among South African females, and the cancer which most South African ladies die from in our country. Furthermore, in the African context, it has been reported as the leading cause of cancer-related deaths with the greatest burden carried by the sub-Saharan region. Almost all cases of cervical cancer are linked to persistent infection by the high-risk human papillomavirus with the HPV DNA, which is located in various tissues across the female body and transmitted mainly through sexual contact. Now, the WHO recommended treatment for cervical cancer involves surgery, chemoradiation, amongst others, depending on the developmental stage of the cancer. And in the instance of recurrent or advanced cervical cancer, cisplatin is often the recommended first line of treatment. However, sadly, due to continuous exposure of cisplatin, it does somehow result in drug resistance, which is a major burden to the success of chemotherapy. Several or various strategies have been explored in order to circumvent cisplatin resistance, and one such would include the use of verapamil or cyclosporine. However, these then results in undesirable side effects such as your drug-drug interactions, cardiotoxicity, experiencing toxicity to normal cells, and lack of efficacy in clinical trials. Hence, there is a need to actually look into natural products for new, novel, effective, non-toxic strategies. The plant of interest here was cannabis, which has been traditionally used to manage quite a number of human ailments, including cancer, diabetes, and hypertension, prior to it receiving its illicit drug status. It has also been studied extensively for its anti-cancer properties, but the studies were particularly looking into the synthetic cannabinoids. And also the data on its potential influence in multi-drug resistant mechanisms with respect to cervical cancer are still lacking, which is why we also need to investigate the potential targets and mechanisms of the active ingredients within this plant in order to help us develop modulators that are affordable and possess fewer adverse effects. The methods which were followed in this section were as followed. The landrace used in this study was collected and harvested from the Sikisiki area in the Eastern Cape. And prior to that, a permit needed to have been obtained from the Department of Health, which would allow us to use and process cannabis for laboratory research purposes. The specimen obtained was then authenticated by the Geopod Herbarium at the University of the Free State Department of Pharmacology. And thereafter, our plant material was then immersed in cold ethanol for extraction. The crude extract was then further fractionated by hydrodistillation in order to obtain the 5 fractions, which Prof has also shown in his presentation earlier on. And then these fractions were then characterized through HPLC mass spectrometry in order to identify the active ingredients which are available in this particular landrace. We did obtain quite a number of them, but for the purpose of this talk, I'll only focus on the CBN, cannabigerol, and the terpene compound cardiophyllin. For the network pharmacology or in silico study, it went as follows. The first step then entailed predicting the potential targets of our reference drug, which was cisplatin in this case, followed by the cannabinoids, which would be CBN, CBG, and your cardiophyllin, alongside the disease, which would be cisplatin resistant in cervical cancer, and the selected cervical cancer cell lines. These potential targets were then obtained from a series of databases, including NCBI, GeneCards, and Campbell, just to name a few. Secondly, the potential targets obtained were then used to construct protein-protein interaction network using string databases. And then this was followed by the construction of the compound and target network using cytoscape. And then lastly, the identified networks were then further evaluated by enrichment analysis using network analyst, which would then help us predict the potential mechanisms, the gene functional annotation, as well as the pathways of the cannabinoids and the terpenes in multi-drug resistance in cervical cancer. For the results, the constructed network of multi-drug resistance in cervical cancer alongside the cervical cancer cell line actually resulted in a total of 126 targets and 201 as well as 31 cervical cancer cells targets respectively. However, when we look into the drug, a total of 116 drug targets were identified, while the network of the drug alongside the disease and the cells consisted of a total of 53 nodes or targets as shown in this figure below. These are the ones that are encircled in red. Interestingly, some of these identified core targets include drug efflux transporters such as your ABCB1, ABCC2, and ABCC5, which are known to be the major contributors towards cisplatin resistance. Now, moving on to the matched network of each of the compounds alongside the disease, the drug, and the cervical cancer cells. The cannabinol network showed on my left, I think it would be your right, show the cannabinol network resulted in a total of 12 targets, and these are the ones that are encircled under CBN, and of which can be explored. These then would include, just to name a few, cannabinoid receptor 1 and cannabinoid receptor 2, and your most famous TRPV1, as well as your PARC targets. While the CBG or cannabigerol yielded a total of 5 targets alongside the disease, the drug, and the cervical cancer cells, which also included your most popular targets would be HIF1AA, PARC again, and the 2 cannabinoid receptor targets mentioned earlier. And then lastly, on the meshed network would be the meshed network of the caryophyllene and terpene constituents, which only yielded 2 target genes, namely your most famous one would be GLI and then followed by KMT2A. In order to elucidate the potential molecular mechanisms underlying the efficacy of these cannabinoids as well as terpenes, the cytoscape data was then further analyzed on the network analyst software, the WNT signaling pathway. I'm just going to mention quite a few of them, which are mostly studied, especially with respect to MDR in cervical cancer. And then it would be your Notch signaling pathway, as well as your MPK signaling pathway. All of these KEC pathways are closely associated with cervical cancer, resistant to cervical cancer, as well as other gynecological disorders. Moving on to the gene functional ontology, the enrichment identified quite a number of functions across the 3 sectors or terms, and only the top 10 significantly enriched gene ontology terms were selected to generate the bubble maps. As it can be seen in the figure below or bubble graphs below under biological processes, the biological processes targets were predominantly associated with cannabinoid signaling pathway. One can also look into the negative regulation of the action potential, as well as the monooxygenase activity. Thereafter, the cellular components target were mostly enriched within the nucleus, the mitochondria, and the cytoplasmic region, just to mention a few. while lastly, the molecular functions that which are mainly involved and were predicted in this study were the receptor binding and mainly associated with cannabinoid receptor activity, as well as through protein binding. Now, in conclusion, this in silico analysis did provide or does provide insight into the potential targets as well as underlying mechanisms in the form of signaling pathway and gene ontology functional terms in which the cannabis sativa plant can modulate multi-drug resistant in cervical cancer. And secondly, the potential hub genes were also have been able to identify for further experimental verification, either through RT-PCR or Western blot, or both of them. And last but not least, I would like to acknowledge the following entities which played a role or contributed to the study, each in their respective capacity. And with that being said, I'd like to thank you for your attention.
So thank you very much, colleagues, for your presentations. I think we'll now go very quickly into the panel discussion. And the essence of the panel discussion is really for us to have a conversation around some of the things we've heard, to hear from some entrepreneurs, some of the panel members, what their challenges are within the National System of Innovation. We'll also speak to our experts from universities, state transfer officers, just in terms of their role as far as the System of Innovation is concerned. So my first question is really to Dr. Gumbi. If you can hear us, can you just confirm you can hear us?
Yes, thank you.
Okay, super. Dr. Gumbi, as an entrepreneur, having come from universities, having started your own business and so forth, are you able to share with us what you think are the major shortcomings in South Africa in supporting startups in complex biopharmaceutical endeavors, such as the one that you are pursuing?
Thank you, Dr. Pehane. In responding, let me first start to say I've been in this space for decades already, and I must acknowledge the huge strides that have been made already to support SMMEs in the area of commercializing technology that has developed or that has been developed at universities and research institutions. There have been extensive programs and support structures that have been put in place already in this space. And I think in many cases, they are starting to yield positive results. But as always, there are always challenges that still exist. And for me, I think that one of the bigger challenges is in the area of commercialization. It's very easy for research institutions and researchers to say a product is now market ready. Little do they realize that there's a significant number of steps and experts and resources that are required to move a product from being market ready to one that is penetrating the market. And so I do think that in the same way that time has been spent in assessing the technology development value chain and making sure that across the technology development value chain, there are interventions that are in place to support that part of developing a product and taking it to market. A similar assessment needs to be done on the commercialization side of the final stage of actually entering into the market. And just to my experience in terms of what are the shortcomings in that value chain, I think starting, I would say, would be that many entrepreneurs would benefit from mentors who have done this and have been there before to help them understand, for example, how to connect with maybe contract researchers, what is required in terms of the containers of a certain product or the package design of a certain product, what are the regulatory requirements where patient information leaflets and package inserts are concerned. Where does an entrepreneur get access to the resources, the expertise, and the services to actually put together a product that can be put onto the shelf of a retail store? How do entrepreneurs actually access retailers? Is it a business-to-business kind of engagement, or are you engaging directly with the consumer? How do you go about with your sales and marketing? And so there's a lot of new areas that many researchers may not necessarily be aware of in terms of taking products to market. I do think that in analyzing the value chain of commercialization, there needs to be prioritization of SMMEs. So, for example, in the regulatory space, how does SAPRA prioritize the efforts of small, medium enterprises to ensure that their experiences are positive and are seamless, and that they're also affordable to them, and that they've got access to the right kind of expertise to take them through the regulatory process? There are other national programs whereby SMMEs may not necessarily be able to access. So, for example, ESD programs and other programs that are designed to build SMMEs, are they actually working for some of the SMMEs in the technology space? So you will notice that I've talked about resources, I've talked about facilitating easier access to certain areas such as the regulatory areas and the like. I've not talked about funding. Obviously, the funding, yes, is very important because all of this does cost money and it does take a lot of time. And therefore, a review of what's the financial support provided for these different activities. And so just to conclude is to say that those entities that have been put in place to assist SMMEs to take products to market, I think a much closer look at what it entails to actually commercialize and enter the market needs to be done, and to assess whether small, medium enterprises are adequately supported, and that the bottlenecks that small, medium enterprises experience can be identified and released, so to speak, so to enable them to pass through some of these areas that are of concern. Thank you, Dr. Peane.
Thank you very much. Dr. Simelane, as hopefully an aspiring entrepreneur, doing the kind of research that you're doing at University of Johannesburg, surely you have experienced certain hurdles regarding your ability to bring these innovations to the market. Perhaps share some of those hurdles, and you too, Dr. Weyers, in terms of the hurdles that you experience as academics in taking your innovations to the market.
Thank you, Dr. Peane. Not sure if you can hear me. Okay, great. The challenge that we have, I work very close with traditional healers. So the problem that we have is benefit sharing. So you'll find that the traditional healers, they think that whatever research that we do, there's going to be money that they're going to get immediately. So when you try and explain to them that this is a long process, the research is not something that you do today and you end up having a product the next morning. So as you know that NIMBA Act, they want traditional healers to be part of the project since we get the knowledge from them. But the challenge that we are facing is that sometimes we end up being delayed because of the discussions about benefit sharing. You find that they want a certain percentage, and some of them you find that they think that they can just take the project away from us. And another challenge that we have, it is funding. So funding is a very big problem because you find that you have the project and you want to, like for example, to start, doing formulation, and the money is not there. And that is the issue, because that end up delaying the whole, project. So yeah, that is what I will say. Thank you.
So, Dr. Mangwati, if you can hear us, do you have similar challenges as an academic trying to bring your innovations into the market? Dr. Mangwatu? So perhaps let me ask you, Dr. Weyers, as an academic as well, do you have similar challenges?
Yeah, I think what was previously said now is exactly where the challenges lie. But it's also a thing of that in terms of, and I can refer to SAPRA now here, in terms of the whole law aspect of medicine, the regulatory, the registration of medicine, and how that works. Not a lot of people know that exactly step by step, what the process is, what do you need to follow, what the cost is. Obviously that will always come up is the cost thereof. But even if you could, there's obviously a difference between if this is a natural product or a new type of chemical entity. But even if you could find an institution or a few of them that can help you develop this product and eventually put it on the market, at the end you're only gonna maybe have about 2% of that IP, because all the financial costs involved is gonna shift that IP to all the other entities through preclinical trials and clinical trials. But like I said, it depends on if this is a natural type of product or a new chemical entity. But I think the biggest challenge is at the beginning, where people don't understand the whole process from the beginning to the end. And that's the reason why some of these medicines take 15 years to develop. So yeah, I think it's the same kind of challenges.
Thank you very much. So, Dr. Langa, you've heard in essence your colleagues in the academic space talking about their challenges. As someone who has this experience in tech transfer, incubation, entrepreneurship, but also at a university tech transfer office, what do you think TTOs should be doing to support the development of these IK-based innovations at higher education institutions? And tell us a bit about, how they should be aligning themselves with industry to assist them to get to the market.
All right, okay. Thank you very much. So, of course, as indicated, it's a process. And having the researchers to understand the process from the beginning is very important. And then the question is, perhaps, where does the process begin? So the researchers could interact with the traditional healers, but then there's something that they do in the lab which would result in some form of intellectual property arising. And then the question always will be, whose intellectual property is it? So it starts off with proper intellectual property management. This is what we do, because we try to, file patents, but the patents would probably, for instance, in our case, relate to the extraction method. But then the knowledge around the plant having this particular anti-diabetic activity was something that the traditional healers had to bring forth. And then whose intellectual property is it? So, so having to understand what the patent is filed on and where it will eventually get to, and managing those relationships with the traditional healers through complying with the NEMBA Act, benefit sharing agreement being in place, what they want and what the university can contribute. But having said that, also having to bring in the partners at an earlier stage, such as the ones that can help with funding, and the funding at the different phases. But then again, I always say that just to talk about industry and how the tech transfer office can help. Researchers must do the research and innovate, and then the tech transfer and the commercialization and intellectual property management professionals will handle the other part. So each and every institution has a technology transfer office with people that are in the same role that I am in. So I think the main thing is that allow your tech transfer office to deal with matters of intellectual property management and how the project can get different types of funding for commercialization and industry relations, and how that can eventually be commercialized. And then the researchers can focus on what they do best, which is researching and getting the product to be technically sound. From our side is to ensure that it can be commercially viable and get to market.
Have touched on something quite sensitive, which we often see in the funding space. Basically, this conflict between the owners of the IP, your role as a tech transfer office, and of course what the inventors, or let me say researchers, want to see coming out of this. Perhaps tell us a bit about that tripartite relationship, your experiences around that, and what advice you can give to our indigenous knowledge holders when they approach a university such as Free State University and have to deal with the academics who have their own desires to publish their work. How do you manage all of these?
Yeah, so it's a very interesting concept because to be understood, it must be understood in terms of who brings what to the table, okay? And everyone brings everything that's equally important. So for instance, the knowledge about what the plant can do is, most of the time is from the traditional healers or, the knowledge holders. And that's always acceptable and understood. There's also the scientific validation and scientific methods that come with that. That would entail, in our instance, the extraction method and optimizing that process. And that takes a different angle altogether because it comes to reducing certain things to practice. So for them to understand that this is the scientific part and whatever results that come out of that is the university will be bound to patent and file patents, particularly for the scientific element. It doesn't take away the knowledge that the traditional healers have brought in place. That is acknowledged, and that's why we do benefit sharing agreements and comply with the NEMBA Act. And of course, some of the results can be published, and publication can also happen concurrently with patenting. Okay, so as long as we've filed a patent and claim priority, that can still also happen because we would have had a priority to have done that. So a priority date to have filed that patent application. So these things can happen concurrently. Everyone has a role, and the benefit sharing agreement would allow for how money can be distributed once the commercialization takes place. So everyone wins at the end of the day. It's not at the exclusion of others. So it's to help parties work together.
Pumuza, I just want to check something with regards to publishing a research article. Does the name of the traditional healer needs to appear in the research article, or the traditional healer has to be fall under acknowledgements?
I don't know if there's any representative from there, but maybe Dr. Piani will take it. But I mean, it would be common courtesy. I'm not sure if it's a requirement, but it would be common courtesy. I see most publications, they do mention where their information came from. But I mean, I could need assistance with this one, especially from colleagues from TEF and complying with the NEMBA Act.
Yeah, okay, so thanks for. So I'm the facilitator here, and you are the panel members. Just so that we get things straight here. So, colleagues, my experience in these kinds of things, not to want to answer the question directly, but is to say that this is a negotiation, it's a discussion always between the IK holders, the universities, and the inventors. And ultimately, universities have their policies, have their processes, and so forth. It is my view that universities should always be looking to modify and update their policies as new things start coming up within the system. So it's really for the universities to, number one, consider, where the IP comes from, who owns the IP, to establish that, because there are processes in universities to transfer office to establish that. And if indeed, the IK holder is an inventor, the idea is theirs, they certainly must be acknowledged. I think ultimately we're saying that, you know, as a country we need to move forward as far as this is concerned, because there are certainly benefits to publication as well. But also it is to start to show you know, our indigenous knowledge holders that indeed, you know, we consider them as partners, we consider them as critical partners to what we're trying to do as a country. As in the same way that they benefit through some of these, you know, benefit sharing agreements, I believe they should be benefiting as well from publications. So you have an answer now.
Yeah, so if you allow me, just I see Dr. John Yermilan is here as a patent attorney and understands and assists us a lot with that. Maybe if you could also touch on it, because she's been instrumental in that as well.
Dr. John van Hamelin, perhaps if you can hear us, if you can perhaps just add very quickly to that particular question, the sensitive question around how we recognize our IKS holders in our publications and even patents. I may go that far.
Hi. A little earlier than I was expecting, but since we're keeping it informal, can you hear me okay?
Yes, we can.
Good. Yeah, I mean, so effectively in terms of patenting, it's quite clear that the standard is really, is there some sort of an inventive contribution that's been made by an inventor? So if a traditional knowledge holder has provided an inventive contribution, which may or may not be the case, it depends on how much kind of further research has had to happen at the university or at the Science Council or at the company to generate the actual scope of the claims that you are wanting to get protection for. So it's really a question of fact whether that traditional knowledge provider has given enough information that it's actually going into the claims themselves. And if that is the case, then the traditional knowledge holder must be cited as an inventor. It's not a sort of an optional thing. It's something which has to happen in terms of our law. And if you have a patent that has been filed and granted where the correct inventors have not been cited, it's actually a ground to have that patent revoked. So it's very important to get that right. And it's fairly simple in that it's a question of fact. You look at how much of the information comes from the traditional knowledge holder, and you look at how much information was generated by, you know, subsequently by whoever the patent applicant is going to be, and then you make the determination on that basis. If there is the decision that the traditional knowledge holder has contributed some sort of intellectual contribution to the invention, then obviously there needs to be some sort of transfer of their rights in that invention to the applicant. So the applicant might be a university or a company or a science council. There needs to be some sort of a transfer of their rights in terms of the Patents Act. And obviously in terms of member, you know, because they are a stakeholder, there will be benefit sharing agreements, etc., that need to be in place. And there will be agreements that are in place with that traditional knowledge holder. So those will form part of your patent application. And then, of course, in addition, in South Africa, it is a requirement that in terms of our Act, there is a statement or a declaration that needs to be filed for a complete application that specifically sets out whether you've actually used traditional knowledge or whether you have used an indigenous biological resource in coming up with your patent. And if you have to make a declaration that sets out that that is the case. And you have to provide some sort of proof of authority that you've got consent from the stakeholder. And there are various, I'm not going to get into detail, but there are various things that you can show that give evidence that you have authority to apply for that patent. If you don't submit that statement, or if you make a false or a material misrepresentation on that statement, it is in fact also a ground for revocation of your South African patent. So, you know, it's very important to give that consideration when you are doing your patent application. I don't know if there was more to the question. I've gone on a bit, but I hope that was helpful.
Yeah, it was helpful. Thank you very much. Very much, very, very helpful indeed. I'd just like to confirm if Ms. Dolita Skenjana is online. Mrs. Skenjana, are you on? Okay. That's it, colleagues. I'd like to say thank you very much. We have indeed run out of time. I think we've sort of overstayed our welcome as far as this is concerned. I'd like to say thank you very much to the audience, but particularly also to our panel, esteemed panel, for your contributions to this discussion. And I certainly hope that going forward, we will be, I suppose, educated just in terms of how we manage these opportunities, because ultimately it's about us taking care of and looking after our economy and of course, one another. Thank you very much, colleagues. Good afternoon.
Okay, so on the line for this panel, we have Dr. Bridget Duprez, as well as Dr. Joanne that you just heard now, who was answering some of the questions. So I'm hoping that colleagues and the delegates are quite energetic to hear about this, because I'm honestly honored and I'm looking forward to learning a lot from our panelists, and also to answer the question that Dr. Matsabisa, Professor Matsabisa, why did I not even call you on this thing? Our host asked earlier on with regards to why do we drink tea? And now it's the time for us to learn why do we drink tea. And after this break, when you drink tea, you will drink it with the benefits of understanding what the session was bringing. So the session is titled The New Developments in Indigenous Health, Beverages, Infusion Industry. So we're going to learn about the developments that are happening in the Indigenous Health Indigenous Health Beverage in the infusion industry. So we're learning what the developments are, but the special focus will be on herbal teas. And what I wanted to point out is that this particular session is happening at a time where we've learned on what rooibos tea has accomplished so far. The rooibos industry earlier on this year, they've gotten to give and commit about 12 million rands to the Khoisan indigenous community since after the benefit sharing agreement was established. This was done simply because there was no clear acknowledgement of the community. And I think it was a great going of us understanding that that money would be used to benefit that community. And so we know rooibos is a native plant to South Africa and has enjoyed a global market. So with understanding of that, the fact that there is more herbal teas beyond rooibos, it's something that we as South African need to take good understanding and knowledge of to see what more benefits can be acquired, especially from those that are going to be from the panel, and see if there will be more global market that can be untapped with the teas that we have beyond what rooibos has achieved. And one of the exciting things that I want to mention before I start this is the new exciting partnership that we've read about earlier this month, that the DSI as well as the South African Rooibos Council have come to an agreement of having a total of 10 million rands that will be given to researchers to uncover even more health benefits. And these health benefits will be beyond us knowing that we drink rooibos, but we will learn the claims that rooibos tea has on a human health. And this is in the alleviation of diseases such as Alzheimer's, as well as inflammatory bowel syndrome, and some of the heart attack as well as blood pressure. So those are certain claims that we say rooibos has, but this research will help us prove that those claims are true. And I'm really happy that we have on our panel a high caliber of researchers as well as industry players that are in this market to make us understand what are the developments are. There's no one who's working on the rooibos tea, but I believe that Dr. Anne is going to get into it. One of the things that I want to first start with, I know I came here, I didn't introduce myself. My name is Dr. Puti Chilapa Mgobozi, and I represent an organization called the Innovation Hub, management company that is based in Pretoria. And we are an innovation catalyst for the Gauteng region. And we even go beyond Gauteng through partnerships such as Technology Innovation Agency, as well as the Department of Science and Innovation. And I have with me, I am an innovation specialist representing the bioeconomy unit at the organization. So I'm gonna just get started to request my panelists just to introduce what they do in 5 minutes, but I'm gonna ask those that have slides to also just come forward to present what they have, then we can get into the panel. So those that are gonna be introducing themselves, just do it in a period of 5 minutes with regards to what you do and with the title that you have. I'll start first with Dr. Celia Bester, just to tell us more regarding the Honeybush Tea platform. Dr. Celia Bester is a genetist, so she did her PhD in genetics, and she specializes in plant breeding as well as crop development, and she represents the Agricultural Research Council. Can you please just tell us more about the Honeybush Tree and Tea platform, Doctor? You can use the mic. Just move the slides.
Thank you for the introduction. Can you hear me? Yes. Oh, okay. And I must say I'm a proud COFSI. I did my PhD here, so I'm back here. Yes, I have a PhD in genetics, and I actually is a plant breeder, but that evolved totally in my past few years. As I'm not a plant breeder anymore, I'm now doing all the research in honeybush, pre-processing, starting from breeding, seed production, nurseries, the crop development, crop horticulture, how to cultivate it. That includes diseases and insects and all these kinds of things. And then the harvesting and irrigation. So I'm now totally, I don't know what I'm anymore. I think I end up at that master of none with all the kinds of jobs I'm in. And then what became very important the last couple of years is my involvement in the community development and the startups of small SMMEs, where I'm involved in 4 communities. Through my plant breeding that I developed a new selections that has higher yields, and the quality of the tea is more improved. And we know for the farmers, the more yield, the higher price they get. So that is where they're interested. So we've decided on how to commercialize our new breeding selections and next generation honeybush is through the SMMEs. So we have SMEs that have seed orchards to produce the seed that then is sold to the nurseries, and where we have 2 nursery SMEs, and then to cultivate it. So we have one community focusing specifically on the cultivating, but the seed orchards and the nursery guys also have plantations where they can harvest their own honeybush and sell it to the processors. And then I have colleagues at our institute in Stellenbosch that are focusing on the agro-processing, so I get involved there, although I don't understand always the chemical compounds and all these wonderful things. But we have Brigitte that will tell you a bit more about that. That was a student at the ARC with us. And like rooibos, we have also all these many health benefits. We know it has anti-diabetic and anti-cancerous and things. But our biggest problem is, and I think that is where many of our medicinal plants and indigenous knowledge is a problem, is to put it through the clinical trials. So although the research indicated, and we have tested it on mice, we can't put it on our products that it helps for diabetes or whatever. And that is where we get stuck, is to get that clinical trials, because that is where a lot of money is. And we also, honeybush is a small industry. We are about 2 years, there is a formal industry, but we are about 1/10 of rooibos. So, and we are exporting about 250 to 500 tons of tea to internationally, mostly to Germany and USA. So we are already there. I think we export 90% of our teas, and locally we don't sell it, so there's only a few people. That is where the honeybush grows in the Southern Cape, from Piketberg down the coast to near Ekkeberg. I still stick to Port Elizabeth, but I'm still trying. So you won't find it really located in Pretoria or Bloemfontein in the shops. So that is where we also need to get to work on. So there's still a lot of things we need to do. We have made progress. And I don't want to talk too much. They said no slides, but I can talk for hours without slides as well. The ABS, we are currently in negotiations with the Khoisan, also to get our ABS in place. But it is not that easy as it sounds, because to identify the different Khoi groups and who is involved and who has interest or the knowledge belongs to is not that easy. It's not like one community or one person. So it is, and because honeybush is also known for 300-400 years, in public domain, so it is more open as something that is not that well known. So yes, so I'm all over involved. So as I said, I have knowledge of a lot of things, but master of none at the end. Thank you.
Things, given the time as well as the passion that you represented, the work that you do. I understand that online, and I just want to say that I had a great discussion with Dr. Celia on just making me aware of many other things that are happening, especially with what you just mentioned. But I'm happy to even hear that even the work with the SMMEs are going on, which is quite impressive with the ARC and with Stellenbosch. Dr. Bridget, are you online for you to just give? I want to get started with the academics so that they can tell us all the great, excellent work before we start with our SMMEs. Dr. Bridget, are you able to
yes.
tell us more about your interest in the sensory research flavor? I'm not sure if you wanted your camera to be on. It's currently just showing a blank screen. But we can hear you quite well, which should not stop the discussion. Dr. Bridget is apparently was a student at the ARC, but she is coming from the University of Stellenbosch in the food science. So I think her passion is in food and aromas. So I'm glad that she's going to tell us more about that. Yeah, we can see your slides. You may go ahead, Dr. Bridget.
Thank you very much. Let me just start my PowerPoint. Good afternoon, everyone. Thank you for the opportunity to share what we are doing. Like Dr. Cecilia Bester mentioned, I completed my PhD end of 2020. My topic was to develop a honeybush grading system for the sensory quality grading system for the honeybush industry. And just to give you background, like Dr. Cecilia Bester mentioned, honeybush is an endemic South African fynbos scrub and grows on the sandy coastal plains and mountain slopes of the Western and Eastern Cape. And scientists have identified 23 Cyclopia species, unlike rooibos, who only has one species, and it's natural, caffeine-free. And the name honeybush is derived from the sweet honey-like scent of the plant when in full bloom. Traditionally, honeybush flowering time was also harvest time, so it was easily recognized in the veld due to its bright yellow flowers. But flowers, as research has shown, that the flowers are not essential for the characteristic sweet flavor and taste of honeybush tea. So who are we? So currently I'm working at the Sensory Research Facility at the Department of Food Science at Stellenbosch University. And the ARC, Infotech in Stellenbosch, conducts honeybush research in collaboration with Stellenbosch University. And so what do? We evaluate and characterize the sensory profile of different food products, but also indigenous herbal teas. We use the trained sensory panel with extensive experience in honeybush and rooibos sensory evaluation for more than 10 years to evaluate the different tea samples. And we have a large database of sensory profile of more than 500 samples of honeybush tea. So what is sensory quality? Sensory quality characteristics is important for the overall product quality. Honeybush and rooibos are listed on the ingredients list of the Tea Herbal Infusions Europe, and they state that appearance, aroma, flavor, taste, and mouthfeel are all important for overall product quality. So from research, we've based on our data, different research tools were developed, and the sensory profile of honeybush consists of the major aroma notes, that is woody, fynbos floral, fynbos sweet, and then also secondary aroma notes, fruity sweet, followed by apricot, raisin, and caramel. It has a characteristic sweet taste, which makes it such a popular beverage, and a slightly astringent mouthfeel, and characteristic red-brown color. So why is it important to do sensory research? It is important to develop communication and marketing tools, and also quality control tools for the industry to ensure that the product is consistent, to give industry role players like tea processors and quality control personnel the tools to describe the tea and to see whether the tea is of poor or superior quality. Sensory research is also done, like we mentioned, in collaboration for ARC honeybush breeding and horticultural program, and also for processing and product research. So at the present, there's no standardized sensory quality criteria and assessment methods to evaluate honeybush tea. Tea of variable sensory quality is reaching the market, and the South African Export Control also makes no provision for sensory quality. And consistent quality, as you all know, is key to growing consumers' confidence in a product. And the trade of inconsistent and inferior quality could be detrimental to the success of an industry like honeybush and any other indigenous teas. So essentially quality, one of the outcomes of my research project was to develop a quality scorecard that has also been further developed to be an app that the industry can use. And it is user-friendly. It can be used for record keeping, for marketing, for batch blending, and it provides the whole honeybush value chain the tools to ultimately ensure that a product of good quality reaches the end consumer. And yeah, just for those of you that want to take some notes, there are a lot of research currently done on honeybush in collab by the ARC, and you can welcome to visit their website as well as the South African Honeybush Association website for more information on honeybush. Thank you.
Thank you so much, Dr. Bridget, for that enlightening and more. Can you hear me? Okay. A more elaborate work that you do with regards to the flavor and aroma enhancement at University of Stellenbosch. I'm gonna call our host of this meeting to come also to give us more information on the teas that he gave us a bit of insight on in his initial presentation, and Professor Motlalepula Matsavisa, who is the host and is a director as well as a professor at the pharmacology. I don't know if I need to go into it, but Department of Pharmacology, as well as the AMIDT platform that they showed the great work that they do. So without further ado, Prof, I know that you have slides. You can just come forth and just give us more information. So he will be presenting on the Ibran tea stories and asking us to drink tea for a reason.
Thank you so much. Yeah.
Should I engage with them?
Yes, please. I'll just do this. And I'll feel more comfortable if they start talking.
Yeah, because I don't want to waste time in the slides, I'm just going to ask perhaps Ms. Mokete Sekete to tell us about the Sela brand tea in the meanwhile, while we're working on the slide.
Okay. Should I start? Okay. I don't know if it's good afternoon or good morning. I do not have a fancy title before my name. It's just Mokete Sekete. So my background is actually in marketing. So a lot of this, the conversations I'm hearing around the room, for me have been, over the last while, have been very eye-opening in terms of some hurdles we have in the industry and some great work that's been done in the industry. So my background is in marketing. I've worked for about, call it 10 years in FMCG. I then moved into nutraceuticals. And this is where I came in touch with African traditional herbs. During that time as well, I lost my father to probably a heart attack or a stroke. And he was taking African traditional herbs, and I was not in the position to support his journey with African traditional herbs. And I feel like my life has come full circle just through my career. And this is where I find myself in the last 4 months with Sunpack. Sunpack is generally an FMCG company who is an agency for international brands, and they market them locally. And I've joined the team to drive their traditional medicine division. And I look after Sela tea. Now, Sela tea is a very basic tea. It's a rooibos base, and in some of our other teas, we do have a black tea infused. And then we've added African traditional herbs to the formulations. And this is to help people with ailments that they possibly have. And for me, what I love about the tea is the stories that we get and the testimonials that we get about our product, you know, how it's helped, how it fits in with their lifestyles. You know, it's not to say it's to replace certain things and certain good habits that one needs to kind of apply in terms of their lives, but it's really how our tea fits in the bigger life span. Yes, we are mainly in the tea space at the moment, but we're a brand that wants to grow, that wants to expand into other, you know, categories within the market. We have vast conversations with, you know, our points of distribution in our retail sector. And the conversations that we're having is that African traditional herbs are important. And at least that is starting to be recognized by our retail partners. Even last week, we were down in Cape Town and meeting some of them, and some of the stuff that we're working on from an MPD perspective, they're like, we want to list it now, you know, so at least the excitement is there. And the excitement for me, at least from my perspective and what I've experienced of it, is also the migration of people into a headspace of wanting a more natural delivery in terms of what they put in their bodies from a supplementation perspective. A lot of the stuff we take are very synthetic and in terms of absorption and how it goes through your system. And delivering it through something natural like a tea makes the product really, really user-friendly. Hence, we find that people are looking for our kind of product in a retail market. So Sela is really just about offering the consumer an affordable product that is effective and that is also easy to consume. So they don't have to go through figuring out how to mix this with that and all of that. So we've already done that. We've already given them the instructions in terms of how to take it, when to take it. And yeah, so I'm just looking forward to growing the brand. I've been with the company for 4 months now. So looking forward to grow the brand, and yeah, and of course, having some opinions from you guys about the product. We have it downstairs, so when you have a chance, please come visit our stand. Thanks.
So much for that, Mokete. I think what I love also was the story that you told, and I think what question that I might want, maybe many of the audience will have, is just understanding the strategy that Sela Tea brand had with regards to what they have in the communities and your relationship with the indigenous communities with regards to that brand. But I don't want to waste any more time. But let me, before I go to you, Prof, I just want to go to also the next panelist, who is Mam Nondumiso Patla, who is representing Sitsong Tea brand that is coming from Sikukuni. So we call her the Zulu woman who makes the Pedi tea. And quite an interesting story that she has. But just tell us more about the Sikukuni tea story and how you benefited that community, Mam Nondumiso.
Afternoon, everybody. I'm Nondumiso Phahla. You can hear from the differentiation of my name and my surname, half Zulu and half Pedi. I'm choosing this afternoon, Madam Chair, to rather capture the milestones of what brings Sejong Tea Crafters here where we are, because I think we've been narrating the story, and the story is also written all over our website. So allow me this afternoon just to share the milestones that are bringing us to the level of commercialization today. So I'm a founder and a mentor of Sejong Tea Crafters, coming from the nursing profession, which I left 20 years ago, and followed a mission of my passion, which has been for the past 20 years. The past 10 years has been the years that I'm not gonna forget, because it took me back to my in-laws. Pedi people are so strong, they can call you from far, even if you think you're gonna neglect them. So I found myself wanting, and I'm honoring Mam Dora, who's amongst us, who held me by hands and took me back to the villages of Sikukune, back to my in-laws. The milestones that we have gone through was to firstly do community mobilization in these two rural community villages, which is Rapahla and Mahamatlala Ramshibo, and put them together. Community mobilization, doing asset community development, analyzing their needs, so that they can feel that they are fully part of the journey, opposed to us just coming and impose our ideas. That's what actually helped us to understand the culture of Bapedi, that it can be used as a socio-economic upliftment platform or a social enterprise. We had to work with them the first 3 years, just developing behavior character that is suitable for socio-economic upliftment. You know, our communities have got so many dynamics and challenges, which some of them have been highlighted here. So grouping these two communities has taken the passion from myself and my children, who saw that I'm desperate and I didn't have resources to do this. So we just gave and surrendered ourselves to incubate and support the Bapedi women. Our targets then, as we were emerging, became traditional healers who are in the community, traditional leaders, as well as youth and women and men. I want to say men, because the stereotype is that we are always focusing on women, and you ask yourself, who's gonna marry our youngsters? And then youth. The youth that we targeted at first was the advantaged youth that's gonna help us to travel this journey. The second phase was to establish a clear mentorship and coaching a path that we're gonna walk together. We were not in a hurry. I'm a Makoti here. I want to stay here and find my grave here. So the second level was a mobilization of stakeholders, investors and partners and incubators. In that process, then we had already identified 2 teas that we are seeing outside, the Dipanit Black Bush tea and a red root tea, which is called Dia, because these women were secretively drinking this tea alone for ages. And you could see the character, the behavior, the energy that they have, beautiful skins, you know, industrious and very little diseases with the elders of the community. You hear old women and men who are pleading to die because they have lived too much. So those are kind of things that, as a primary healthcare nurse, opened my eyes. That's something that we can pick up here. And amongst all other solutions, we pick up the teas. To fast forward, then when we mobilized the stakeholders, we knocked at different doors of science, including SABS, your CEDA, your ARC, DSI, your CSIR. I was just all over telling the story of Bapedi as a Makoti. And I was amazed with the attitude of the professionals as they were hearing the story. And I was always carrying my basket on my side to say, there is something that we're gonna learn here. And they opened doors, they did analysis of the teas, and then they actually prioritized this project because it had everything that the government need. It had all elderly community members, it had women, it has youth, it had people with disabilities as well. So we then fast forward move to establish our value chain management, which talks to harvesting up to grinding processes and packaging and blending of these teas, as you're gonna learn as you visit our stand. We moved from there we were lucky to find GIZ, Germans, to accompany us to do access benefit sharing, which we have signed with 2 communities for the 2 different products. We had to learn all that, biodiversity acts and all that in our journey. Lastly, with our aggressive youth, they took the teas, blend them, brand them so that they suit the cultural perspective of Bapedi people. And then it has taken us to e-commerce, branding. We have, with all the programs that South Africa has today, we have traveled the world from Russia down to Botswana, back to South Africa, and I participate in different platforms of big expos that the country and partners provide. So I just want to say this is becoming a true story with Tia here saying now we can commercialize, and with DSI and ARC replanting plants and also rebuilding a facility for the rural women in Skukune. And we are inviting you to come and enjoy our agritourism as well. Thank you.
Thank you. That definitely deserves a round of applause. What a story indeed. And should I mention that she is by profession a healthcare practitioner who was a nurse before she joined the Bapedi. So welcome to our culture, ma'am. And we really appreciate the work that you did to the community. And what I also I'm interested in these milestones that you are even potentially reaching, and the fact that you've tapped into the scientific backing for the work in terms of the safety data is there, but now the health benefits. Those are the things that we need to just establish and get even more benefits and even, greater benefits out of the Stepani tree from Sekhukhune. And we really appreciate the work you've done. And now I'm going to call you, Prof, once again to just come expand more on those tea infusions that you told us about earlier. Thanks.
Thank you so much. I'll see Puti. I think what we are really trying to do are 2 things. One is to get the communities, build up a community enterprise that would be then sustainable to supply the markets. What also we want to do is then to position those community teas as herbal, health teas. So I know that people interchangeably use the word, tea and infusion. And to position that, I think, many tea drinkers are in the East. And they would then, tend to use the word infusion. I don't know, I was told to press something here and it will not explode. So that's fine. But I think what I want to talk to you about is the work that we do with communities in the Eastern Cape, communities in the Northwest. And the journey is very simple journey to say, put in, these teas into the formal markets and ensure that there is, constant supply. Because one of the challenges, with Africa and us is you start off and you then cannot sustain, the supply. That's where the problem is. So now why do we talk about drinking a tea with a purpose? It's very simple that, if we were to position these teas, now I can't remember this thing, if we were to position these teas, it's not moving. Or is it this one? Oh, there we go. Now, I brought this one up simply because everybody thinks teas are different. And I think when I started, I said, but all the teas come from a tree called Camellia sinensis, and which is that big tree. So if that tree is not maintained, it grows into something like that. But when you go to a tea plantation, you find it to be like that, simply because they keep it at that level. That level is important so that you don't bend, you don't do that. So that's the message. The differences between Joko, 5 Roses, and whatever, it's really how they process it into the red tea. Okay? So if you keep it like that, you go and you say, to my mother, I would say, oh, I like, go and buy me Chinese green tea. It is that tree, okay? They've done nothing to it, dried it, and then supplied it to you as a Chinese green tea. Okay, go and buy Joko. It is that tree, except that they've done what you call oxidation to it to make it a red tea, but it's actually the same tree. So that's how marketers really fool us. Okay, but I think in essence, what we then, did, with those communities, we approached them to say we need a health benefit. So we did a number of scientific tests to look at the safety, to look at your nutritional content, to look at your health benefits, and more importantly, what we picked up was the issue of caffeine, that all those teas were caffeine-free. Now, our interest was then to find substitute. Were people tired of Five Roses? Were people tired of, rooibos or things like that? Could there be new entrants to the market? And that's, what we want to do. So that was the scheme in terms of the science, but at the bottom, I'll tell you where those teas come from. So we did everything from safety, health benefits, health support, as well as your nutritional content. So where do these teas come from? Quickly. We brand them as I-brand. I think that's a brand that came in. Why I-brand? I for Indigenous, I for Infinity. So you'd always see them branded as the I-brand. So the first tea, that's Molucha. And I'll show you the health benefits that we have proven. It comes from the northwest in a village called, Mohula. And then second to that, they've got another tea called Croton Gratissimus. Also, it's a very good tea, also coming from the same community. Close by to the community, they also have another tea called Musukujani. And a lot of people have heard about Musukujani. There are so many. Musukujani is a leap year. I was in the DRC. They had a leap year tea. I was in Brazzaville. They had a leap year tree. All these leap years seem to be, into the tea. And then in the Eastern Cape, near, Alice, then we have those teas. We gave them names because sometimes, when you want to go and send your child to a shop to buy something, you don't want a complicated name like Amakatekiwa. You need something nice when you send them to a shop to say, and then it's something that sticks. So they then gave, those names, and I'll explain the names. And then again, in Chachongo, we were there, last week with ARC Agriculture, because they are putting in money into that. So also, that's another tea. Let's quickly run through that. These are some of the communities. They've organized themselves, into cooperatives, into SMMEs, and a lot of, women are driving, those teas. Not to say that men are helpless, but they're very good in talking. So we started off, making up those cuttings. We have two, agricultural, specialists in my group. They are, in fact, moving towards those communities to do agricultural, planting. They're putting up the irrigation system because we realize that we cannot continuously go into the wild to harvest this if you want to be serious, about the markets. So you need to grow them so that you know the quality of these teas. I'll run through that. This is the science, behind some of those. So we know everything about those teas in terms of, cytotoxicity, toxicology. We gave these, to monkeys at around 40 times what a human being could drink. Those monkeys were happy, that means those teas were not toxic. So you can drink as much as you can. But also more importantly was, also doing a study on drug interactions, that if I'm a diabetic, I'm on my metformin, will these teas not interfere, I think, with my medicines. And we actually shown that, in fact, you can drink those teas with any other medicine, they will not interfere. That is very important, because you don't want to drink something and then in the end it starts interfering with your other medications. But then I think what were also the health supporting studies, they could be very supportive in terms of your hypertension. We have shown that, I think, in the science, they could be supportive in terms of your diabetes. In fact, if you were to look at it now, you've got calls from people in Cape Town and Lesotho who are diabetics, hypertensive. They want these teas. We don't sell them. We just give them because we are collecting, I think, as much information as you can. Anyone who has got, I think, constipation now, please tell me. We'll give you one tea with 1 cup. We guarantee you that is going to go away forever. That's how confident we are in terms of the science that we have put into that tea. We're not marketing it. We're actually saying we can back up, I think, the claims that we are putting onto those teas. I showed you these pictures, but I think what I want you to show you quickly is where are we now, in terms of, these teas. This is, I think, on tomorrow. So the staff are actually taking 3,000 of those cuttings that they have done to the communities into their greenhouses, so that in the end, they would then put these out onto, I think, outside onto the irrigation. They are ready to be planted. But we then, I think, from there thought we needed to then formalize this thing. We needed to have businesses, communities. So this was, I think, last week. This is a new project where now, together with the engineers and the architects and everybody, we were now going to start putting up infrastructure at that site for, I think, the people in the Eastern Cape. It's another site in the Eastern Cape. We got some money from, I think, rural development to expedite, I think, that process. So they gave us money and said, by March, we want to see that there is something happening there. But what we have done, I think this was some of the work. I think, people were talking about exhibitions. I think we've been everywhere. South Korea at the bottom there, Mepahla, these were the young nurses, from South Korea. They just loved those teas. So we were then given an N, and said, here in South Korea, we don't just show people, we actually make them taste it. So they gave us a big N and we started cooking. So these are some of my stuff. We started actually making those teas. So South Korea has fallen in love, I think, with those teas. The same as, I think, Jamaica. We were in Jamaica. We did the same thing. We sent these also, I think, to the US. And there is a huge market for that. And I will talk to you about it. But more importantly, again, I think this was, I think, in Zimbabwe at the time, and again, I think there was an interest. Where are we? So when we start moving, towards closing, I think Germany. I will talk about Germany and what they want us to do. Where are we in terms of these teas? People's Republic of China. We've just signed an agreement with them. Tongreng, they are huge tea lovers. And they would really want to take up some of these, I think, teas. Now, what are the needs? This is what when we sent, this is a company that is interested in the US. So they gave us and said, I think, please send us, I think, your, MSDS. We need to know that. So we had to develop, I think, these aspects if we needed to get into the international market. And through that science, we never had a challenge with the FDA to get those teas across America. So they quickly just went through because we completed all, I think, what industry needs in terms of showing the safety and showing, I think, what needs to be there. So quickly, yeah, I'm done. We did a number of, I think, publications. So if you want to find what we have done in terms of the health benefits, lots of those publications. I think the last one came in, I think, this month, where we are actually comparing those teas with the available teas onto the market in terms of their nutritional content. So that we did also your compare it. But I will not say anything. Yeah. But I think those were the publications. Now we came up, I think, for the I'm done. We came up with a sketch to say what infrastructure do you need to put on the communities? And this infrastructure, in fact, we have completed one, community site in the Eastern Cape. This is where, near Alice, that infrastructure, in fact, is completed. It has been handed over, to us. That's where, in fact, the staff are going to now do the layout for the irrigation and, your whatever, cultivation. So this is the site. So it will be launched early next year. It's complete with furniture. It's complete, I think, with equipment that they need to do. We have written up some SOPs in terms of how they would then handle the material coming in there. So we have now, hence why we have started moving to the next site, in Fort Malan and then also in the Northwest to replicate those, sites, because we have now learned to say, how then do you build a community site to support the commercial cultivation of these teas so that in the end we will be able to have constant supply, to your buyers. You don't want to put in a product onto the market and then next time when people don't find it, they always go and find substitutes immediately. And once people fallen in love with a substitute, they'll never go back to that product. So we don't want to have something like that to keep a hype onto the, the market, and we don't supply. In last, we have just also signed, I think, quickly, a very big, I think, agreement with another company on these teas. Now, on the sides there, we show you the proven health benefits, and I've just summarized them up here, that when you drink those teas, these are the things that you are going to get. And we did this summary because the pharmacist wanted to say, when people come in here, give us something that will help us to be able to say, this one is good for that one is good for that. And that's what we prepared, that summary for each and every one of those teas in terms of what benefits you could have. Thank you so much. I took 1 minute of your time. Thank you.
I'll accept that. A round of applause. So I had to give him some time because he knows very well that I said 5 minutes, so it did not translate very well, but I forgive you. But great, interesting story, Prof. I think the community at the Eastern Cape are lucky to have you support them. And I'm also happy to say we've met those communities also through the Innovation Hub with what we do, but I really would go into that tomorrow. I just want to encourage the audience. I know that I'm standing between you and your lunch, and most of you are panicking to go get your teas. I'm going to ask that you start preparing questions as I ask the last panel speaker to kind of give us her insights if you have any questions. So on the panel, we still have Dr. Joanne that you just had earlier on the last panel who answered a question, who is a patent attorney representing Edward Nathan Sonneberg, and she's like the head of biotech and life science cluster. I believe that she's one of the people that played a key role in this benefit sharing agreement that was addressed with the Khoisan people. And I'm happy to have you, Dr. Joanne. If you can hear me, please just talk. I see the slides still on the screen. I'm not sure if I can end the slideshow in any way, so that she can start. Oh, there she is. We can see you now. I need you to just tell us more about the benefit sharing and commercialization of IKS-based technologies, and just also go into any complications that perhaps you had with the Khoisan in establishing that benefit sharing agreement. Can you hear me?
Thanks very much. I can. I think there might be a bit of a misunderstanding. I was not involved in the Khoisan arrangement at all. I am a patent attorney at Edward Nathan Sonnenberg's, and I do head up the IP Life Sciences group. And so although I have assisted a number of clients in the sort of bioprospecting space, I'm afraid I can't claim to have had anything to do with the rooibos case at all. So, I mean, other than what is kind of publicly knowledge, I don't really have any additional insights into that. I think maybe where I can provide a little bit more value is to say, as part of my role at ENS, and just to let you know, ENS is a full service law firm. So we have a lot of clients that are international corporates who do business in South Africa, as well as South African corporate clients. And so our corporate and commercial group and our regulatory group often will approach me with clients that are working on mergers and acquisitions, or are looking at license agreements for other things where there's an intellectual property component, and where there is some sort of indigenous biological resource involved, or possibly traditional knowledge, they'll reach out to me to assist with that aspect of it. I've actually also done quite a bit of work with some of the universities, including the University of the Free State, on some of the aspects around culture collections at the university. So you'll often find that universities have microorganism, whether it's yeast or bacterial, whatever, culture collections, and those are often accessed and used subsequent. They might be very old culture collections, and they're often used subsequent to the Indaba provisions coming into effect in 2004. And so, often, and in fact, the bioprospecting provisions in 2008. And so there's often a question as to, what do you do there where you've got this existing culture collection, which predates Indaba, but, the products are now being used. And they're potentially going to be processed to make further medicaments and that sort of thing. So those sorts of questions often come to me. And I think the overarching challenges that I have experienced with most of my clients has been, I think, first of all, very often there's a lack of understanding in terms of what's actually required. So a lot of people don't even realize actually that bioprospecting is an issue, and that there are legislation in South Africa that deals with that. So a lot of what I do is in fact education of clients to make them understand that if they are involved in that space, that there are some of these requirements that need to be looked at. And I think that's one of the places where a lot more education and awareness could perhaps be put in place for this sector. I think then the second issue that people are faced once they understand that this is something that they need to do is it just understanding at what stage they need to do what part of the process. Where do we go from a notification stage to a bioprospecting stage in terms of requiring an actual permit application to be applied for? And I tend to advise relatively conservatively that, as soon as you're starting to do any of this sort of research, it's a good idea to get your notifications in. And as soon as you think that there might be something that is commercializable, or if you start to file patent applications that are going into a complete phase, that you think quite soon about your bioprospecting requirements. So as soon as possible, really. I mean, even while you're doing the notification stage, it's really important to start looking at how one can negotiate and get an understanding and a relationship with the stakeholders that are involved. With regards to the sort of pure material transfer agreement access provisions, that tends to be relatively simple. It's often a kind of payment based on a quantity of a material that is provided. Whereas in the case of traditional knowledge, it obviously becomes a little bit more complex. And there's always a difficult discussion to decide exactly what kind of benefits are going to be fair and equitable. It's particularly difficult in the health space because, when you are having to get your bioprospecting permit application in and do those agreements, and particularly if it's a foreign entity that's doing the research, where you actually have to get the material transfer and benefit sharing agreements in place early on, it's a real challenge to identify at that early stage exactly how best to deal with the benefit sharing. And so I think in terms of the Rooibos study, one of the real benefits there was the fact that you have this consolidated benefit sharing agreement, which just kind of simplified things across the board and provided for a consolidated way to provide funding to the communities that are involved through the trust. And so I think those sorts of things would be very useful for other industries where there is a large number of community involvement and a large amount of access to those sorts of resources and that sort of knowledge where commercialization is happening. So, I mean, hopefully the Rooibos teaching, I guess you could say, is going to be something that's going to be used down the line in terms of benefit sharing going forward for a lot of those products. I think that's probably all I really needed to say. I know we're also running out of time. So, I mean, I think perhaps, as I say, just in terms of lessons learned, I think one of the biggest things that we can do if we are experienced in this field is making our knowledge available to people who maybe are not quite as experienced, because there's an awful lot of commercialization happening in this space. And I think a lot of the information is just not reaching where it needs to reach. So thanks.
Thank you so much for that elaboration and also accepting the correction that you were not involved, but I believe that you have quite a lot of knowledge regarding that. Thank you so much for clarifying that and also the benefit that this benefit sharing has had and could have to the tea pipeline that we have to was achieved with Rooibos. I'm just going to request if there is anyone who has a question to just raise their hand. I'll ask someone to kind of bring the mic to you. And while we start with engaging our panelists. But the first person perhaps that I can ask the question is to start with you, Ms. Mogedi. I know I didn't introduce you quite well since we started, who you are a general manager at SunPark, as you mentioned. I need to know the strategy. I know that Stellar Tea is currently at various markets. I mean, ShopRite, Clicks, Discam, all sorts. And it's something that we know was achieved, I believe, in a short space of time due to the branding that you've had. Just give us perhaps a strategy that can be used and also your work with the communities and how that came into place with SunPark. Thanks.
Okay. So the brand has been with SunPark for about 6 months. Okay, so still fairly new with the business that I'm in. The general brand itself has been around for 7 years. So what SunPark has done has basically fully inherited the system of manufacturing from the previous owners into how we manufacture our products. Basically what that means is that we basically use third-party manufacturers. So we don't go source the materials ourselves. We don't, we don't currently have those kinds of interactions that I think are quite important as well in terms of driving the brand forward. However, that being said, we do not see our future just here in terms of what you see. We see ourselves growing. At the end of the day, we are a business. We want to grow. We want to start tapping into different categories within the market. I do not see why and I loved the work that Prof. Matabisa here is doing, in the immune space and, in the tea space and all sorts. How do we not have products, natural African products in these different categories? And I think there is definitely a need in that space. So in order to do that, we are also consciously aware that we need partners to get there, but partners with the knowledge. And this is the journey that we're embarking on, and hence our presence here today is in terms of how do we start cultivating or start entrenching ourselves into knowledge platforms or organizations that have already done the work that we can partner with in terms of taking our strategies going forward. However, in terms of the strategy of commercialization and getting it into store, that's always a tricky one. Because you walk into a Discam, you walk into a Clicks, they'll ask you for a listing fee for one product, 200,000 down on the table, for one product. That's even before you start doing promotions, ads, et cetera, et cetera, et cetera. So really high investment in terms of marketing these products. But because the company has a history with these companies and with these retailers, it makes us easy when we go into meetings with other products and we go into the table and we come with an offering, with a table of offerings. It's asking for shelf space, it's investing the money, but importantly is also to promote the product within the space. Otherwise, then the consumer doesn't know it, you don't drive it off shelf, all you do is just pack the shelves with a lot of product and it doesn't move.
Wow, thank you so much. Really, really exciting. I keep taking notes because I came here with with the intention of learning, and it's also just good that we can take notes with how that was done. I actually want to just quickly go to you, Dr. Cecilia, with regards to our conversation that we had during lunch. We spoke about the challenges that honeybush tea has. I think the complications that do exist, but I just also need to maybe to just run us into that in terms of, I had a scientific question with regards to the conservation of the plant as well as improving the yield, but maybe you can just quickly get into the challenges with the honeybush tree that you mentioned, with the benefit sharing problem that you had with the communities that you mentioned.
Okay, yeah.
So this is honeybush versus rooibos or any other tea that's there. And if there's any question, please do raise your hand. Okay, I notice 3. I'm going to take
okay, sorry. The question, yeah, it is, as I said, we are smaller as rooibos, but we're probably also just as long known as the honeybush, rooibos guys. We have also the ABS sharing. And we have, especially, it is the push for ABS sharing is coming from Europe, because if they buy indigenous or plants or products with indigenous knowledge without ABS sharing, they are getting in the trouble because of the Nagoya Protocol. So they are pushing us to get these ABS in place, otherwise they don't want to buy our products. So, but our problem now is like with the rooibos, it's very local in one area. But with the honeybush growing over a widespread area, it is various communities and quite widespread. Then also 80% of the product is still wild harvested and not cultivated. So, so that we have a lot of people, wild harvesters, that go into the wild and harvest. So, and to get a koi, you know, currently they are all in fight. Who is koi and who not? We just have that case in Cape Town that the guy said, this area belongs to me and to my forefathers, and then they said, but you are a fake. You know, and that is what now also happened, you know, everybody is now jumping and trying to get some benefits. So that is now where the problem comes, to identify the correct people who must benefit in the end with that. But we have, luckily, government is involved in this and leading this negotiation, so that we are not alone. And the lady who have done the rooibos is helping us with the honeybush. So she have her lesson she's learned, she can implement now with the honeybush. Thank you.
Thank you so much. Thank you, and also that particular collaborations, because I think we can go far when we are together. And thanks for that. I need to just quickly go through the questions. All the questions can be asked, so we can have one round of answers from the panelists. I noted him. And
good day, everyone. I'm Tabiso Khwedi. I'm a PhD student in religion studies. I just want to pose this question to the speakers. When the knowledge of indigenous traditional herbs was handed to us, the motive was to preserve life for our people. And then now, let us take one scenario. Last time I took my boy to this traditional healer, she charged me 5 rand to heal the boy. So then now, here you are, you come with this lot of science into our thing. And then now commercializing it, are you not gonna sell us to the foreign countries as it happened in the past? Because then now they are bringing in too many things into our thing, and then they are charging extra amount, and then they're gonna benefit out of our own skills, out of our own knowledge, and then our people are gonna be suffering till and till. So that's the question I'm posing to the speaker. Sorry.
Thank you. Thank you. We captured your question, and I'm gonna request you, Prof. Mazabisa, to note that question when it comes to you, and maybe we'll go to the next one. So I guess you're talking about biopiracy as well as the taking of this, the risk of taking the traditional thing into science, but I will have that be addressed. Can I have the mic? Oh, yeah, there you go.
Good afternoon. My name is Tando Gama. I'm a master's student in pharmacology. I have a question for, I think, Dr. Dupreez. And it's, so COVID has been reported to affect the smell and taste senses. So I want to know, how has this affected your research with regards to the aroma and the taste sensory research?
Thank you. I hope you heard that. Dr. Dupreez will come to you to answer that as we conclude. We're asking the last question from, there is a gentleman. Okay, we can go to him and then we come back to Mr. Maleho.
Yeah, my name is Jabu Stone. I think the question goes to Prof. I assume that the people are having in Alice, it's rural community. I'm working with township economy. You know, I empower young people, talk to them into manufacturing. So would you and your team, Prof, allow those township young men that I'm talking to contract package some of your product and give it a different name, but being produced by your team?
Thank you. I will go to the last question from Mr. Tsietsi Maleho.
My name is Tsietsi Maleho. I'm from the Innovation Hub Management Company. My question is to the lady from Seller. I believe you said that they are suppliers for your product. Basic question, what are the conditions required to become a supplier?
Okay, noted. Thank you so much. I'm going to ask Prof to start with the answer of both the two questions that came through, then we'll come to you, Ms. Mogete, quickly. Yeah, just be as quick as possible, because, yeah, I think we need to be out of here.
Thank you so much, Puti. I need to go back to that question so that I get clarity, but Ndade Jabu, the model is very simple, you know, because even I think, you know, the companies that we are getting into commercialization agreements with, they are talking about, you know, rebranding, okay? We had one company that is keen to say we want to buy bulk and we want to rebrand. And I think, you know, our office had no issue with that. As long as I think what we said, if we could have some indication, some of India brands, where these teas come from. That was very important for us to have that indication. But we had a model, and I want to put it up straight here, that we are doing this for the communities, you know. So whatever we're doing, we're empowering them. So the model was very simple, that the communities themselves could be trained and sell to whoever in bulk, okay? But because we cannot put tea bag making machines and all that, you know, in all the communities, for those branded products, then the university could come and assist them, you know, to package them. So if you have, I think, you know, your communities and they want to rebrand, I think, you know, those products, I don't think it's going to be an issue, because that's something that we've already discussed, I think, within the communities. That's something we've already been discussing with these big companies that actually say, we want to buy bulk, we want to rebrand, but also we want to blend them. And I think the opportunities are there. We should not be too possessive and kill ourselves. I always believe that over-regulation, you know, sometimes kill. So we can talk about that, okay? Ndate, kibang tsirizo, tabiso, hari bue ka Sotho mona, ono reng?
Ke hlalosa hore
Yeah, okay.
Of scientific validation into these traditional herbs, whilst they could be biopiracy by the Western medicine into what we do. How are we managing that?
Okay.
Prof, a se yona ke buileng e.
Okay.
Nna ke re mongaka,
Thank
this
you.
calling ya rona ya the knowledge of traditional healing and alles, it was brought to us to preserve life, okay, to extend the longevity of life. And then it was at the lowest cost. And then I even gave the example that I took my child to Sangoma last week. She charged 5 rand. So now that you are bringing too many things towards our calling, they're gonna benefit from our own skill. They're gonna sell and package our own thing at their own prices. So now it is moving away from us to them. So it's gonna benefit there. And normal Sangoma from my location will not benefit in any way, because then now his or her budget or thinking will go to others, as it happened last time with other things. I don't want to go there.
You're correct.
Okay, all right. No, thank you so much. But I think, when I started in the morning, now I just bring it back. I said the knowledge holders, the traditional healers voluntarily come. And I asked a simple question: why do you want us to test your medicine? And the answer would be, I want it to be in the clinics, I want it to be everywhere, I think in the hospitals. That's what they want. They want economic emancipation, okay? They want to benefit out of that. Hence, our laws are now out there to protect them, okay? So the aspect of biopiracy, I think, if we move on, it's very difficult now for anybody to do biopiracy, because the laws are there to protect. I think, the lawyer there was talking about, your NIMBA Act, that when you disclose, if ME discloses, it has to be in a formal, way. When you bring your knowledge to us, we sit down, we tell you what we can do, we tell you what we cannot do, we agree with you what needs to be done, and we put that into writing, so that in the end, we have the same expectations in terms of what we are going to be achieving in the end. But also the other thing, what I believe in, the work that I've been doing with the healers, we never say, then because you are working with us, stop everything that you are doing. We don't do that. You can still continue, to do the practice that you are doing. In fact, the only little thing that we don't want is now you go along and market yourself using our name. Oh, that we don't like. But you can continue doing whatever you are doing, when we sell these things. There are people that would still prefer to say, I still wanted that traditional medicine, hakibati that capsule. So the options are there. Mulao, I think there's the National Environmental Management Act. It also talks about the aspect, bioprospecting and biopiracy. And therefore, everybody gets protected. We just say to our communities, if you don't understand, please go and ask, but also just be careful, to just dish out, or receive money because someone is promising you money. I'll give you a simple example. I was working with one healer, Meputi. We got 1 million rand for the research from the National Research Foundation. The healer says to me, Natema Savisa, you can take the knowledge, just give me 1 million rand, I'll get out of here, I'm gone. And I said, no, that money is not for that. That money is for us to do the research. So you need to also empower and educate the healers so that they understand. We don't buy the knowledge. We're not buying the knowledge. In fact, we're adding value to that knowledge for your own benefit. Thank you.
The traditional healer can make way more than 5 rand because he can reach a person like me to increase the baggage of money that they have. But then we can just continue with the last answer from you, Ms. Sel, and then we'll come to you, Dr. Dupreez. Ms. Mokete first, and then we'll go to...
Okay, cool. So the question was how to become a supplier. We work with our manufacturers quite closely. So we're happy to have those engagements, particularly linked to our NPD pipeline in terms of where we want to take the brand going forward. I'm particularly interested in those types of partnerships for those ingredients of that pipeline. Thanks.
Thank you so much. Quickly, if you can just answer that question, Dr. Dupreez, so we can understand the effect of COVID-19 on the question that was asked.
Yes, thank you for the question. Fortunately, it did not affect me myself in terms of my taste and aroma perception. However, research at the sensory lab was could not be conducted specifically in the first few months during the lockdown. We were, yeah.
All right, thank you so much. Okay, are you fine?
Yes, there, yeah, that's fine. Yeah.
All right, thanks, Dr. Bridget. I think the last question that I just want to put to Ma'am Nondumiso is just with regards to, we heard about the milestone, but just give us a concluding remark on this panel discussion with regards to what you've, last time I know it was at Food Lovers Market, but there's actually more, the export that you've had, like just talk about where it is, because I know there's lots of potential with the Tapani tree, the Tapani tea that you also made at Sakakukuni. Just tell us the expansion of your export that you've reached, like the countries that you are selling to, and yeah, the benefits, because we know about the benefits that it has to the community.
Yes, thank you. We are not yet in the countries. We were doing market research in different countries. The breakthrough is local. We are supplying quite a number of outlets now, including, we first started at home, Kalapeng Pharmacy, which has got quite a number of outlets. And then from there, we are supplying some private spas. We are supplying independent distributors. We are supplying organic grocery markets. You're going to see all these things on our website. But the last breakthrough that makes us feel confident that we are fully going into commercialization is when we won an award, a seed award with Food Lovers, where we're going to be supplying 60 outlets, the whole country. We are also expanding our our product range, which is all going to be at Food Lovers in February. We are going to be having iced teas, about 4 flavors of iced teas. We are packaging tea bags of different ranges that is suiting the same blends that you're going to be tasting down there. So the breakthroughs are also, the big breakthrough is that we are mobilizing youngsters now to be promoters. We are expanding our job creation range to say young people gonna distribute these teas and be promoters in different outlets. So at the moment, we are standing, just for interest sake, we're standing at 30 people are in the forefront of the ownership of this product. Mam Dora is a chairperson of such. So they are the ones who are then mobilizing their communities for expansion of employment. But in all different stages, communities are coming forward. They are owning this project, and all those who have visited us to confirm what I'm saying, it's very exciting. There is great. In 3 weeks ago, we did an interview of all the members who are in the leadership of Sejong. They are so confident. They've stayed. Nevertheless, there was no much money. They are affirming their commitment in owning this wealth that God has given to them. I thank you.
Thank you so much. And I think with that, I really just want to thank our panelists, and also just a message to say that I think with all these developments as well as activities, we see quite a great potential into developing into and understanding the health benefits that are currently said to be claims. There is a potential to develop a pharmaceutical product out of these trees, and that obviously aligning with the clinical trials that need to be done. So I just want to just lay the ground that we are really at the low-hanging fruits by using the teas as our first start to getting to use the understanding of the health benefits onto this, and making sure that this health infusion industry grows even further beyond what it's currently at. And really, the pipeline of teas that we have in indigenous communities, there is a long way to go. So with that, I just want to thank you all for your patience and for me standing in between your lunch, and also all the questions and the engagements that we had. I would like to end the session. Thank you so much.
I see that there are some colleagues who are outside. Maybe we should give them a minute or 2 to 3 minutes to get settled so that we can start, just to avoid the disruption when we have already started, as they will be coming in. Okay, I think we are ready to start. Maybe I must introduce myself first. My name is Vuisile Hobololo. I work at the Technology Innovation Agency as the head of the Indigenous Knowledge Systems Business Unit. In our programs, we've got Dr. Stephanie Kaywood, I think was scheduled to facilitate this session, so I will facilitate instead, because she's not available. So the title of this panel, or the focus, is Indigenous Knowledge-Based Cosmeceuticals. I will start with, maybe I will briefly introduce them, but they will have an opportunity to say, who they are in greater detail. I think the first panelist on the far right or left, it's Mr. Jabustone. I think he needs very little introduction. He has managed to establish a giant of a brand in hair care. And second to him, we have Dr. Pehano, who is based at the University of the Free State. And we have Mr. Trenton, who is a director and a co-founder of the Chiba Cannabis Academy, which is an academy really that focuses on training, training within the cannabis space of businesses, training of startup companies, incubation, and even acceleration. But they will tell us more about what they do when we give them that opportunity. Then we have Ms. Kaylee Adams, who's an entrepreneur and the sole director of a company called Shanti Natural Care. She's based in the Western Cape around Mammelsbury. So she manufactures a range of products. Really, it's a cosmetic range. So it includes indigenous plants such as buchu, and some includes rooibos. But maybe I must say that the common thread, when we put together this panel, each one of them, the work that they shall be discussing this afternoon talks to the cannabis industry. So even though Rajab has got a wide range of products, but also I think with time he tapped into cannabis infused a product range, and that is the good part, I think, of this discussion. So even Ms. Adams, what she's doing in her SME or small enterprise is that she's manufacturing and commercializing these products that are cannabis or CBD infused. And Mr. Siboto and Mr. Trenton, as I mentioned, that they're from the Chiba Cannabis Academy. So their work really talks to training, really, and empowerment of startups or businesses in the cannabis industry. So I will ask, I think there will be a combination, ladies and gentlemen, in the form of which the colleagues or our panelists should be presenting their information. I think for Mr. Stone, he's got a clip that he would want us to play at the beginning, and then from there we shall be able to have a discussion. And I think Dr. Behano has prepared a presentation which he shall give as PowerPoint slides. And the other colleagues have not prepared presentations, but we shall take questions and we shall have a discussion. But we would like it to be as interactive as possible. So you are free to take notes as we go through this discussion and also to participate and raise your own questions to them so that it's empowering for everyone who is in the room. Thank you. So I'll ask to start off that we have the clip from the Jabulstone clip. If you could play that for us, and then from there we can take the conversation. It's a very short clip. Okay, our technical team told us that I think our colleagues who are joined via live stream might not hear the audio of the clip, but I think for the benefit of the colleagues who are in the room, we should be able to hear that, and then but they should be able to join in the discussion. Thank you.
How would he feel?
Okay, thank you. That is a very inspiring story of the success of the Jabulstone brand. Maybe I think just to start off the conversation, Mr. Stone, I think one of the questions that I always have when we look at your story, and what we always, will never cease to salute you for, is that people who wanted to enter the job market, about 20 years and even longer ago, there was a certain attitude that corporate South Africa had towards the hairstyle that we now say is dreadlocks. There was a lot of negativity attached to it. When people were called for job interviews, it's either they had to cut their hair, or if they were employed, they were told that it was conditional, to their employment, that they would have to rethink the kind of hairstyle that they had. And even in religious spaces, in churches, if you identified yourself with certain faiths and thought dreadlocks were an appropriate hairstyle, your genuineness as one of those in that faith, would be questioned, because there was a lot of negativity associated with dreadlocks. And that's why I'm saying that beyond the commercial success that Jabulstone has, but he has managed, to diffuse a lot of these stereotypes and be able to allow black people to embrace, their true identity and the genetics of the hair that God gave them. So for that, Prajabu, we never cease to salute, the work that you have done in this space. But this is the first question that I have, to you, that to any aspiring SMME or entrepreneur, I'll make an example. For example, the other day we did a site visit to Miss Kaylee Adams' place at Shanti Natural Care, and she manufactures hair products, and she's doing actually quite very well. She has been able to start and do what she's doing, and she's selling quite a lot, and it's cannabis-infused products, but we shall talk to her when we get to her. But when you started selling the Jabulstone products, were you manufacturing these from the garage like most entrepreneurs do? Or when you started selling these products already, when there was a Jabulstone, a trademark, it was stuff that came out of a GMP facility? So, or if that was not the case, if you started in a garage like everybody else, how then was that transition? How did you navigate? How did you move from that person who cooked these products at home, in their kitchen, or in their garage, if you did, to actually where you are now?
Good afternoon, ladies and gentlemen. Yeah, thank you for the introduction. Congratulations for getting into manufacturing. As earlier I've mentioned to Prof that I mentor young people in the township, pushing the township economy, to make sure that they get into the mainstream of manufacturing. Like any young person, I was young then, 30 years ago when I started. And I saw the need. But when I started, there was no demand. But I'm not a chemist, But all I did is I asked Prof earlier on, I went to a qualified chemist, somebody who was mixing the product already. So what I did, I gave the person a brief. This is the kind of product I'm looking for. I'm looking for a product that when you twist towards a certain direction, must hold. And at the same time, after you shampoo the hair, because your scalp produces natural oils, but once you use harsh shampoos, you strip. Now, I needed a product that will add moisture on that. So I gave the chemist a brief, and then immediately he developed a formulation out of my brief. And that's how we started. And then from there, you do the tests, testing the product, and when I saw that I'm comfortable, then the next step was access to market. But remember, when I started the locks, it was not fashionable. As it was associated by all those negative, ganja smoking, nobody wanted to be associated with it. And, the salons refused, the shops refused to keep the product, and the men on the street. So then I used celebrity endorsement. Nowadays you've got your social media influencing and everything, but now I used your celebrate, like your people like Abo Hot Sticks Mabuze, people like Abo Lawrence Dube. So those are the people that I used, So for them to, I would go to their houses and make sure that I take care of their hair. But the biggest challenge again was the shelves. The guys refused to keep the product. They said, but we can't keep the product. Nobody's asking for this product. What do I do? Then that's when I had to go back, to the drawing board. But now I've got the product, it's developed, it's working, it's tested, I'm happy with it. But now I want the product to be on the shelf because I don't want people all the time, they said, I need the product, then I must get it from the boot of my car. Then I had to send my friends to Curtains, the shop in Small Street, to go and ask for Jabuston product, knowing that it's not there, you know. So now Curtains realized that all of a sudden people are looking for the product. Then he called me, then I put 6 units. After 6 units, I look for a gondola. I don't know whether a gondola is, you see, when you go into the store, you find maybe your Ricoffee or Oros right in front. It's called, you pay for that. So I had that for free from Curtains. So immediately the other issue was the salons who refused to, because remember the salon, they amplify the usage of the product. Now I had a problem because none of them wanted to use the product. That's when I started renting chairs in different salons to make sure whoever is looking for the service will get it. So it was like, so it was not easy, but as you go along, but fortunately, it was the first entry advantage because I was the first one in the market and it gave me, you know, an advantage. But marketing all the time, not stopping, you know, getting involved in Miss Soweto, all the beauty contests within the communities, but make sure that the name is out there. But after that, fortunately, now we are in all the chain stores in the continent, we're even in the US. Thank you very much.
Thanks, Mr. Stone. I want to emphasize, ladies and gentlemen, that, you know, what he's saying when he talks about the story of using celebrity endorsements, this is something that the Jabstone brand did long before the era of social media. So what we say is influencers today, when people take pictures and they post them somewhere, I mean, it's the same concept that the Jabstone brand was able to build itself on, to be able to it's just one of the very important building blocks, I think, to what we see today. But I just want to ask a question quickly, maybe the last one on this subject, Mr. Stone, that in your own view and how you've seen the cosmetics or beauty industry work, have you seen, would you say, to what extent does the role of influencers or role of celebrity endorsement take brands forward? For example, have you seen products that are not that good, for example, or just by virtue of being carried by certain figures or celebrities doing very well, or products that are quite, you know, good and innovative, that are backed by science, that are backed by all these things, you know, that we seek to do, not being able to get very far because maybe that part of the equation was missing?
Yeah, I think the influencers, they play a big role. You know, somebody will sit there and start shampooing the hair and apply this product. The next thing, once that, I mean, it goes everywhere, you know. And after that, the people will say, I want that product. But the issue is distribution. Where are they going to get the product? You know, so the whole thing, you have to get an influencer, but you have to back it up with the distribution as well. And also educating as well. You must continue to educate the market as well. So I think the influencers, they play a very, very important role.
Okay. Thanks, Mr. Stone. I think I will move to our colleagues from Chiba, Chiba Cannabis Academy. As I said, that they are involved in the space of, they are a training institution, so their contribution to the cannabis industry is that of training. So but I just want to ask a question to them, which will allow them maybe to tell us more about what they're doing. And the question is, from your understanding of the space in South Africa, the cannabis enterprise, as it were, what do you think is required insofar as training, and how has that informed how you've structured your training interventions? For example, what you're offering at different levels. What do you offer to businesses that want to enter into the space, or to businesses that are in the space, and what informs that? So, Trenton or Linda, any of you, I think I'll give you an opportunity each to say something.
I can start with that. So first of all, I have a fairly strong marketing background, and whenever I've dealt with brands, one of the things that we always make sure is that you have an LMS and location, and you have your target market. But when people ask us what our target market is as educators for cannabis, for the first time in my life, I have to say everybody. We have students on our campus that are 18 all the way up to 55 years of age. I believe in the next 10 years there will not be a single person that any of us know that do not use cannabis in some way. And that doesn't mean smoking joints and hitting bongs, but just from the creams and oils and everything to do with the whole plant is completely mind-blowing. But I want to say so we teach the whole spectrum, all the way from making hemp bricks, all the way up to the business and the metrics of cannabis, commercial cultivation. We also teach doctors as well about medical cannabis. But I think one thing that I just want to leave in terms of the context of this space, I think this event is so important at this time and this juncture in our country. We have a crisis economically after COVID. We need every bit of help we can get. And plant medicine, I believe, is the future. It's complicated because we are under the grip of big pharma who dominate the medical industry, and plant medicine is probably the most disruptive and biggest threat to their business model, since they started. I want to say a few things. First of all, cannabis was the first drug to ever have come to market because of us, the people. Most things you take in the pharmaceutical space have been given to us, but we as the people, as the population, have driven the agenda of cannabis becoming legal. The other things I want to just touch on quickly are that we must be very careful, and it was mentioned earlier, the word biopiracy. So on a genetic level with our landrace strains, many of them have already been stolen by internationals. We cannot allow the same to happen to our other plant medicine. We also cannot allow plant medicine to be captured by corporate and capitalists who want to make as much money as possible out of it, because these plants have come from the ground, from many, many years of indigenous knowledge systems and people who have worked hard to make sure that those plants have been kept in our systems. And that is one of the biggest battles we are going to have at the moment, is making sure that SMMEs have the opportunity to enter the market. Distribution is a massive challenge, as somebody mentioned earlier, 200,000 Rand to get listed in Discam. We have been captured by corporate, and I really hope one of the things that we push for, we often say we're not a cannabis or an education company. We are trying to drive positive change, and plant medicine has such potential to help our economy and to help a lot of people on the ground. So that's just a bit of about the ethos, and I'll just let Linda just talk about more of what you actually do on a practical level.
Thanks, Trenton. So I'm Ulinda Siboto. I know that surname sometimes makes people get a bit shocked, but Ngusboto, Ikamalam, so please don't mind me. I'm one of the co-founders and directors at Chiba Cannabis Academy. The holding company is Chiba Africa, and we have a campus out in Rivonia, where Untate has visited there and seeing what we do there. And essentially what our focus is around teaching students around the full value chain of the cannabis industry. So we don't necessarily specialize in just the agricultural aspect of cannabis. We literally focus on everything, because we believe that at this point in juncture, as we are developing the industry, we need generalists, not really specialists at the moment, because we're also not too sure as to what's happening with the legislation. And so what we do is we enable our students to be dexterous in terms of their approach within the industry, and also be able to offer what they want to offer within the legality of the spectrum. Just in context of this group, I mean, we have medical training that we offer. We've partnered up with a medical company in America called Medical Marijuana 411. So they're FDA approved, the citations. I mean, America's been doing this for 20 years in terms of the medical research. But it's also very pleasant to hear that there's a lot of research being done. So there's potential partnerships that I think that can be realized here also from an African point of view. But most of the content that we get for Medical Marijuana 411 is then stripped back, and then we put in this African information, history, prohibition, etc. And we also have this course, which has been accredited by the Health Practitioners Council of South Africa. So there's CPD points for health practitioners out there who want to do that. We've also partnered up with a company called Carol's Oil. They've been treating people with cannabis for the last 15 years. So they've got a lot of knowledge that they've developed, and also products that they offer to their clientele. And a lot of doctors also refer their patients to them when the patients are basically at death's bed. So it's very important for us to have people who are offering practical training, which doctors can then utilize in their practices. We're also accredited by the CETAs, agriculture, and with services CETA. We took the services CETA as our primary CETA, because we wanted to focus on the industrialization of this industry because it is coming online. So we can't just focus on agriculture, we need to focus on how we industrialize. And also listening to a lot of what's been spoken here, I'm just in such awe what's happening here in the University of Free State in terms of getting research, and then from research, packaging, distribution. This is what this country needs. You know, universities shouldn't be places of these ivory towers where people get knowledge and PhDs and that's it, you know, and write white papers and what do we do with that afterwards? But actually having tangible community development and impact is definitely in line with what we're doing currently. Our students are currently doing a process called Canadian, where they're doing a presentation on their businesses that they've created, having been spent 12 weeks with us in our campus. So now they're going to look at realizing that with the network that we have created for them. Also, I think another important thing, I mean, for me personally, both my parents died from cancer. My mom from breast cancer, my father from prostate cancer. And I think to go back to your question, because that's what you asked, is that there's a huge knowledge gap in terms of what's offered for people to utilize in order to help rehabilitate people who are on chemo, people who have severe cancers. We're still in the dark in terms of what medically can be prescribed. I wish I knew what I knew today for my parents, because I think the outcome could have been a lot different. And just to add also, to give respect to the context of where I am, my great-great-grandfather was, as my father used to put it, a muti man. He was our shaman within our village. And the fact that I'm here and hearing how there's a coalesce between, you know, the traditional leaders and traditional practitioners, and then also with the pharmaceutical people and pharmacology, gives me great hope that definitely we're going to reach a point where our people are going to be able to access this knowledge in a formalized way, in a safe way of engagement. And then I think I'll just break away and just say that thank you so much for this opportunity, for being here. And just one more thing. My father, who passed away, was the first acetabular fracture specialist in Africa, meaning hip fracture specialist. And for him to have died from a disease that could have been cured is the reason why I'm in this industry. And when I don't want any other parents to have to let go of their parents, or any children have to let go of their parents in spite of ignorance of not knowing that already the cure is here, but it's just that we need to get it to the people. Thank you.
Wow. Thanks, Mr. Sabot. Let me just, before I move to the next panelist, go back to Mr. Stone. Just the last question. It's just a question that comes to mind, Mr. Stone, that when you had an established range, a very wide range of products that has been there for time, like for quite some time, what then caused you in the recent years, for example, to try to add cannabis infused products, because we've seen that you've diversified, you know, in that area. What sparked the interest, and how has the reception been?
Yeah, actually, we always talk to our customers. You know, we understand their challenges, so we realize that, you know, a lot of them find that the hair is falling, receding hairline, you know, because of tension when they braid, or when they've got locks, you know, continuous styling. Now, we realized that then we made a research as well in terms of in the cannabis side. And then we realized we use the sativa oil, you know, in our product. So it kind of, you know, once the product is applied, kind of activates, it's got some kind of active ingredients as well, you know, my understanding. So kind of allow the hair not to fall and to keep that moist all the time. So in the cannabis space, we are not stopping, you know. We are making more research to find out what else can we bring, because earlier on, our discussion lunchtime, you know, the issue of, I find women at the age of 25 years old, they can't walk with their hair because they've got receding hairline. The hair starts from far, and they are embarrassed, you know. So they come back to me and say, Babu Jabu, what can I do? You know, so that is why the platforms like these, you know, it's very, I mean, for me, it's very helpful, because I'll be able to interact with the researchers, the developers, the professors, everybody involved. So we can develop something to help my sisters out there. And then, since I am in the market, then I can take it out there and commercialize it, you know. So platform like this, that is why I say I'm very excited to be here.
we will have Dr. Behanu last because you have the presentation. So we will, so I have a question for, or two, for Ms. Kylie Adams. As I had said when we introduced her, that she's an SMME called Shanti Natural Care. So she is involved in manufacturing and selling of a number of cosmetics or personal care products that are cannabis infused or CBD infused. This is the question that we have for you, Ms. Adams. What has it taken for you, as a small company, 100% woman-owned, 100% youth-owned, to have been able to make the kind of progress that you have insofar as distribution of your, just formulating and distributing your product to the extent that you have done, even though currently your product is not manufactured in a GMP facility, but is manufactured at home. When we look at your clientele and how wide you are able to distribute this to directly, there are many people that you distribute to nationwide. You are also able to have, I think we have an e-store where you, what has it taken for you to be able to get there? That's number one. Number two, what challenges would you say have you experienced, and what support do you think companies, establishments like yourself need to be able to go to the next level? For example, what hindrances, for example, that you think you have to be able to enter, other markets, maybe foreign markets, or even to distribute yourself even much wider within South Africa?
Hi, good afternoon, and thank you so much for having me. I would first like to say thank you. It's an immense privilege to share the stage with you guys and represent myself as also just a regular person that's into the natural product space, but also as a mother and as a woman and also as an entrepreneur. I think this is a perfect opportunity to explain my journey with my business. Of course, when I left school, I decided I was going to attend university. And I studied, of course, for 5 years in the field of natural sciences. After finishing university, I decided to, of course, enroll for employment, meaningful employment. And at the time, everyone knows the struggles of the youth. We study for many years, only to find out that there's no job opportunities for us in the field that we chose. At the time, in 2008 and 2009, there was no such thing as cannabis. There was no such thing as formalizing indigenous-based knowledge or using natural products as like your everyday use. And so that also inspired us to start our brand. We in a rural area on the West Coast, which also allowed us to tap into fynbos such as rooibos and buchu, which also forms a lot of our properties in our products. And with the recent legalization or the legislation changes in the cannabis industry, and also being practicing Rastafarians, we thought this was the opportunity for us to kind of step into that role naturally as people of the faith, and also of people that believes in the natural products. And so I decided to, of course, reach out to companies such as Cedar, firstly, as a SMME, to see this any assistance from their side. From then, I, of course, started to formulate my products over a period of 4 years. And so currently, right now, like Mr. Bio-Trade said, we're quite informal, but through assistance of Cedar, CSIR, and TIA, we've now slowly moved to product development, R&D, and also getting ready for export readiness. So for me, this was a perfect opportunity to share my story and to let you guys know the innovations that's also taking place in the cannabis industry and what things are happening. One of the major challenges that I faced as a SMME, firstly with regulation and compliance, because I want to be taken seriously as an SMME, as an entrepreneur, I experienced lots of red tape. And so I also found it key to associate myself with different organizations to kind of gain that credibility in the space. And so hence I met Mr. Bio-Trade, which also led me to understand my role as a small business. When I started, I thought, okay, I'm just creating natural products and I'm selling it to people. But as I got in the industry, I realized, but my role's in manufacturing, it's in training and development, it's in technology. And so this has actually broadened my trajectory as a business to a point now where I'm not anymore a mentee, but I'm a mentor. So slowly we also giving back, we're developing other small businesses, advising other companies like myself that's pioneering kind of this industry, because there's not much people that's kind of doing what we're doing, and also with the support that's kind of lacking currently in the industry. So I just want to say thank you again for having me and allowing us to be part of this panel and to share our story. Thank you so much.
Okay, thanks, ladies and gentlemen. I think we will take questions from the floor at this stage. Then when we've taken questions based on these presentations that we've had or the discussion that we've had, we'll give over to Dr. Beanu, then he'll give his presentation, and then thereafter we can have questions that will talk to that. So at this stage, we'll take the questions, if there are any questions from the floor to any of our panelists. Okay, looks like there are no questions. If there are no questions, Dr. Beanu, you can give us your presentation. Okay, there's one. Is that the only one? Okay, so I think let's give him
it's quite an honor to meet you. So, Linda, basically, not that I want to take your patent or something. How do you basically manufacture the products? Example.
So it started out with formulations, of course, doing like research of like what type of products I want to create. So I focus a lot on topicals. So it's very important that when you work with cannabis or CBD, especially I use CBD, it's actually the delivery method. Sometimes people think that cannabis works on its own, CBD works on its own, THC works on its own. But I feel like from a science background, it allowed me to kind of formulate the products based on the delivery method that I wanted to use. So it was important for me if I was creating something for the skin, I would do research on the skin firstly, what benefits the skin, the type of, say, natural essential oils, carriers to use. And then that actually I created over 4 years, and it's always improving. So when you're creating products, it's very important that you understand firstly what you want to treat, the skin area you want to treat, and also the delivery method, because CBD cannot work on its own. You need a delivery method to actually take the CBD and the healing to where it needs to be. So it's actually about research and research.
Thank you. Okay, I think there's another hand.
Good afternoon. I'm Pombonani from the Innovation Hub. So my question goes out to Brastones. I would like to understand, how did you make it in America? Like, how did you break through? And what were the challenges, and what is it that you can share, especially for those that are interested in also trying to export to the American market?
Yeah, thank you for that question. Yeah, like any other market, the market in America, you know, my target was more the African Americans. And because we're a delegation going to sell South Africa as a brand. So when we were there, what I did, I went to Harlem to meet the salons. And when we traveled to like New York, Chicago, Atlanta, so I made sure that I go to the salons to understand how the market works there. Then I realized that they were natural hair, but they were enhancing, they were moving away from chemicals. Fortunately, coming from the continent, it was a plus for me, you know, so with the research that we've done as well. So to get into the market, but like here, it's challenges to penetrate the, you know, your chain stores there. But fortunately, because, you know, like you have to find out you create relationships with the people that are there, that are in that market, in the same space as yours. So that was very easy for me. So I created a working relationship with them. And then we ended up, of course, sending the product on the other side, and then we started distributing them.
Questions, colleagues? Okay, I think in the absence. Okay, there's one.
Thank you. My name is Mohadi Fafodi, also known as Daphne. I come from SAPRA. So when you're speaking about formulations, that includes patients, patient safety, the quality, and the efficacy is very key. So I just want to find out, because we do have what I love about South Africa is that we've got very strong research institutions. So which research institutions are supporting the work that, because you speak about various formulations, and topical can be very easily administered through the bloodstream. So we need to make sure that our people are protected, especially the vulnerable, because those are the ones at the receiving end. Thank you.
Okay, thanks. Thanks, ma'am. That's well noted. Maybe we must mention that also, I think Shanti Natural Care is part of the cannabis incubation program that. Yes. So the program that she's part of is being implemented by the CSRR and other players of government, and they are. And the value that they're adding, I think, to the work that she's been doing talks particularly, to the issues that you're raising.
Thanks so much for that statement, man. I feel like as a SMME, that was one of my main challenges, is actually taking the next step and seeing how I actually get accredited as a business, because since I started, we had to work with Sakosa, we had to work with Wesgrow, we've had to work with various institutions just to get firstly compliant with packaging, and then the next step for us now is with CSIR in the incubation program for hemp and cannabis, which will allow us to tap actually into the scientific support as well as the technical and the clinical trials. So I feel like that's what's going to happen now with our brand. Thank you so much.
Okay, I think in the interest of time, and also.
Sorry, Daddy, can I just have just one question? So I have a question from the panel. Thank you, Sis Daphne, for raising question. I just wanted to raise a question through to SAPRA, because as a cannabis community, we really feel like we're at loggerheads with your organization. How do you envisage us working together? Because we're on the ground, we're working with the people, you're up there in SAPRA's offices, obviously abiding by regulation, but how do we get to a point where we can actually work together towards the common good for the community in South Africa?
Thank you. The mandate of our regulatory authority is safety, quality, and efficacy, to ensure that all health products that are in the market have got proven safety for patients. You don't want a patient to take a headache pill only to lose one liver that they have. So that is our responsibility. And one thing for sure is we are actively participating in all the fora that are relating to cannabis. One thing we are, because remember, we need to also differentiate who are the role players. We are involved in medical and scientific. Anything outside, it's not our mandate. And in that mandate, we engage with various stakeholders. We are currently engaging with the presidency on matters of enabling. But when you are enabling, you cannot enable at the expense of life. So that's what we are saying, to say that that's why we are mentioning the research institutions. There's a lot of permits that SAPRA has issued to our research and we continue doing that. Prof has got quite a number of them. So hence we are saying who is supporting you. Because if people are making claims, advertising that these are the magic miracles, medical miracles that cannabis has got, however, there is no supporting evidence to that. We are misinforming the public. Hence, we are saying work with the experts so that our patients can be safe. We've got Section 21, we've got registration, and as I'm saying, all the policy making is not SAPRA's position. We enact the law, but we participate in information sharing and also getting information. Thank you.
Mr. Spoto, I think the next panel will have a SAPRA representative. And I think yourself and I think the whole audience will have an opportunity, I think, to raise any question you might have towards SAPRA, even though the discussion will really be around clinical trials. I think let's give over to Dr. Peano. He will be talking about the interesting work that he has done, scientific work on wound healing properties of cannabis.
Thank you, Kaut. Good afternoon, everybody. I'm Gavra Mariam Brahanu, a postdoctoral fellow and in pharmacology under Professor Matavisa. I'm a pharmacist by profession, and I'm interested on formulation development from natural products or from traditional medicines. Basically, currently I'm working with development of two traditionally used medicines, bluebeam fructose and cannabis sativa extract loaded with hydrogen wind dressings. So, in the coming few minutes, I'll try to address why we choose this topic and what we are doing following this outline. So, when it comes to the introduction, let's see every one of us in our life. At one time in our life, we have some kind of food. Whether it's accidental, whether while you are playing somewhere, or whether while we are cooking somewhere in the kitchen, or because of several accidents like car accident and so on. But unlike the other chronic communicable and non-communicable diseases, wound is a bit neglected, and the research on wound are less compared with other chronic, both communicable and non-communicable diseases. So in spite of the impact that it has on the society, it has unrecognized various impacts. Wound has physical, mental, and social impacts on the society. So a study done in Europe in 2016 showed that almost around 2 million people are living with chronic wound across the Europe. And when out of that, 1 in 287 people are living in wound worldwide. And when it comes to the SA, chronic wound affects more than 8.3 million people. And the annual expenditure on chronic wound reaches to $65 million. Even the prevalence of people suffering from chronic wound is still increasing. And the trend is similar in Africa, especially in South Africa, because there are some factors that will cause increase in prevalence of wound. We'll come to that. So these are some of the factors that will increase the risk of developing chronic wound and delayed wound healing in most countries. The first is age. When the age grows up, especially, most people over 65 years develops one kind of wound in their age. Smokers are more prevalent for wound than non-smokers. Obesity is the other factor, and chronic diseases like HIV and diabetes are the most common causes for developing chronic wounds and delay in wound healing. If you see HIV patients, almost near 90% of all the people infected with HIV develop some kind of infection or wound infection in their life, like herpes zoster, Kaposi sarcoma, and thrush in their life. And a WHO report 2012 indicated that 5 risk skin conditions were also among the 15 leading causes of death worldwide. So there are various therapies currently in the market for wind treatment, but none of them are effective for treating completely all kind of wounds. So there is a drawback of all those wound treatments like topical agents, topical dressings, topical antibiotics, and oral antibiotics or systemic antibiotics. All of them do not give a guarantee to adequately heal, and recurrences more frequent in wound. So there is a need for improvement of chronic wound treatment, and a scientist should focus finding a new treatment modality for chronic and acute wounds. Moreover, skin and soft tissue infection caused by Moreover, cause of skin and soft tissue infection caused by medical drug resistance. Bacteria such as methicillin-resistant staphylococcus are a source of ever-increasing mortality, which cannot be treated by the currently available oral or systemic antibiotics. So although antibiotics can be used to control these infections, the problem is the development of antimicrobial resistance, which is a major challenge for the scientific community. So we are working to avoid that. Therefore, the search for better antibacterial tests has become a topic of great interest in wound healing. So medicinal plants used for wound healing and skin disease are a key to unlock the doors to combat antibacterial resistance are raised in wound healing, and the incorporation of therapeutic agents into wound dressing and their release at the wound site is very interesting and currently research area, because if you see marketable products for wound healing, none of them have drug releasing impact on the local area. None of them have a drug incorporated inside them, but we are working on that now using different plants, especially bluebeam fruit juices and cannabis crude extracts. So there are currently wound dressings like gauze and bandages. However, they have a drawbacks because they have unsatisfactory hemostatic performance for arterial rupture and wound with irregular deep narrow shapes. They need long-term treatment. They cannot heal the wound within a short period of time. So the time required to heal from using these bandages and gauzes is longer compared with the one that we are designing. They are dry. They will cause irritation to the wound area. But the one we are designing or we are planning is not dry, we'll see. And they will easily adhere to the desiccated wound surface that will cause difficult to remove them from the wound surface. But our hydrogels will not have that. Require to be surgically and mechanically removed from the damaged area, so that will cause a serious secondary damage to the patients to remove them. But when we come to our formulation, what we are planning to do, these are the hydrogels. The picture of hydrogels are liquid, this one. Unlike the bandages and the goods, they are transparent. They are made from three-dimensional network cross-linked polymers composed of water-insoluble chain with high affinity for aqueous media. They are not dry. We'll come to that. They have hydrophilic porous structure that permits massive degree of water absorption, nearly 10 to 99 times the dry weight of the polymers in the hydrogels. And these are the ideal properties that makes hydrogels most promising for wound healing application compared with the available wound products in the market. They are non-toxic. They are biocompatible and biodegradable because most of the hydrogels are made from natural or synthetic, non-toxic, biodegradable polymers that are available around us. They are high water content. Water is very important at a moderate level for wound healing because it has major roles at various stages of wound healing. We'll come to that. They are soft texture and transparent. They are soft, unlike that one. They will not cause irritation to the wound site, and they are transparent, easy to monitor the change in wound site from time to time. They swell and diswell behavior. When the wound have high exudates, they will suck and swell. But if the wound is dry, they will diswell. We can make stimuli responsive potential interactive in natural. That means we can make stimuli responsive hydrogels by incorporating different nanoparticles or by choosing different polymers that can release the drug based on the environmental influence, depending upon the pH of the wound site, or depending upon the change in temperature at the wound site, or depending upon light, or depending upon some external stimuli like magnetic force. They can deliver the therapeutic agent control it at the wind site. That is very important. None of the currently available wind healing materials have this property. We load the drug on the dressings, and the dressings will sustainably release the drug until complete healing of the wound. They are non-adhesive, unlike the gauze and the bandages, so they will not have an impact, sticky impact on the wound site, and they are not difficult to remove after the recovery, or they are not difficult to change. They are malleable, that means the shape can be changed, and they are low cost compared with that. They are not expensive as we think, because we can make the hydrogels from natural or synthetic polymers that are around us, and the main thing, they have remarkable potential to absorb wind oxidates and allow oxygen diffusion, because these are very important for wind healing. And currently, the hydrogels are applicable not only in wind healing, they are used, a lot of research has been done on various areas using hydrogels, like in tissue engineering, drug delivery, and mainly in agriculture. So these are the ideal properties that a wind healing material should meet, and the properties that the unique properties that hydrogels have. That is why we are planning, or we are designing to prepare hydrogels compared with the previous ones. And we choose certain natural products like bluebean fruitaceae and cannabis. You know, we have a reason why we choose these plants. There are several reasons why we choose these traditional herbs. Majorly, the first one is bluebean fruitaceae, which is an indigenous plant in South Africa, which is found only in South Africa, and it is traditionally used for treating different wounds in various regions of South Africa. If you go to the north, the Eastern Cape, the Northwest, and so on, many traditional healers used this bluebean fruitaceae, especially jelly-like juice from the plant is used for the treatment of various skin conditions. And it's locally called stick bluebean, snake flower, cat's tail, burn jelly plant, and so on. Maybe most of the South Africans may know this plant. This plant is very important for ecologically. And the juice from this plant, the leaf of this plant, has various applications for the skin. For example, it can be used for the treatment of burns, rashes, insect bites, cracked lips, acne, body scars, cold sores, mouth ulcers, and cracked areas of the skin can be treated by using this one. So, because the leaf, as a study indicated, a phytochemical study indicated, the leaf is rich of many phytochemicals which are very important for this pharmacological activity. Mainly it contains anthraquinones, flavonoids, terpenes, saponins, tannins, alkaloids, and phenol. Of this, some of them have the pharmacological properties that we need for their wind healing effect. For example, tannins, terpenes have antioxidant effect, flavonoids are antibacterial and anti-inflammatory effect, alkaloids are antioxidant. These are very important for wind healing. That's why we determined to choose to load the leaf extract of this plant into our hydrogels. However, research is limited in South Africa using this bluebean fruitaceae for various skin applications. Especially, there is no hydrogel in South African market that contains bluebean fruitaceae for wind healing application. So that is why we are planning to develop a novel hydrogel that can release bluebean fruitaceae in the wood side. The second plant that we select is obvious. I cannot say more about cannabis because there are a lot of experts about cannabis here around me. But these are some of the few reasons that I chose cannabis for my formulation study. If you see cannabis, there are more than 565 constituents. Of that, 120 are phytocannabinoids. So most of the researchers obviously focus around these phytocannabinoids. Mostly THC and CBD are the ones that were extensively studied by different scientists across the world. But we are not working only on phytocannabinoids or the other constituents. We'll work on the crude drug, because in the crude drug there are more than, in addition to this phytocannabinoids, there are more than 445 another phytoconstituents, of which there are some constituents that have important pharmacological effect for wind healing activity. And also, if you see limorously stated, they indicated the role of cannabinoids in skin problems, including skin cancer, acne, pruritus, dermatitis, and so on, including pain and wind healing. So, but SAFRA doesn't have yet any official cannabis containing hydrogel in the market. I haven't seen any registered medicine in SAFRA, especially cannabis loaded hydrogels for various spinal applications, specifically for wound healing. Therefore, we are planning to prepare another hydrogel that can release cannabis extracts as the wound site for the treatment of various wounds. So these are the aims. Obviously, the aim is to reduce cannabis or blueprint loaded hydrogels for the treatment of various wounds in the South African market. Hopefully, we'll do that within the coming, me and my team in pharmacology will do that within the coming 1 to 2 years. So when we come to the objectives, you have two phases. The first is discovery development or clinical research. So in this case, we'll prepare blueprint processes or cannabis-loaded hydrogels using different methods. We already did some prototype hydrogels. Unfortunately, I don't have it in my hand, but it is in the department. You can see it. So we'll prepare that. Then we'll determine the critical quality attributes of this drug, because we need to have a scientific proof about the physicochemical property and the biological property of the hydrogels that can release either of cannabis or blueberry fruitances. And then we'll evaluate the in vitro antimicrobial and wound healing potential of the hydrogels using different assays. And then we'll evaluate the wound healing potential of the hydrogels using animal models in collaboration with the veterinary medicine unit of the UFS. And secondly, we'll do clinical trials to determine the safety and efficacy of the hydrogels. Then what comes is pharmaceutical development to characterize the critical process parameters that will affect the quality and the consistency of the hydrogels that we're going to prepare. And we'll request a regulatory approval from SAFRA, and we'll do post-marketing safety monitoring. Where we are now, we have done something from this project. First, we have submitted the proposal to RIMS, and feedback was received from RIMS unit, and we are working on that. But unfortunately, one of our collaborators from the veterinary unit has resigned from the work. That makes a problem for us. I hope Prob will find someone who will work with us. And we are mobilizing some resources which are important for the development of the hydrogels. Obviously, we have all the chemicals in our hand, and we made some prototypes, but still we need some instruments outside of the pharmacology department. We already approached different departments in EFS, from chemistry and physics, microbiology. Hopefully we'll go that. And we prepare some hydrogels, which are prototypes using two kind of polymer combinations, and some of my colleagues know that. And we are creating a collaboration because it's a teamwork. The team in pharmacology, we have a team in pharmacology. We are working this thing in team, but that might not be enough. So we'll work this because it's interdisciplinary work. It's a drug development process. So we'll work with some physicians like dermatologists, microbiologists, veterinarians, chemists we'll need. So we'll work on that. And finally, as a conclusion, I can say that within the coming few years, we'll see some hydrogels that can release these herbal products for the treatment of various wounds. And with that, I will end my presentation. Thank you.
Yeah. Thanks a lot, Dr. Piano, for your inspiring presentation. But we will just want to give opportunity again to the House if there's any question on the work that Dr. Piano just presented on, or if there are questions that you couldn't raise concerning the discussion we had before we gave to Dr. Piano. So I see there's a hand.
Hi, everyone. So my name is Mudise Sebatana. I am a postgraduate. I'm doing my PhD with UKZN and also work for UFS. So I really found this section of your part very interesting. Starting with Mr. Mabena. So I also had an awakening after my dad passed away. He had lung cancer as well. So I discovered, the advantages of this in the treatment of that, like towards the end, because he only discovered he had the fourth stage of cancer. By that time it was late. But fortunately by the time I discovered it, we applied it to him. So apparently that helped him as well, like relax in the final stages. So after that, I had like a very keen interest in cannabis. And then just to add to Dr. Burma's study, I also find it very interesting because so for the past 3 years, my mother has been in treatment for wound. So she was bitten by a spider, I think 2 or 3 years ago. And then I don't know what happened, but it made a hole on her leg that was, I think the size of a teaspoon. Like you could put in a teaspoon in there. That's how large it was. And for the past 3 years, we've been in and out of treatment for her wound. They've been doing like many treatments. Like sometimes they would even use her own like blood the wound just to stimulate apparently like some growth in it. But it has been like exhausting because my mom is in her 60s, and during the pandemic it was such a scary time. We were going up and down for that treatment, and then in addition she's on pension, so that treatment, even though she has medical aid, is still very expensive. So recently, it has like healed, but we're waiting for the top skin to close. But like the whole has sort of like disappeared because we're using like a zinc treatment, which is very expensive. So again, I wish I had your research had already been out there of what you're doing. So I want to know now: is there anything that is available on the market which is similar to Dr. Burma, or which is what you're working towards? Is there something already in the market that people like my mom can use? Yeah, that's it. That's my question or my statement. Thank you.
Thank you for the question. If I get you are asking about the availability of any marketable product related to this. I haven't seen in South Africa any hydrogel that can be like this. But we are working on this, and in the future, hopefully we'll have in the South African market. But currently I haven't seen any hydrogel in the South African market. It's a we have worked some prototypes, you can see it, and in the near future we'll develop the drug-loaded ones. Thank you.
Hi everyone, my name is Tepiso. I'm actually here with the lady from Stella. So this is definitely not my market. I'm more into accounting. So I've learned so much today, and what I'm asking myself is, what's been done to expose this type of information to everybody else? Because if I didn't come here with her, I wouldn't have been able to get this type of knowledge, and it's important that the youth know about it. So what has been done that other platforms that are not necessarily in the pharmaceutical world are exposed to this type of information, because it's very knowledgeable? Thank you.
Okay. Thanks. There's a comment. Do you have the last question, or is this, yeah? Okay, I think we are at the end of our session, ladies and gentlemen. If there are no further questions, Kumlani. Okay, I thought he was raising his hand. Okay, thanks, ladies and gentlemen. We want to appreciate your audience, and also to Prof. Matsabisa. I think it's always inspiring, as much as we When we listen to the work that your postdocs and your PhD students and your team are doing, and it's quite inspiring that there's work that's ongoing and somebody's asking if there's an advancement in the form of a product. So it just emphasizes the fact that it's not just research work that is just being done to satisfy scientific curiosity, but it's problem solving, or it's we're developing solutions that real people actually need. So we want to thank you, for your leadership, that the University of the Free State is able to make the kind of contribution that it's making to the community, to citizens of South Africa and even beyond. So we want to say thank you. So we have one more panel left, ladies and gentlemen, but I want to propose that we take a 10-minute break and then we'll come back. The panel will be led or facilitated by Dr. Petul Mahasha from the Medical Research Council. But we just have one announcement that we wish to make before we go to our break. That there will be dinner for all of us that has been prepared at a place called New York Restaurant, and that starts at 6 o'clock. So we will make sure that the panel that we shall have, we shall finish on time to allow the colleagues to go where they need to go to refresh or to do whatever they need to do before they actually present themselves at New York Restaurant. So shuttles will be available, and these will take us from this venue, after this venue, to hotels, and also shuttles will collect the delegates from the respective hotels to the restaurants. And also at the end of the dinner, colleagues will be transported back from the restaurant to their respective hotels. So we just want to say that if you leave before we finish, please take note that there is a dinner that has been arranged, prepared for all of us at 6 o'clock. And there's also transportation that has been prepared. Thank you.
Just before they leave, just ask for to come in.
The panelists that we have in the next session, we are asking that if there are presentations that need to be loaded, if maybe during this break we can be busy with that, so that when the colleagues come back after 10 minutes, we are able to start right away. Thank you.
so that we can start. Please take your seats so that we can start as we wait for those who are outside, please. Afternoon, ladies and gentlemen. Can we please take our seats so that we can start? Obviously, Mr. Hovolole has kind of mentioned who I am, and I think you can appreciate that I'm not Dr. Shabalala just on the basis of the hairstyles, those who know him. Yeah, we are going to begin now, just for starters, this panel 4 session, and I'm going to ask all of the speakers and the panel members to come in front so that we can begin. I don't know if the people online can hear us. Prof. Ngaba is going to be replaced by Dr. Ngobo. Dr. Kahoud will be replaced by Mike Ngumalo. And the rest are available here, who is Mr. Magua, Dr. McPherson, and Prof. Matabisa as well. So can you all please come and take your seats here in front so that we can start. Just a bit of introduction as to what is it. Already you heard that I come from the South African Medical Research Council. So what I do there is I'm the project manager for the IKS and ATMs projects, as well as the precision medicine portfolio. Having said that, I'm going to just confirm if all of you gentlemen have your presentations loaded. You'll just speak over it. He's got one. Do you have one for?
No, I'll just talk. And then, sorry, Dr. Chair. We then thought that our lady was second because she's in regulatory compliance. If she can just join. You know, in medicine regulation. So, Mohadi.
Okay. Mohadi, can you please as well join the panelists here. Can the people who are online hear us as well? I would just like to check with Mr. Ngowo or Dr. Ngowo if he's got a presentation to give, which is prepared in a way, or is just going to talk through about the work that they are doing there. Maybe you can just put him on screen and we start with him. So obviously the panel discussion and the theme of that is developments in medicines regulation and IKS clinical trials in South Africa. So we will now start to listen from Dr. Ngobo, who's replacing Professor Ngaba Kaleni. You can go ahead, sir.
Good afternoon, colleagues. I don't know if you can hear me.
Yes, we can. You can proceed.
Okay. Thank you. I do have a PowerPoint to share. Just trying to share it with you guys. Can you see my screen?
No, we only see you, not, yeah, it looks like it's coming through. Yes, we can now. You can put it on presentation mode. You can go ahead, sir.
Oh, okay. Thank you. I don't know how much time I have, but thank you, colleagues, and I apologize on behalf of Prof. Kaden. He has other commitments.
Just sorry there, Dr. Ngowa, 10 minutes I think will be the max we can give you.
Okay, no, thank you. As I've said, Professor Kaeni has other commitments that are holding back, but I'm hoping that I'll be able to share some of the work that we are doing with you, and you'll be satisfied from my point of view. So what I want to share with you guys is our work on product Kabinde, which is work that has been going on for quite some time. We are looking at product Kabinde as a potential cure for HIV. Just as a bit of a background, you know that people are infected with HIV when they start taking ARCs, their viral loads are suppressed, but they are not cured. And this is largely because of the reservoirs that are formed by the virus. And how the reservoirs are actually established is through memory cells. The virus actually integrates into your immune cells and then forms a virus, which is silent and cannot be targeted by any treatment. And when someone who was taking treatment stops, these proviruses start reproducing. You get an increase in your viral load. Yeah. So some of the cures, some of the strategies that are that are being looked at as a form of a cure for HIV, and I'm going to focus on this because that's the strategy that we are actually looking at. Is the shock and kill strategy, where you actually want to reactivate the proviruses that are integrated into your immune cells. So that the cells start reproducing the virus and are able to actually target the viruses that are being produced from those cells, either through ARCs or through any other treatment that can actually reverse the increase in your viral load. And that will allow your immune system to actually clear the virus. Hello? Sorry.
Hello, we can hear you. Can please proceed. Maybe move
Oh,
a
okay.
bit quicker
No,
because
thank you.
already you have lost a few minutes.
So, in our case, as you know, that people of our continent are still using traditional medicine for various ailments, and the medicinal plants that are used as traditional medicine have a potential to actually assist in alleviating some of the challenges, health challenges that we have in our country and in our continent as well. And there are various compounds and organisms that we have in nature that can actually act as antivirals. So what we are looking at in our case is a product Gabin. It's a traditional medicine from traditional healer from here in KZN, but he also operates in Gauteng. It's a product made out of four medicinal plants. I won't mention the names of the plants, but they are known, and these medicinal, basically to prepare this traditional medicine, the traditional healer mixes these plants in a certain ratio, and they are boiled for 5 minutes and taken as a form of decoction. So based on our initial work, we were looking at the anti-HIV activity of the product. And as I've said, this work goes back a long time. So the initial work was using pseudoviruses, looking at the mixture and the individual plants. And what was observed was one of the medicinal plants in the mixture was quite active in neutralizing the virus, which was STK, and the mixture itself was quite active. So because unfortunately our colleagues were working on HIV research were not that interested in traditional medicine as potential potential cures for HIV. I'm sorry, my connection is. We had to find collaborators from overseas, and one of those was Professor Ian Tijian from Simon Fraser University. So these extracts, we actually sent extracts to him, and they were blinded. They didn't know what type of plants he was looking at, and so basically the extracts were quoted, and these were some of the results that he produced. What was interesting was that basically confirmed what we were shown with the pseudoviruses, that the traditional medicine has potent anti-HIV effects. But while doing that, one of the extracts, one of the medicinal plants, which was a dichloromethane extract of SDK, actually increased viral production instead of decreasing it. This is the green line going up on your left. So fortunately for them, they had a latency model for HIV, and they actually looked at this as a potential to actually reverse HIV latency. Fortunately, it produced positive results. As you can see, these are different extracts of SDK using different solvents. And the lower bars are the actual mixture which showed lower potency in reversing latency than the single plant itself. So based on this work, which was done on subtype B, HIV subtype B, because in the northern hemisphere, they have mostly subtype B, unlike us, who have subtype C. We had to bring this work back and actually look at potential product Gabinde as an anti-HIV products on subtype C, which is more prevalent in our area, and also reversing a latency in a latency model infected with subtype C. And fortunately, one of our colleagues at HPP had actually developed a model.
Sorry, Dr. Ngobo.
Latency model using subtype C.
Dr. Ngobo, sorry.
Yes.
Were you moving your slides? Because on our side, they are not moving. We're still stuck on the first slide.
Okay, I'm actually moving the slides. I don't know what's happened.
We were not seeing any movement on our side, but since it's been a while, I think you can just, okay, we can see movement now.
Okay, you can see it now?
Yes.
Okay. So I was already here where we had actually moved our work back into our country, where we had a subtype C latency model for HIV and different viruses, subtype C viruses that we have in our research institutions here at UKSN. So these are the objectives that we looked at. We looked at cytotoxicity of the product before we started using and looking at the anti-HIV activity itself. And then we also started using our latency model that we developed here. Also, because initially the traditional healer had mentioned that he was using this product as treatment for STIs. Unfortunately, we have a model for STI or for chlamydia, and what has been observed is that STIs actually increase the virulence of HIV. So we wanted to test whether Proancabinde will be able to actually reduce the virulence of HIV in the presence of chlamydia as an STI. So the first part was looking at the anti-HIV activity using different viruses. So we have both subtype B and subtype C viruses that we looked at. The subtype C viruses are the ones starting with C, and the subtype B viruses are the NH Y2 virus. So when you compare it with the graph on your left, which is your positive control, you can see that the mixture, which is Proancabinde, actually compared favorably when you compare it to the positive control by increasing the anti-HIV activity with an increase in your doses. Similarly, SDK, which is a single plant which showed the highest activity, also showed the same by increasing anti-HIV activity with an increase in your doses. All of these doses that were used were below our IC50 when we looked at cytotoxicity in PBMCs, normal PBMCs. So moving on from that, we looked at latency reversal using both latency, the subtype C latency model and latency model using subtype B, just to replicate what our colleagues in Canada showed. So similar to what was observed in Canada, the mixture itself in terms of reversing latency had lower latency reversal activity. As you can see, these are the doses that of the mixture, and the latency reversal was insignificant for both viruses. But when you looked at, we looked at SDK, there was an increase in your latency reversal with an increase in doses of SDK. And the percentages were comparable to what was observed in Canada. Also, what we saw was that SDK was less effective in reversing latency for our subtype C viruses. So we moved on and looked at the known latency reversal agents that are currently being studied in combination with our products, both the mixture and SDK, and to look at whether SDK will actually enhance the
Dr.
efficacy
Ngobo,
of these latency reversal agents or
Dr.
actually
Ngobo,
suppress it.
sorry, can you just move a bit faster? We have 2 minutes now so that
Okay.
you can finish, please.
Okay. What we observed was that SDK actually enhanced all of these latency reversal agents in terms of reversing latency, both for subtype C and subtype B. And we moved on to look at the combination of HIV and chlamydia and whether Prodgabin will actually reduce the virulence of HIV in the presence of chlamydia. What we observed was that actually, even in the presence of chlamydia, Prodgabin was able to actually reduce viral copies, which was very positive. And we used 2 strains of chlamydia. This was the first strain, strain E, and then strain L2. And in both cases, Prodgabin was able to actually reduce the virulence of HIV. Looking at these green bars, the higher bars are the virus alone, and the purple is a combination of the virus and chlamydia alone. And the green bar is when you add Prodgabin and you get a reduction in the virulence and the viral copies of HIV. So what we are actually currently doing is looking at the latency reversal activity of Prodgabin in clinical samples. We have cohorts that are donating PBMCs in different studies, and we've requested some of these PBMCs to actually look at whether Prodgabin would have any effect on those samples. And we are also looking at the immune response after treating with Prodgabin, and we are also busy with animal studies. Some of these animal studies have been completed, and we can say that Prodgabin is not toxic to animals for the studies that we've done. So we are hoping that we will do more of these studies, including HIV models of animals to confirm the anti-HIV and latency reversal effects of Prodgabin. This is just one publication that is we've produced as of this work. This is from our colleagues in the University of Pretoria, looking at SDK alone, and they've isolated the active compounds from that. I think I will leave it here for now. So I'd like to acknowledge these colleagues and these organizations that have assisted us in actually doing this work. Thank you.
Thank you, Dr. Ngobo. I think it's best that you wait so that the other panel members can give their summaries of the work that they are doing, and then we can take questions after that. Is that all right with you?
That's fine.
Okay. Thank you. Ladies and gentlemen, I'm going to ask you to just give a brief intro about what you do and where you come from, and then just a summary of the discussion as per the program. No, you can start with him, it's fine. Okay. But sorry, with you, I think you're going to come here, so it's, yeah. Just to introduce as well, Mohadi Fafudi from SAPRA, because this is about clinical trials, and she comes from the Regulatory Agency of South Africa. I think whatever questions that you have, she's the right person to respond to those.
Good afternoon, colleagues. My name is Mike Malo, and I'll be standing in for Dr. Kehu today. My work is based on the documentation of indigenous knowledge. We are based here at UFS. We work in collaboration with DSI. They are the funders of the work that we do. Thanks.
Good afternoon. My name is Mohadi Daphne Fafudi. I head the Regulatory Compliance Unit at SAPRA, which is responsible for matters relating to cannabis, responsible for control of imports and export, control of compliance with regards to all matters that relates to medicines that are in the country to ensure that there are no substandards and falsified medicines. And we also conduct testing throughout the supply chain to ensure that there is still compliance with the Medicines Act, amongst other responsibilities. Thank you.
Thank you. I'm just going to ask a couple of the speakers here, the panelists, to give their talks because they have the presentation, and then we can discuss after that. He comes from SAPRA. He's going to be talking to us about the natural medicines regulations, where we are today and where we are going in the future. That is Mr. Makuba.
Is it good afternoon or good evening, colleagues? Thank you very much. My name is Mamatho Robert Makuba. I'm one of the technical officers at the South African Health Products Regulatory Authority, SAPRA, which is the regulator of medicines and medical devices. Really, mine is really not much of a presentation as such, but in the last 5 minutes over the tea break, I decided to put a few notes as prompts for my conversation with yourselves. I'm just quickly trying to put it on the screen. Somewhere here.
Yeah.
Thank you very much, sir. In the meantime, while the technology is still being sorted out, I guess I have at least 5 minutes to go through today's speech, if that allows. Okay, are we winning? Is it set? I can't see the slide.
There it is.
Oh, there it is. Thank you very much. Maybe in less than a minute, I want to just quickly highlight a few things that I picked up during the course of today. You know, in my Sepedi home language, they say "Muja morago ke kgoshi." So during the day, I've been sitting here listening to everybody talk and everything. I got to appreciate the kind of audience that we have here today, and I picked up a few things that maybe, as we'll be talking this afternoon, maybe they can get clarified, simplified, or demystified. I'm reminded there's a Sepedi author, novelist by the name O.K. Matsepe. That man's style of writing, when he writes a novel, he starts with the conclusion, and then that's chapter 1. And then as you read through the whole novel, you get to understand the story how it developed. So I'm going to try to do that. Start with the conclusion in case I get cut off by time. Maybe just to itemize and mention, initially in the morning, there was a question asked How does SAPRA assist SMMEs to get products on the market? I think it was earlier in the first sessions, in the first panel. I think in our discussion, some of the answers may be picked up, but we're not going to go into details, otherwise we'll need a long period to do that. There was another question over, okay, it was just a comment, I think, in terms of instant gratification of probably the knowledge holders. They say, I give you this knowledge, and then how am I going to make money out of it immediately? It's a long process, it takes time. There was issue with it, the discussion was about challenges. Challenges about funding, costs for registration of products with SAPRA, they involve monies and all those things. And then there was another issue, for example, that I picked up. Okay, I noted that in this audience, when I came down here, I didn't have a clue who will I be talking to. I just thought maybe, well, I'll use my old technique that the professors at university taught us to say, just look above their heads, don't look anyone in the eyes, so everything will fall into place. So there was an issue about technology transfer. There was the issue of knowledge holders, there's researchers and academics, practitioners, marketers, regulators. We are all stakeholders in this thing. Oftentimes, we make mistakes to think that we are on opposite ends. I'm a funder, I'm a regulator, I'm an entrepreneur. We forget that the language that we speak, all of us, we are talking natural health products. We are talking natural medicines. Everything that you do is about the well-being, development, and progress with respect to natural health products. Okay, I love the story about the teas. There was this other issue, for example, I think it speaks also to the issue of how SAPRA facilitates entry of natural health products on the market. Prof. Matsabisa hinted in his discussion a bit earlier about how documents such as the MSDS, the Material Safety Data Sheets, assist with getting products into certain territories. Maybe in my talk also I'll mention some other things that SAPRA does to assist under the current situation, getting products either on the market or into external markets, okay? Now, we all, yes, I know when you many times when you mention the word SAPRA, it's like to other people you are saying institutions like SARS. You know, you watch the queues at people going to SARS, nobody talks to anybody. They just follow in queue. It's like sheep to a slaughterhouse. And now, unfortunately, SAPRA is not and should not be perceived to be that kind of an organization. SAPRA is your regulator, is your organization that you, as South African public, own. It was established by an act of parliament to service the interests of medicines in this country. So it is your organization. Don't look at SAPRA as an enemy, but it's a body that you can interact with. That's why, for example, we are here. When you invite us to these occasions, we come running, okay? Thank you very much. And lastly, I wanted to just mention, oh yeah, I was encouraged to hear from the colleagues from Chiba. Interestingly, I attended one of your open sessions in Vereeniging, I think, yeah. That was in Vereeniging. I was encouraged to know, to hear that Chiba is also offering Health Professions Council accredited courses. So we hope we'll be getting, and actually the purpose thereof is to provide information, knowledge, and education, not only to academics, not only to consumers, but to everyone involved in this field. And we are all involved in that. We're speaking for Joe Soap, we're speaking for Joe Public, we're speaking for professionals and everyone else. I'm not going to have to remind everybody about that one, okay? We know that for sure. Lastly, of the points, okay, the point that I wanted to stress is let's all remember, everything that we do, everything that I do, everything that you do is in the interest, one, of natural health products in South Africa, okay? Thank you, ladies and gentlemen. Now, can I quickly go to my, to my prompts? Let me talk a little bit. Let me talk a little bit about medicine regulation in the country. I'm not going to give you a lecture about thalidomide, how medicine regulation came about. I think we all know that. I know there are new people in this area. When we were having tea outside, I met a few people. I'm new in this environment and everything. Came at 2000, my generation, you know, those people. All I wanted to indicate to all of us is to say, South Africa is a country of the rule of law. We are governed by laws in this country. I'll just put at least a few examples there to say, from SAPRA, your regulator, we are governed by the Medicines and Related Substance Act. And we know this act was there since 1965. It has been amended many, many times. I had to delete all those slides to show how many times it was amended. If you look on the government gazettes about Medicines Act, they will show it was amended this year, next year. It's still being amended even today. So that is the act that is in force in this country that is regulating medicinal product and medicinal products and medical devices. If you are not talking medicine, you are not talking medical device, we are not talking to you. Okay, let's get that straight. If you are talking of food stuff, don't come to me. Okay? All right. Then obviously, then there will be the Constitution with the Bill of Rights and all those things. There will be the National Act and all the associated legislations that govern our republic. Now, coming to SAPRA, we say all of us are supposed, and maybe even for the benefit of the new ones, is to say previously medicines were regulated through what was called the Medicines Control Council. The Medicines Control Council, which is the precursor to what is now SAPRA. The Medicines Control Council was sitting, it was a statutory council with secretariat staff sitting in the Department of Health. Now, that arrangement was kind of like causing problems, which, you know, when you talk government, I hope my bosses are not listening, you know, bureaucracy, red tape, things that take time to get things done and all those kind of things. Eventually, it was decided that SAPRA be established through the Medicines Act and be formed as a public entity, a 3A company. So it sits outside the public service now, and now it can get things being done very quickly. Some of those things, I mean, under the capable leadership of our CEO, sorry, 3 minutes. I'm summarizing. I started with the conclusion anyway. Under the capable leadership of our CEO, Dr. Boitumelo Makokotlela, we've put electronic systems in place to make sure that people can access information and everything. The biggest problem with regulators is they don't communicate. People don't know where to find this, where to find that, but that is changing very rapidly with SAPRA. Now, quickly, our mandate is the regulation of medicines. We look only, like my colleague Mohadi had indicated, 3 pillars of medicine regulation: safety, efficacy, and quality of the medicines. Anything else? No. And our decisions are science-based. All the work that many of us are doing in here, the doctors, the professors, the entrepreneurs, and everybody, we saw very nice presentations today where they're looking into the details of all these products, showing us very fancy graphs there. That information is the kind of information that is required to be able to satisfy SAPRA that the products that you want to feed our nation are of good quality, they are safe, they're not going to cause harm in people, and they are efficacious. They are going to do what they claim to do. We are protecting the consumer, and at the same time, we are protecting you, the supplier of the product. Because at the end of the day, the next person cannot copy your product if it's registered with us without concomitant action being taken. Now, long story short, we know normal pharmaceuticals, we have what we call complementary medicines, which are natural health products from outside our country. In the country, we have African traditional medicines. What I wanted to highlight on that one is to say, with African traditional medicines, the regulatory framework under the Medicines Act is still being developed. It's developmental at this stage. Professor Matsabisa and myself, of course, and many other colleagues are involved in that field to come up with a regulatory registration framework for African traditional medicines. You may want to call them traditional medicines. Complementary medicines, where a framework for their registration was published. Unfortunately, those regulations were challenged in court, but then they are being amended. Something will come up very soon in terms of their regulation. Finally, I'm not going to bore you with all that. The purpose of my talk today was to say, where are we now? Where are we going? In the meantime, we are under the rule of the Medicines and Related Substances Act. It's in place with its regulations and the guidelines. a lot of information is readily available on those websites. The first website is the generic website of the authority, sapra.org.za. We have a specific one for natural health products. It contains the guidelines, all the information, how do you apply, and all those kind of things. It is sapracm.org.za. I hope very soon we may have that kind of a website, Sabra TM, maybe, or IM, Indigenous Medicines, for these types of products that we are talking about. But that one is not in place yet. I thank you, ladies and gentlemen. Thank you, Chair.
Thank you, sir. And I apologize for keeping on reminding you about time. I understand I'm standing between dinner, which now the time in between getting to it from now is getting shorter and shorter. The next speaker is going to be Dr. Reinhard McPherson. He's going to tell us about the FAMOVS, I don't know if I'm pronouncing it correctly, clinical trials. You can come in, and then after that, I will ask Mokhadi to just sort of, if there's anything to say, but I have a few questions that are directed to SAPRA as well. We know Prof. He will come and cover part of the WHO as well.
Do I share it on the Teams, or do I just put it in presenter mode? Maybe it is best for you to come and help me. Thank you. Excellent. Okay. I'm usually the one that breaks things, so I'm glad somebody else is doing it. Good afternoon, everybody. My name is Dr. Reinhard McPherson. I am the Chief Medical Officer for FAMOVS. We are situated here on the campus of the University of the Free State. And I wanted to thank Prof. and the organizers of this meeting for the opportunity, the huge opportunity for me to say a few words about FAMOVS. I think that, during the course of the day, I want to also use the strategy that was used by the previous speaker and say that I really enjoyed the course of the meeting today, the agenda of the meeting today. And I think if I think back, there were two things that really caused resonance for me, and I think resonance is the word that comes up for me. So firstly, I am a son of the Eastern Cape, and throughout the day, it was really highlighted how an important role the Eastern Cape is playing. Some of the plants are coming from that area. Some of the entrepreneurs are coming from that area. As a previously quite a disadvantaged part of the country, it really makes me proud to see that the Eastern Cape is coming to the fore and coming into its own. The second part of the resonance for me as well is that, as a physician scientist, I mentioned that I am the Chief Medical Officer for FAMOVS. I'm a medic by training, but I think, as I think was highlighted by Prof. and some of the other speakers during the talk today, for all of us, there are different levels of our being. And, there's the scientific component, but there's also the cultural and the spiritual component. And I think that was the second part of why this really, resonated with me. So I'm going to get straight into the presentation with the question of, when it comes to clinical research, the word clinical talks about the fact that you work with patients or you work with humans, as opposed to preclinical, where it's either with in vitro systems or animal studies, whereas now you take the step and you move into working with patients or with humans, so patients as well as healthy volunteers. And currently still clinical research is the only way globally that you can get a medicine from the laboratory into a patient's body, let me say, legally. And so that is what my industry represents. So when you ask yourself the question, how do we know even before we think about efficacy, which is late phase clinical research, and we can get into that with regards to the questions. I'm going to keep it relatively tight to what we do here at Pharmorphs, and then a little bit of the rest of the organization. If even before the drug is tested for efficacy, firstly, you must show what does the body do to the drug? What does the drug do to the body? How do you know how much of it you're supposed to take? How do you know how many times a day you're supposed to take it? We were talking about drug-drug interactions before. How do you know that a drug A and a drug B shouldn't be taken together? Or if you take drug A with drug B, that you must increase the dose of the one or decrease the dose of the other one. Early phase clinical research, which is what we do at Pharmorphs, answers all of those questions even before you move into patients to look at the efficacy of the drug in the patient population. So just moving into my presentation, I think the two things that I want to highlight from some of the presentations before are two things, and I'm hoping to show you this during my short presentation, is one, that we don't compromise on the good science. And secondly, an aspect that was also mentioned was the international perspective. So Pharmorphs is a South African organization. Our experience as a company spans almost 50 years, started next door to where Pharmorphs is today at the Department of Pharmacology. The then head of department started a clinical research unit, and it was spun out due to its success because the university traditionally is kind of seen as a non-profit organization. Due to the success of the unit and the fact that it was, a business generating income, it was spun out. We were also part of the Parexel early phase network previously between 2000 and 2018, and currently we are a privately functioning company, partly owned by the university and partly owned by a private company. The arrangement both with the university as well as the privately owned company is really one of a hands-off relationship. I was mentioning to one of the ladies at the back, our interest is not in the drug itself. Our interest is to conduct the clinical trial to a high standard. So we don't own any interests in the drugs that we test and the drugs that we research. So we have flexibility because we're not that big, but also by virtue of our international involvement previously, we have robust processes that conform to international standards. So the bigger company consists of three parts. So we have our early phase unit, the physical building next door to pharmacology on the campus. Then also in the physical building is the bioanalytical unit, which is responsible for testing pharmacokinetic and pharmacodynamic levels of the drugs the studies that we do, and then reaching out into the later phases is what is called the site management organization. So just to speak to the international perspective, the red flag is where Pharmorphs is. The sort of see-through or the white flags is where our clients are. So from an international perspective, we serve South African, African, and then also clients across the world. So our clinic is really a state-of-the-art facility. We can accommodate for admission nearly 100 patients, 5 wards where we can, in a sort of a sharing style, accommodate the healthy volunteers who are the biggest part of the work that we do. Together with that, we also have the long stay facility that caters more to sort of your older, frailer patients, and those are sort of single rooms with ensuite bathrooms. And so altogether, we can accommodate nearly 100 patients or healthy volunteers to be admitted like in a hospital kind of setting. Together with that, because we do early phase research, we have set up processes with regards to emergency equipment on site, emergency evacuation, management of emergency situations, as well as evacuation of those patients. The 5 of us as clinical research physicians that conduct studies and take the medical decisions for our patients, or the healthy volunteers that participate are all ACLS trained, which is done on a 2-yearly basis, and the rest of the clinical staff have similar training. I just wanted to point out as well that our bioanalytical laboratory, from an analytic perspective, is the only GLP certified laboratory on the continent. And then also looking at some of the types of studies that we do, we have an on-site kitchen which sounds a little bit like a catering service, but they can provide us with expert support when we do those drug-food interaction studies, which, as you now have been told, are also very important in terms of the clinical research pathway. So I'm going to just go into the two next slides, and I'm going to skip this one because the next one says more or less the same thing in a different way. This is just a rendition of the considerable clinical pharmacology and early phase experience that PharmOffs has supported. So all the way from the first study that's done when the drug is introduced to a human subject for the first time, up until the first introduction into patients, is what we do in the physical unit at PharmOffs. And then our site management organization goes into the late phase component of things. Just from the perspective of thinking about the fact that we do perform what we call first-in-man and early phase studies, we refer to international guidelines regarding mitigation of risk in first-in-human and early phase clinical trials. That is an EMA regulation. The MHRA also has regulations. The MHRA is from the UK, and they also have an accreditation scheme to which that PharmOffs follows in terms of our processes that help us to safeguard the safety and the integrity of the subjects that are involved in our studies. So just moving that a little bit along in terms of inspection history, if you look at the slide here, you will find all of the major regulatory agencies globally. So from the FDA, the EMA, the Japanese regulatory agency, the Chinese regulatory agency, the MHRA, and then you will also see, just to bring it closer to home, previously the MTC, so bottom left of your slide, and then bottom second to the right, today known as SAPRA. We have been inspected and have had successful inspections by all of those regulatory authorities. When it comes to having the patients or the patients in the study, we have good networks around the Bloemfontein and the Free State area. So whether it be healthy volunteers, which really comes from mostly from the student population, but also further afield from the healthy volunteer population that is not affiliated necessarily to a tertiary institution. Those healthy volunteers participate in our studies. But then on the other hand as well, when it comes to patient studies, our connections to both the public sector, the private sector, the academic sector helps us to recruit the patients that we need for our clinical trials. I think just to bring it back to the agenda that we spoke about before, I mentioned to you that I really enjoyed the agenda for today, and I want to take us back to the first panel discussion, which I don't have to belabor because Prof did mention the collaboration that there is already between PharmOffs and the IKS and the Department of Pharmacology next door to us with regards to the planning, the approval, and starting to conduct the PILA study, as we affectionately call it. Moving on to the second panel, and I'm maybe going to stretch your imagination a little bit. We were talking about teas and taste research that's done. You may think about how how what is called orally dispersible tablets are researched, and that the taste that comes with that is also something that we have done previously. And then when I talk about, if I think back to the third panel that just happened, and I'm going to close with that, I did get the sense that it was, a little bit more emotionally charged. But I think just from a solutions-focused perspective, when it comes to topical drugs, dermatological drugs, just a solution from my side that I wanted to throw out there, and we were talking about the systemic exposure of patients to a drug that's being locally applied. Our bioanalytical laboratory that supports the work that we do have such specialized equipment that they can detect very, very, very minute quantities of even drugs that are or that are administered as topical drugs. And so by showing how very low the concentration is, you can say that the greater systemic circulation or this exposure will be very little. And I think I'm going to end there. Thank you very much for your attention.
Thank you. Please accept my apology for rushing you. It's just that too much time has gone already. But it's good to know that there are resources for those who want to conduct clinical trials. Prof, you are wearing a different hat now, so I'm just going to give you 5 minutes before we get into the questions.
That's good. I thought she was going to talk about cannabis.
Okay, let's bring her in then. Mokhadi? I thought I was going to start shooting questions at you. And I hope that everybody else with questions as well. Maybe you should come through and talk about cannabis.
Good afternoon. One thing that Mama Hlo forgot was that SAPRA, as a national regulatory agency, has been acknowledged and accredited by the WHO for a maturity level whereby, because WHO has got 4 levels, maturity level 1, 2, 3, and 4 of operating, 4 being the maximum and then 3 being the minimum that an agency can operate at an international level. So SAPRA has recently achieved that level, and in terms of our vaccines, we even got ML4. So in Africa, we are just one of the few, very few, who happen to be at this level. So yeah, of course, they are still assisting us to be fully at those maturity level, at that maturity level 3. But that is one of the major achievements that are currently making headlines. So this is about ensuring that the public, so they are satisfied that our endeavors in ensuring that the public will receive safe medicines. Yes, we at the moment operating at that level. So, ladies and gentlemen, I thought let me speak about cannabis because there is a high interest in cannabis with a prospective multi-billion dollar industry. Apologies, sorry, I'm short. The cannabis journey, the cannabis journey, we remember in 2018 the Concord judgment declared unconstitutional, denying personal use by adults in their private space. To say that in terms of our current legislation, the Medicines Act, which is SAPRA and Department of Health, together with the Drugs and Drug Trafficking Act under Department of Justice and Constitutional Development, were declaring the name cannabis to be a banned substance. And this was in line with global legislations. However, in terms of medical use, there has always been that enablement, but it wasn't very clear. So the Medicines Act, together with the Drugs Act, had 24 months to enable personal use of adults in their private space. Then in terms of the Medicines Act, we remember that cannabis can be categorized into two, which is a high THC and low THC. Low THC, we also call it hemp here at home. So now my focus will be on how cannabis is globally regulated, focusing more on medicines, medical and research use. So in terms of global use, cannabis is regulated in terms of the UN conventions, the 1961 Convention on Narcotics, 1988 Convention on Psychotropics, and also the 1988 Convention on Prohibition of Illicit Use of Narcotics and Psychotropics. So all the UN member states have to develop country regulations that align with ensuring that the control is aligned. So we amended our schedules, and during the amendment of schedules, what concurrently was happening is that there was this increased already demand in cannabis and cannabis-related substances in terms of global trade. Then we engaged a lot, and there was also the Ministerial Advisory Committee on Cannabis, Interministerial Committee, the master plan, and also from the presidency, the Operation Vulindlela, there is a project that focuses mainly on cannabis. So we have been actively we have participated in any platform that relates to cannabis. Invite us, we will come. We have always been coming. When we were amending our schedules through these other platforms that I'm also mentioning, we were presenting to those platforms. We engaged in our amendments. Before, what we even did in 2019, we amended our legislation to enable CBD-containing products for a year at a specific level with certain claims to say, let's see for a year how they do so that we can develop a proper framework for regulating that. So globally, THC, especially tetrahydrocannabinol, delta-9 tetrahydrocannabinol, it's still regulated under the conventions. And in terms of SAPRA, how do we regulate? We regulate through licensing of the cultivators of cannabis, because the dried flower is highly concentrated in terms of THC, but again, we regulate medical cannabis and research cannabis. We issue research permits to institutions of higher learning. We issue licenses to anyone who wants to cultivate. We issue licenses for manufacturing, where extraction is taking place. If you want to export, if you want to import, we issue licenses. However, locally this is similar to international trade. There is currently there is only one internationally registered medicine. So, and we are saying, let us encourage research, and research outcomes should be available so that we can see how we can enable the use of this, because we do hear a lot of research has been conducted globally and all that. Ask the FDA how many products they have registered, ask the MHRA and others. So we communicate, we keep in touch. The TGAs, Australia's, we communicate. So how do we enable products that are currently in the market, which are not registered? This is through Section 21. It's another mechanism of authorization. But this is limited to where there is no alternative. Because remember, when we speak about safety, we are encouraging that safe product, like if you say this is a safe product, present it to the regulator for evaluation. We have got different mechanisms of registration. There is also priority reviews. You've seen with COVID how products were given priority review. And so in terms of licensing, ladies and gentlemen, because we are a regulator, what we don't just, you don't just come to the regulator and say, I want to cultivate cannabis for the purpose of producing a scheduled substance, and then I'll look for the market afterwards. No, we need to, because we are, for every THC, which is internationally controlled, for every THC containing the high THC cannabis, we have to inform the International Narcotics Control Board to say that South Africa, we do this, we have done it already in August to inform them the estimate for South African consumption of cannabis high THC in 2023 will be an estimate of this much. So, and then every country has to do that. At the beginning of every year, they will show South Africa in terms of cannabis, it will use this much in 2023. But that is a rotating, it's a revolving, we can amend in case we increase the consumption. Every quarter, we also need to report on how much did we produce, how much did we consume, how much did we export, how much did we import. At the moment, the current market, we are exporting successfully to the US, Israel, UK, and a whole lot of other. But we are exporting it in the form of the API. Those are, we have got over 65 licenses that we have issued for cultivation and just 2 for manufacturing, showing that we need more manufacturing. And also we need more products. At the forums of the Cannabis Master Plan, the interministerials and the presidencies, they want to know, because they always ask, where are these billions? We as the regulator as well, we are asking, are they in medicines? If they are in medicines, present data that we need to enable. So we are always open to engaging, as Robert said, to engaging with anyone, and a multi-stakeholder such as this, assist in people raising hand and say, we can help with this, we can help with that. So with that, I just wanted to say that the regulator is actively participating. Fortunately, we've got such a young CEO who's also driven in terms of pushing evidence-based information that can provide solutions to our wicked problems, and obviously those that are scientifically backed. So I just want to say to you, we are also South Africans. We would like to see South African problems having South African or African solutions. Thank you very much.
Thank you, Mukhari. Prof, we are now giving you the opportunity to talk to us about the position of the WHO and AU.
Thank you so much, Doc. Where's Puti? Because I know wherever she's sitting, she's getting worried. I want to stand here now as not a UFS person, but probably standing here as the chairperson of the World Health Regional Expert Advisory Committee on Traditional Medicines for COVID response and other pandemics. So I think in summary, WHO, the World Health Organization, remember the World Health Organization just gives guidelines. Whatever they do, it is a guideline, and those guidelines, countries or member states can adopt and adapt, or they can throw them out of the window. It is not mandatory for countries to take those guidelines. Those are just guidelines. So I think that's what I need to make it clear. But sometimes I think those guidelines are very useful. WHO, I'm pushing, because of time, its stance on traditional medicines. That one, I think WHO is moving positively towards the institutionalization of traditional medicines. Historically, they've been supporting, I think, the Traditional Medicines Day on the 31st, I think, of August every year to celebrate, that. They've put up, I think, strategies and developed certain, I think, or declared certain years as decades of traditional medicines. I think next year, it's the last year of the decade of traditional medicines. But I think what's going to happen, they will, I think, extend that, because next year, I think in Tanzania, we invite all of you. That's where WHO is going to recap and say, what have we achieved as the World Health Organization in terms of WHO and the decade for traditional medicine. And that's where, again, I think that decision to extend the decade will go through. But also I think what is happening, it's beginning to recognize the importance that is being played by traditional health practitioners. And I know this year we've been discussing, I think, that and say what we did actually wrong also was we never engaged with traditional health practitioners at the community level in terms of how they could contribute, to stopping the spread, of COVID. So we recognize that, I think, as WHO, that was, I think, a mistake. So this committee, the Regional Expert Advisory Committee on Traditional Medicines, and COVID, the response, it was formed, and it's very important that I mention this, it was formed by the African Union Commission on Social Affairs, together with the EDCTP, and also Africa CDC. You could actually see that, I think, those, groupings are beginning to realize the contribution and the value of traditional medicine. So the mandate then for us is to report to the Director General for Africa, Dr. Matsidiso, and also to report to the African Ministers of Health. I think a month ago, we were in Togo, where in fact, I presented some recommendations to the ministers, of the African Ministers of Health in terms of the role that traditional medicines, is playing. And some of the recommendations included continued and sustained support by the African leaders, the heads of states and governments, in terms of supporting traditional medicine and traditional medicinal product research. As Mohadi was saying, we need to begin to look at local manufacturing, of traditional medicines. And those recommendations will come out, I think, in the ministerial report. Either it's out or it will be out next year, where I think we then hope that we will see a more, even better concerted effort, to support traditional medicines. But what then the REACT did, we call that Committee REACT. We produced a number of clinical trial, I think, protocols. We did some observational studies where we look at the relationship between a traditional health practitioner and scientists and doctors doing observational study, with an intention that the outcome or the results of that clinical observational study will help us then to put up a better and a bigger clinical trial protocol. But we did some phase 1 up to phase 3 clinical trial protocols. Those are sent through to the member states, WHO country offices. I know that here in South Africa we have a WHO country office. It's in the, I think it's in the UN, offices. So we have a country officer who oversees that any decisions that's being made by the World Health gets, I think, sifted down into the country. So that report, hopefully, then it will be sent together, I think, with those clinical trial protocols available for countries to use, to adapt, and also to see if they can improve on them. In terms of medicine regulation, quickly, I think the proposal, there's a document, I think, from WHO where we propose how should African traditional medicines be regulated. And we're talking about traditional medicines that are being commercialized, to the larger public. They've got category 1 up to category 4, where category 1 those traditional medicines that have not been processed. So you take a root, you take a bark, and you want to sell it. That's category 1 according to WHO. Category 2 are semi-processed, partially or minimally processed, traditional medicines, while category 3 will be what we have been talking about here. Those traditional medicines that have been researched, in the lab, developed. And then category 4 are traditional medicines that come outside the country of origin. Say, for instance, I think the anomaly with South Africa, we have complementary medicines. And complementary medicines are everything else excluding African traditional medicines. There are reasons for that. So according to WHO, then complementary medicines should actually be category 4. But again, let's clarify, because when you talk about categories, SAPRA uses the word category differently. So we need then to begin to look at and say, how then do we harmonize, I think, the wording and the terminologies? Because when I talk about category A medicines in South Africa, I talk about Western medicines. When I talk about category D medicines, I talk about complementary medicines. Now, one thing maybe that Robert and Mohadi maybe did not share, even though Robert talked about, the amendments to the Act. In fact, there is a small working group. I think Robert did mention that. I'm part of that working group. It's been driven by the University of the Free State, supported by SAPRA and government, to help SAPRA and government to come up with a regulatory framework. How are we going to regulate African traditional medicines? And that's, I think, the work that's ongoing. Probably, I think, in the next year or so, there will be, I think, these road shows and, visits to begin to talk to you and say, what could be the best and ideal way that we should fairly regulate products, commercial products, derived out of, I think, African traditional medicines. Do we want to call them African traditional medicines, or do we want to give them a different name? Those are the discussions that we want to talk about. But also remember, those that are doing work on cannabis, when we talk about these products, we understand that cannabis is actually used in traditional medicines. So if there are products that are cannabis derived, they should actually find to be regulated through that mechanism. So in fact, as we speak currently, we are going to get involved in the review of the South African Medicines Act to make it, I think, to have it in line, to accommodate African traditional medicines. Chair, you must clap for me. I did it in 2 minutes.
Thank you, Prof, and thank you everyone online as well, if you guys are still there. And for the panel, now is question time. So before I allow everybody who's in the room to ask questions, I have a few. Somehow I knew that Prof is going to somehow try to answer my questions even before I could ask them. There's a situation with the regulations, especially for IKS, and one wonders how long will it take for those to be sort of developed and be put out there for people who want to conduct special trials within the space, can then utilize those? like I'm saying, Prof a bit kind of touched on that, but I will appreciate, and I hope people here in the room will appreciate, just to kind of have an idea of when that will be, so that things can start moving. And the reason why I'm asking this is, maybe as a disclaimer, the Nkavindo project is one of those projects that the MRC is currently funding. It's shown positive results, and one hopes and expects that they will reach a point where they need to do clinical trials, but we can't just run into that. We need approval from the regulator for that to happen, and there are others as well internally. So it will be very much helpful to have an idea of when that is going to happen, so that at least people work knowing that they will be sorted when that time arises. The next question then is, exactly what are the bottlenecks? What is difficult? It's been going on for a while. One has been kind of trying to engage with people in the space, even to the level of the CEO, trying to sort of have a clear understanding of where things are at, how patient can people be, especially because projects are moving now. And we need to sort of have a clear understanding of how then, if then there is a requirement for other people outside of SAPRA to help with ideas of how to go about this, then they can play part into helping out on that. And as we wait, before all of you can respond, and Prof as well, what should happen now? Let's say by the end of this year, or in January next year, or February, one of these projects that we are funding, the results are as we have hoped. Now, obviously, we need to eliminate a few things. Is there adverse reactions? Prove efficacious? So what is it then in between, as we wait on you to finalize things, that people, if we get to that point before you finalize the regulations, then will be a way to go about doing things? Thank you very much. You can answer my questions, and then I can open it to the floor. I hope I won't have follow-ups. They will just be straightforward.
Thank you, Program Director. It's funny that Mr. Mbetsi is sitting on the other side, because traditional health falls under the Department of Health. So you should have been part of this hot seat. What I just want to say is that, okay.
This year is part of the hot seat.
Okay. Yeah, I just want to say, when you look at the Medicines Act, and when we speak about orthodox, we speak about complementary and medical devices, we were trying to move away from traditional health, which fell within the National Department of Health, and obviously regulate more the foreign ones that are coming in, us as the regulator. But there is that convergence now, and then I'm going to allow the people who are part of the working groups to speak to that.
Thanks, Mukhadi. Program Director, thank you for the question. Regrettably, that kind of question, if you put it to, be it Department of Justice or the courts, or you put it to the regulator and say, how long is this thing going to take? It's not readily easy to answer. For the reasons that upon submission of anything to the regulator, be it an application for registration, there was always going to be this to and fro question answer session between the regulator and yourselves as the applicant. But having said that, the honest answer directly from myself is I do not know. I'm just saying, having heard you mention that engagements have been had at different levels. So it sounds to me more like a particularly direct question, which I will not be able to can answer here now. Unfortunately, thank you. I don't know if Prof, you want to add something.
Basically, I've said that in relation to engagements because we got nowhere. And time is moving, projects are moving, we're funding them. We can't just waste the resources of the people of South Africa's tax monies and get to a point where nothing happens. So I will appreciate, and if you can't answer the question, then take it up with management when you head back to at least be able to answer this question when that time arises. What should then happen at the time before you finalize the regulations?
Why are you putting this thing next to me?
You are on the working group.
Can I just acknowledge?
Acknowledge something.
Yeah, Program Director, thank you very much. The point that I wanted to make here is I acknowledge the concern that you are raising. It's a direct, like I indicated, it's a direct question. And between us here at the moment, we'll not be able to can give you a direct answer. Because, for example, like I indicated that you said it has been elevated to higher levels.
Yeah.
From this meeting today, we can just submit an inquiry that we came across this particular thing, and then maybe, I don't know, if something fell between the cracks, it can be followed up then. Thank you.
And if it helps, then when you mention that to management, just mention Prof. David Katarera as the person who's been doing those communications, copying me in the discussions, so that the boss lady will remember quickly.
Yeah, noted. What we will escalate it, but I also still want to say that when it comes to traditional medicines, it's not a mandate of SAPRA because there is that act that speaks about traditional medicines. So hence I'm saying that with the Medicines and Related Substances Act, it was more of the orthodox and also the complementary, because as the definition, as we are saying, they are not indigenous to South Africa, they're complementary. So, but definitely we will escalate this. Thank you. Doc, did you want to?
Maybe just as a way of something to move forward with. Prof, if you can maybe say a few words on the PILA study that was approved by SAPRA, that was approved by the Ethics Committee. If you can maybe just say a few words of what the background work was that you did do from a quality and a safety perspective to get to the point of being allowed to conduct a clinical trial.
Yeah, colleagues, thank you so much. Remember, maybe let me say it this way, so that we don't put Bruce into a corner. I see he's hiding there, but also so that we can sort out, I think, these issues. I think we all understand that when we talk about traditional medicine, and I'm starting this like this so that there's no ambiguity in terms of what we are talking about. When you talk about traditional medicine, we talk about the practice, okay? We talk about the practice, and that falls with the Department of Health, okay? But when we talk about traditional medicines, you add an S there. When you talk about traditional medicines, we talk about the products, okay? And once you talk about the products, it has nothing to do with Department of Health. It comes to SAPRA. So are we clear on that one? Now I'm a teacher now. Are we clear on that one? So that we don't throw blame here and there. So the question is, there is a Nkabinde product. Okay, it's a traditional medicines. Okay, it is a product that then needs to probably go into a clinical trial. Clinical trials are not evaluated by the Department of Health, but they are evaluated by SAPRA. Okay, let's sort that one out. And therefore, what is then happening at SAPRA? I mean, I can understand, I think Robert, myself, Mukhadi, within SAPRA, I think there is the clinical trials, committee. Unit, okay? Unit. So when you submit your clinical trial, then it needs to go to that unit. Then I'm sure they've got a system, to evaluate clinical trials, okay? They may not have the expertise to evaluate the efficacy of traditional medicines, products. So they would probably might have sent it to the Complementary Medicines Committee, okay? So the name that you are throwing in here probably is to me synonymous to someone who's in the complementary medicines committee. That's the more nearest committee that SAPRA could say, can you look at that? Now, most probably what's happening in the complementary medicines committee, then they say, but this is African traditional medicine. It has nothing to do with Chinese, Ayurveda, Unani Tib, and the rest. Because we, as complementary medicines, are more interested in the Chinese, the Ayurveda, homeopathy, and the rest, except African traditional medicines. So you're caught up in that whirlwind spiral thing. Now, what happened to our clinical trial? Okay? For COVID. We sent it through. Same process. It was orthodox. Same process of orthodox, because we're confident that we did the science and we could argue any review that would come out there. Okay? So in fact, the reviews came where they were asking us two questions. The first question was, can you do your study in the other variants of concern? I think, Doc, you recall my response to that, which was a very sarcastic response to say, every year, every winter, we have different viruses floating around and they bring different colds. Do you ask that every cold and flu medicine, gets tested on all those? So they didn't answer that. They didn't have an answer. It was a genuine question to them. If you're asking me now to test this thing on all the variants of concern, your beta, your whatever, do you do the same thing for all the colds and flu medicines? And the answer is no, you can't do that. So that was the first question. And then, but we had enough scientific data and scientific evidence, to show that, in fact, this traditional medicine does what it is intended to do. So that's why it was approved for a phase 2 clinical trial. So I don't know what Indian cabinets they have. I don't know what claims they are putting up there. But my advice would be, if there is some good, solid, science, that should actually not be an issue. I don't know what the reviewers, said from the clinical trials unit, because that's also important to look at it. Because sometimes when they review, maybe they don't know, so you need to guide them as the principal investigator. So it's really, really difficult, but as they were saying, they will go back and follow up, and follow up. Now, can I just say, there's some few things that says what happens now, what happens in the meantime. I always say, because I deal with government, I will never want to be on the wrong side of the law, okay? I will never take a product, even those teas, and just put them onto the market because I want to prove a point that because there are no regulations, it's a free for all. So let me do that. So I'm a very disciplined, citizen. And the reason why I'm doing that is simply because I cannot do things against what I'm asked to advise government on. So I can't now go and say, let's take Pela and put it up onto the market because there are no regulatory framework. Probably I think even Ndate, Pehani, and the guys from DSI, you would not want to be engaged in that, where you want to put products onto the market simply because you say there's no law and therefore let's just put them onto the market. You are a government agency, you should not be doing things like that. So that's, I think, the message.
Maybe just in wrapping, I wanted to say that our clinical trials unit is it's one of the highly performing units. So if you have got data, I will give you the contacts for our clinical trials unit where you can take that information, because I didn't want to speak about orthodox when I was, so if you can submit that, they will definitely look into it. I will share the details. And we've got clear timelines in all our units. Thank you. Yeah, as a government entity, We are relying on treasury. There are limited funds. So as cost recovery measures, that's how our fees are calculated.
Thank you very much for the responses. I think we got to a point where Dr. Ngobo, if you are listening and all goes well as the claims were put before, now you know what to do. And internally as well within the MRC, with some of the products that we're currently working on, at least now it's clear what can be done in the meantime before the regulations are finalized.
Thank you, Chairperson. I think I can see my colleagues from SAPRA are itching for me to say something. So I'd also like to appreciate and thank Prof. Matsavisa for bailing me out on that explanation to explain the difference between traditional medicine and traditional medicines. So traditional medicine, my directorate within the National Department of Health is called traditional medicine. So which means it's a directorate which is responsible for the system of traditional medicine. Within that system, we also have products. I indicated earlier in the morning that there are 3 pillars: the products, the practice, and the practitioners. So as the National Department, we are responsible for policy development. We do have a draft policy that we're supposed to finalize on traditional medicine as a system. But when it comes to issues of researches on traditional medicines or on products, the policy provides that the department should establish an institute on African traditional medicine, of which that institute is established with the aim of trying to facilitate issues of researches, because as the department, it is also our mandate to be involved in issues of researches, but we don't have a capacity to can do that. So it is proper that through policy development, we create an institute which will facilitate issues of researches on traditional medicine. There are so many researches that are currently going on, but we can't see the end results. There are no products that are developed or that are going into the market emanating from researches. Some of the problem is the one that people are raising here, that they are unable to register because the regulator is not yet registering. So the institute will be able to facilitate things like that, so that researches on traditional medicine can finally bring about products which are medicines which should be available in the market. And also that that institute will also serve to fund and prioritize researches. For example, Prof. Matsavisa has been presenting issue of a pillar which is being researched for COVID-19. So when COVID-19 finds us unprepared for anything. We couldn't have any reference where we can refer Professor Matsavisa to say, go and contact this person or this institute to fund your project on COVID-19 as it is a priority. So we need to have that institution to serve as an institution that can actually guide on prioritization of researches from products that are derived from traditional medicine. So that is a policy mandate. We are busy with the policy. It's a draft policy. It is currently going internal processes for finalizations. We have already consulted widely on the policy, but now it is going internal processes for finalization. Thank you very much. I thought it was proper that I must also say that.
Thank you.
Thank you very much for the responses. Those were my questions. I hope that they answered some of your questions and for those who are online as well. But probably a couple of minutes to note a few hands if you guys have other questions. Okay, the four of you will go, and then after that we will close. Thank you.
For the safety of human, there's quite a lot of indigenous herbal products on the market. What does SAPRA do in that regard? They are on the market without approval of SAPRA.
Because a lot of stores and you go through the markets, there's just so much that is being given to people already.
Just as a cannabis industry representative, I want to make it very clear that, especially as an educator, that we fully support a regulated environment. What is absolutely imperative is that at all costs we protect the consumer. So I want to make that very clear from a cannabis perspective. However, what I also want to state is that overregulation of any industry completely kills the industry. We've seen overregulation happen in the Canadian industry, in the American industry, and what overregulation does is it means that the underground market continues to flourish. We have a massive illicit cannabis industry in this country. We have many, many instances of people not labeling things properly, especially in the edibles market. Those things are disturbing to us. But if we overregulate, we will end up in a situation where the informal economy, which is where a lot of traditional healers are operating in, continue to stay in that. We don't bring them into the formal economy. So I think there's a lot of fear around things like cannabis. For those of you who do or do not know, nobody in the history of mankind has ever died from cannabis. And I'm sure it's very similar for a lot of other plant medicine. So we support regulation, but if we overregulate, it is going to hurt our industry and slow our industry down. And then I just had a technical question. I heard recently that CBG and CBN, which are two other cannabinoids, have recently been moved into Schedule 6. Could you confirm if that is the case? And if so, could you highlight why that has happened? Thank you.
So I'm just going to read some things that I highlighted in some of the talks from the Prof and also with SAPRA. We talk about finding South African solutions for South Africans. And then we also talk about safeguarding the community. There's currently an opioid epidemic taking place in our country. Opioids are not safe, but they have passed regulatory frameworks. Currently now in America, they're facing a huge pandemic around this and are using cannabis as a supplementary replacement for the current pandemic. So I'm trying to understand, if we are so pro-African for African solutions, how is it then that we are allowing ourselves to be dictated by Western powers? They told me that now that the WHO gives guidelines, which are not mandatory to follow. I've never heard that before. If it's not mandatory, then why do we have to follow? And also, why does the African Union not interject? Because I feel, Wakanda forever, that we have already solutions here, and based on the research, empirical evidence that's been here, why is none of this been implemented if the WHO provides guidelines which are not mandatory? Thank you.
I'm usually ke buella dingaka most of the time. I want to give you an experience now of how it feels to be a healer and attend sessions like this. Mme Ntate wa Sapra, le tla qala neng hore melao e translate-iwe di languages tse batho ba di sebedisang South Africa? Ke kopa re bueng ka yona eo, even if it's not here. Empa e tshwantse e etsahale mona South Africa. I'm just giving you an experience of when I speak my language and other people in this room cannot hear. Because that's exactly what we do to healers all the time. We have regulations in English, we have sessions in English, we do everything in English, and we don't give a damn about how they feel. I'm telling the honest truth. I've been everywhere with healers. Research councils everywhere. And and we are saying we have solutions for Africans. That's not true. The second comment is this. I'm always warning the scientists. Always warning the scientists. If you keep your narrow-minded type of research, you are losing a lot of knowledge, of indigenous knowledge. Because when you've got a product, one product, you think you've got it all. And I'm sitting here looking at the homeobadisa. It's a product, it's a Basotho product. It's a homeobadisa. It was here on the screen. There's a gentleman who's saying he's researching it for wound healing. I want to tell him that there's more to that plant than what he's doing there. And if researchers don't come to the ground and be willing to be taught and be willing to tell the truth, they are losing a lot of information. And but the healers are dying. They're dying with all the information. Ask me, I've got the experience. I've got 5 healers that died last year. That were libraries of indigenous knowledge. And you can't get it if you are not willing to. I'm always telling learned people, we are learned to save our own people. We are not learned for our own selfish needs and to become this and that and so on. One other comment is this. I just want to find out from Prof. Prof, you say that there's a working group that is actually now working on the legislation for African traditional medicine. I just want to find out how many healers are in that working group. How many healers are in that working group? And if they are not there, when are you going to start engaging them before you engage communities? Because wa regulator batu, basically regulator, usaba consult. There's no way. That is why now we are having a problem, even in things like, other issues of, indigenous knowledge. Because you are regulating people who have regulations already, but you don't want to temper into the knowledge of their own regulations to be put into the systems of government. And because could it belittles me as an African child who do la mona ki bua sekgoana kwena kaofela ke sa kgone hore dintho tse ding tsa heso ke di bue ka Sesotho re utlwane re etseng African solutions together. If o sa utlwe, I'll translate, but we don't always have to be doing everything in English. The last thing, I didn't hear anything about, I have been telling Prof that, okay, let me make you an example. Artemisia afra. When it came into fashion, everybody wanted to drink Artemisia afra, and I kept telling all my friends, you can never in the world drink Artemisia afra on its own. My mother, my grandmother, my big great-grandfather did not drink Artemisia on its own. It was drunk with other products to make it work better and to protect your liver. So I'm just giving you an example. When are we talking about synergy? Because I don't know, I would like to hear something about it if possible, maybe. Maybe that was an expectation that is not being seen through. But there's a lot of synergy in African traditional medicine. And I want to find out from the learned people, Lorena, when are we going to start doing research, specific research on the synergy of African traditional medicine? And why, let me make you an example. There's a product that when you take that product, you die. if you take just that. But the African traditional, the indigenous knowledge people know that if I give you this, if somebody has given you poison, and I give you the poison, African traditional medicine poison, mixed with other products, we take out that poison from your system and you don't die. But if you take that product alone, you die. So I'm just curious.
Thank you. Thank you very much for the questions. I guess, Prof. Numalo, as you were at the conference that you hosted, these were some of the same concerns, especially coming from the traditional healers. And I assumed and hoped that that report, which I had thought will be the best document as a point of departure, in a way of in the next 2 years trying to fill those gaps so that when the next conference is held, then boxes can be ticked. But while that happens, there should be translation, because indeed it becomes very much pointless to be in a forum where you came because you wanted to hear, to have a better understanding, but you leave having heard because you could not hear the language. The same applies here as well, Tia, Prof. I'm just speaking in relation to that comment. I think when she's speaking, I'm putting myself in her shoes, and it just doesn't feel right. We can't dodge that one from where I'm sitting if we are honest with ourselves. Otherwise, it just looks like it's trying to take away things that they have without them knowing what is going on. One can interpret it as such, which is not really correct. So to kind of make sure that this relationship works, I think that needs to be considered as a point of departure from here going forward. Before you respond, I was told there were questions online. I can't read that. I wasn't aware that my eyes was really, they were running away from me. Kofi, please, can you ask your question?
Yes, okay. Thank you very much. Can you hear me, please?
Yes, we can.
Okay, all right. I actually have two brief questions. The first one to the first SAFRA presenter, Makuba. Now, please, in your presentation, you said when it comes to regulation of African traditional medicine, the guidelines are currently under development. My question is, so assuming today somebody presents to you a product for marketing authorization, how do you go about it? What guidelines do you use currently, since you are now developing guidelines for African traditional medicine regulation? My second question, very briefly again, goes to the presenter from Farmers, Dr. Person. I want to ask, assuming somebody has a product and wants you to carry out a clinical trial, how does the person go about it? And funding for such a trial, how do you go about it? Thank you very much.
Thank you, Kofi. I'm going to let the panelists respond to the questions, starting with the first until your questions.
Thank you, Program Director, and thank you for the questions. The first question I would like to respond to was the one about medicinal products that have flooded the South African market. What is the authority doing about it? Maybe briefly, just to remind us all that before November 2017, South Africa as a country, by default SAPRA, we did not have a registration framework for these types of products that we say are flooding the market. in particular, those products that we call complementary medicines, let alone African traditional medicines. That was before 2017. Only in 2017, like I mentioned in my earlier presentation, that regulations for registration of what we call complementary medicines were promulgated, such that that was an enabler for those kind of products to can come in for registration. So the regulations were in place and the guidelines were in place. What was outstanding was for applications to start coming through to the authority and have those products registered. Those that are not registered be dealt with accordingly. Regrettably, I think everybody may be aware the regulations were challenged in court, and a particular judgment came where the authority and the health department or the Minister of Health were required to revisit or to go and remedy what I would call deficiencies in those regulations. That process is ongoing. To directly answer your question in terms of what is the regulator doing about these products, currently, as the status quo prevails, if there are reports of harm caused by such products, our regulatory compliance division follows those up. If there are complaints received, also the regulator is in the process of issuing those cooperative, we call them applicants, people who are coming to the authority to say, here I am, I manufacture products, I apply for licenses. Licenses for manufacture of complementary medicinal products are being issued per application to the authority as we speak. There is also, we know the regulator has a pharmacovigilance system. If anybody reports through the, what do you call that, pharmacovigilance app, any side effects caused by having taken those kind of products, the authority acts on those. I think those are the interventions that the authority, amongst others, does about this thing, about these products. We'll agree, all of us here, that in the so many years, these products have been on the South African market, and South Africa as a country, be it the MCC or SAPRA, but I'm saying South Africa as a country was essentially really not doing much about those kind of products. So it's only now that SAPRA is beginning to try to put mechanisms in place to deal with those. Call these products up for registration, and when they are registered, then those which are not registered would be removed. But we're dealing with the challenges that we're experiencing now, be it court cases and all those things in terms of the regulations that we come across. I hope that helps answer your question. May I quickly just comment a little bit, and I know my fellow panelists will comment on the issue of language. The issue of language is not a SAPRA problem. I don't think it's a Professor Matsabisa or the University of the Free State problem. It's a South African problem. But given that South Africa as a country has 11 official languages, it is up to the authorities when any piece of legislation or information has been passed, it's up to the authorities to make it available in those many languages. For occasions like this, I speak here as a person, if anyone at any particular point feels disadvantaged by language, that person can just say, I didn't hear that, and may you please just translate that for me into a particular language. I mean, some of us can speak Afrikaans praat and Koluma a bit in Zulu and all that, you know. So, but for expediency, we default to English, but it's not saying other languages are forbidden. Thank you very much. Oh yeah, the last one from the online guest about what happens, what do we do if someone comes to the authority with a product which is an African traditional medicine, what do we do about it? At this stage, given all the limitations in legislation that are disempowering, for example, the authority, if an applicant comes with all the scientific data that satisfies registration application as per the law, as it exists now, that is, you'll be having your clinical trials, you'll be having all the information, that application will be processed as, I would say, usual, not normal. It will be processed accordingly. Thank you.
Sorry, the crew that is helping us with all of these mics to work were supposed to have been away from here by now. in a way it's an inconvenience to them. And they are not as passionate about traditional medicine as we are. So obviously there are questions. Inside here people will engage, and I think there is a screen online, I think, for Coffee to engage with farmers, so that whatever questions he has asked, then Dr. McPherson can respond to those. I just want to thank you so much for the opportunity to stand here to represent my organization. And I hope that by cutting all of you, I didn't step on your toes, that when we go outside, you're going to just ignore me. I still would like to engage. So I'm going to let Prof. Matsabisa to just give vote of thanks, and he will lead us as to what we do after that. Thank you very much.
Thank you so much. I think, colleagues, and thanks to Dr. I know him, Dr. Kofi. He's calling from Ghana, so at least we are heard from Ghana. Thank you so much for that. Colleagues, I think we have noted some of the things. They are not being swept under the carpet, and some of those things I think we can respond to. There's still tomorrow, but also I think please bear with us that nothing can be done and compacted in 1.5 days and get done in 1.5 days. So please bear with us on that. And I'm saying this, I think, Malefu, on your question about synergy. In fact, we do synergy work on Pela, but we just can't talk about everything here. But also, please also understand that we know that plants are polypharmacy. A single plant can have many pharmacological activities. So when a researcher is focusing on a particular thing, it does not mean that they are ignoring the other, because the focus at that moment is on that one. Colleagues, thank you so much, I think, for that. Some of the things that you talked about, Ndati, passionately about guidelines. Yes, WHO gives guidelines, but, it is up to the heads of states and government, to take up what you are saying. We can make recommendations, but it is up to, I think, the powers that be. So, but I would want to say thank you so much, colleagues, and thank you so much to our IT people. You did brilliant work. I hope next year I'm going to see your applications into traditional medicines. So I look forward for that. You have been part of, I think, this group. But when you leave here, please don't go and prescribe traditional medicines to anyone. Okay? Yeah. So this time we say strictly follow the guidelines. But what we want to do, I know it's a bit rushed. One, we have some little gifts for, I think, the speakers, the facilitators, and all the tailors that have been here. So what we think, we can do quickly, I don't know how quickly this could be, that all the facilitators, all the speakers, if they could come, we give, I think, those gifts. Those that have been online, we will keep those gifts. We will ensure that they get to you one way or the other. So today's facilitators, today's speakers, if you are still here, please can you come, forward? And I don't know how dark it is and whether there are people that are going to be leaving, this evening. Because we thought we could have a photo, a picture outside as we leave, the place, because it has to be locked. I know you wanted to stay until tomorrow, but unfortunately the place has to be locked. So if when we leave here, we can take 2 pictures outside. One picture is with the speakers and the facilitators, and the other picture is for all of us, together. And the other thing that I need to be a bit, I think, harsh and stringent on, and especially to our beautiful, ladies, we were supposed to have been at the dinner at 6 o'clock. and we are still here. And it's a good thing that we were interested in what we were doing. But my plea and my request is, can we all leave from here straight to the dinner? We're taking you to, is it New York? So we're taking you to New York without any need for visas and passports. So please don't worry about those. If you don't have a passport, it's okay. I've already spoken to the heads of states, in America, so they gave us all a waiver to go to New York. So if we can do that, I will really appreciate it. Mema Lifu, we know that we kept you here. You didn't cook, so we have your plate there as well, so you can come with us. Ndade Taylor, I know also that you are as good as me in cooking, because we always have these discussions when we leave the office late, who's going to be cooking. So today we want to relieve you, because I know it was your turn to cook. So you can join us for the dinner today. But I think for that, Joyce, Diegetseng, and everybody, the speakers, the facilitators, can we come and get those gifts so that we don't keep anybody longer, for the dinner? And then what we also want to do is those that are fortunate enough to have, vehicles, please let's share. Don't charge anybody that you give a lift. Let's share, because we are running away from, we have a combi that can take, 2 trips. So, but if we can try and leave all in one go, it will be a good idea. If not, those that remain, please remain here, and then the combi will come and pick you here. Thank you so much to everybody. Thank you.
Dr. Simelani, you can come forward, please. You too, Dr. Langa. And Dr. Mornay Weyers, you can come forward, please.